are waiting for the dignities to assemble.
A very good morning to the honorable dignitaries, esteemed delegates, and one and all present here today. We are delighted to welcome you back on the third day of KONGU PEDICON 2025. We look forward to another day of enriching academic sessions, meaningful discussions, and shared learning together. The first session for the day is a panel discussion on Immunization 360 from guidelines to ground realities. I am honored to welcome our moderator for the day, Dr. Nandini Kumaran Ma'am, consultant pediatrician from Coimbatore with over 40 years of dedicated practice. She is a past president of IAP Coimbatore and a recipient of multiple prestigious awards, including the Senior Pediatrician Award by IAP-TNSC and the IMA Academic Excellence Award. We are privileged to have her with us today. Welcome, ma'am.
Good morning, everybody. At the outset, I would like to thank the scientific committee for giving us this opportunity, and I would welcome my esteemed panelists, Dr. Jalil Ahmed, Dr. Amal Raj, and Dr. Dakshayani to the stage. To introduce my panelists as they are coming up, Dr. Jalil Ahmed is a consultant pediatrician and neonatologist at Royal Cas Super Specialty Hospital with 38 years of institutional practice, won several awards from IAP, Senior Pediatrician Award, Fellow IAP. Then on the day before yesterday, he also received the Lifetime Achievement Award from IAP. Dr. Amal Raj is a consultant pediatrician from Chennai, and he has a gold medal in nephrology, and he's the CIAP Executive Board Member of 2025, and he has held various posts in the IAP-TNSC. He's received the Active Pediatrician Award. He's been the Treasurer, Academic Affairs Administrator, and EB member for several years, and he's been a speaker in various national and international forums. Dr. Dakshayani is the Associate Professor of Pediatrics from Government Chengalpattu Medical College. I've seen her so active in all the IAP forums, and she's the Joint Academic Coordinator of IAP-TNSC, Treasurer, Editor of the Indian Academy of Pediatrics book, and Secretary and EB member and several things. And to mention, she's got the Young Faculty Award from at National Assembly on Pediatric Emergency Medicine, Yuva Star Award at South Yuva Pedicon 2025. As we all know, today's topic is Vaccination 360 from guidelines to ground reality. We all know that immunization is one of the most important public health intervention, which has brought down the under 5 morbidity and mortality. And we could say that this is a very important pillar of childhood survival. And almost India homes close to 25% of the child population of the world. So we pediatricians have a very important role to promote the health of the children by using the vaccines and preventing the vaccine preventable diseases. With this short introduction, as we know, the title says it is from guidelines to ground reality. So totally this is going to be with only case scenarios where we'll be discussing how the IAP guidelines have helped us to manage the children. So this is the case vignette number 1. 16-year-old Neil, an adolescent. He had received his second booster at the age of 5 years. He had not received the third booster, which is due at 10 years of age. He now presents with injury, which is multiple aberrations because of a fall from a bicycle, and his wounds are badly contaminated with mud. So in this situation, how are we going to manage his tetanus prophylaxis? Are we going to use Tdap or TD? Does he require tetanus immunoglobulin? I would ask Dr. Jalil to analyze this clinical scenario.
Good morning, all of you. I thank the organizers, our President Rajendran and scientific team for giving this opportunity for this important topics. Coming to the case scenario, what Madam has described is a very common scenario we come across in our daily practice. This is, you have to consider the age, at what time he received the booster doses, and what is the current recommendation. Hope you all know, having the National Purple Book with you and FAQ with you. So this baby received second booster at the age of 5 years. And he has not received the third booster at 10 years. So there was a gap more than 11 years. So this baby definitely requires a perfect wound management, and the primary doses are already completed, so there is no need for TIG in this baby. All you have to give the tetanus vaccine. You can see that 3 or more doses, 5 to 10 years since last dose. All other wounds, any kind of wound, in this case it's a contaminated wound, this baby requires tetanus vaccination. then there is no need for TIG. This is for the current recommendations.
Yeah, as is clearly been told, whenever you are confronted with situation, you have to first find out how many doses, documented doses, not by mouth say. Documented doses of tetanus vaccine have been given. So the primary thing is to first find out whether there are under 3 doses. That means they have not even totally received 3 tetanus containing vaccine, or somebody is uncertain. They don't know about their vaccination status. The main thing is to divide under 3 and above 3. So in this case scenario, when it is under 3, this child will be at risk because he might not have a good immunogenic tetanus immunoglobulin titer in him. So if the wounds are clean, then you just give the vaccine. Probably you can forgo the TIG or the tetanus immunoglobulin. But if the wounds are contaminated, they are not clean or not minor wounds, definitely you'll have to give tetanus immunoglobulin as well as tetanus vaccine. And as is highlighted, doctor had said that in this child, it was 11 years. So the wound was, though contaminated, you take care of the wound management, no immunoglobulin and only tetanus containing vaccine. It's better to give Tdap because you're going to give not only tetanus, acellular pertussis and diphtheria rather than TD. It's just only the cost that's the difference. So we have the case scenario 2. Can Tdap vaccine be used as the second booster in place of DTAP or DTWP vaccines? Because you have to understand what is this difference between the capital T. Here it is capital T, small a and small p. In contrast, here it is all of them are capital letters. T, D, P are all capital letters. So this will determine the antigenic content. When the antigenic content is very good, everything is capital. And when the antigenic content is a little lower, then it will be small letters. That is the difference. And I ask Dr. Amal Raj to analyze this case.
Good morning, friends. At the outset, I would like to thank the organizing team and the scientific committee team of KONGU PEDICON 2025 for giving this opportunity. Sure, ma'am, as you already highlighted, Tdap cannot be compared with DTAP or DTWP, which is the complete antigen content vaccine. So what is the difference here? We'll see the scenarios here. At one end, we have the tetraxam, which contains your DTAP with IPV. The other end, we have Boostrix, which contains your regular dose Tdap. What we have to basically understand is the uppercase or the capital letter containing vaccines, they have the complete antigen load. And when it comes to the smaller case or the small letter, what happens is the antigen load is reduced. We can just clearly see here in tetanus toxoid, the content is almost the same. But when it comes to diphtheria toxoid, it is only 1/6. And if you look at the pertussis content, the pertussis toxoid, it is only 1/4. The fimbriated heme agglutinin antigen also, it is almost 1/3 only. So what is very clear is we can't compare both. Definitely, and one more thing is, we should use only your uppercase or capital letter containing vaccines in children who are less than 7 years. There is no role for Tdap in children who are less than 7 years. So definitely it's not a recommended booster dose at 5th year of life.
Thank you, Dr. Amal Raj. He's made it very clear that Tdap is not a substitute for TDWP or TDAP under 7 years of age. If a child comes to you above 7 years having missed the booster, then you have no choice because we cannot use the full content above 7 years because of the reactogenicity. So a Tdap cannot be used as a second booster under 7 years of age. This is the message that we want to give, and he's really told you all the details. Next case scenario is somebody has missed the doses of TDP and they require a catch-up vaccine. So what is the recommended catch-up vaccine schedule for this diphtheria, tetanus and pertussis? Over to Dakshayani.
Thank you, ma'am, and thanks to KONGU PEDICON for the opportunity. And this question is actually a reinforcement of what Dr. Amal sir said, and the guidelines are discreet and clear. If the last dose has been given beyond the age of 4 years for whatever reason, be it the primary series or the first booster, the second childhood booster is not required. And if we'll have to give catch-up vaccination for a child who is below 7 years of age, DTWP or DTAP should be given at 0, 1 and 6 months, all capitals. If the catch-up vaccination has to be given after 7 years of age, then we'll have to give TDAP, TD and TD at 0, 1 and 6 months.
So somebody comes late to us, then we have, instead of normally we give 3 primary and 2 boosters. So all of them would have received almost 5 of these, each of these component vaccine. But somebody for catch-up, it is totally only 3 doses and the schedule is 0, 1 and 6 as has been highlighted by Dr. Dakshayani. Next we will go to case scenarios where a person is exposed or comes in contact with an active lesion or in a spreading stage of the disease, in which case the exposed person is at a risk of developing the disease and they have not been immunized. So here is a case scenario where a mother delivers a 36 weeks preterm and within the next 24 hours she develops a eruptive varicella within 24 hours of delivery. So we know this neonate is at a high risk. So how will we manage this neonate, Dr. Jalil?
Yes, madam. This is one of the most devastating scenario we come across in the neonatal period, especially during the first 72 hours. This particular scenario, we need to concentrate on the onset or timing of the rashes and the development of symptoms. So here the baby developed rashes before 24 hours.
Yeah. No, child is exposed to the mother within 24 hours
Yeah, I'll
of
come to
delivery.
it. So this is a high-risk scenario because already the incubation period started in the antenatal period. You need to know the timing. Before 5 days of the delivery, after 2 days of the delivery of the neonate. So this baby is under high risk. So this baby definitely requires varicella zoster immunoglobulin as soon as the exposure. And if at all the varicella zoster immunoglobulin is not available, you can go for a regular IVIG in the dose of 400 milligram per kg as a single dose. If both are not available, then you go for oral acyclovir beginning 7 days after the exposure for a minimum of 7 to 10 days at the dose of 20 milligram per kg per dose 6 hourly. If the baby is immunocompromised, then the immunoglobulin and the IVIG administration is recommended as early as possible. So in this scenario, I will suggest the immunoglobulin, IVIG, varicella zoster immunoglobulin, as early as the possible to prevent the neonatal varicella, which is a very devastating disease. If the baby is symptomatic, we need to go aggressive treatment.
So this is a post-exposure prophylaxis that we are planning for a neonate with a mother with eruptive varicella within 24 hours of delivery. So this is a high-risk situation as has been highlighted. So you will give the best VZIG, varicella zoster immunoglobulin, but subsequently you will follow up the child for the incubation period and a little beyond, almost they say up to 4 weeks, to see whether this child develops varicella. And if this neonate beyond what measures we have taken, maybe it was a little late or whatever it is, if the baby develops a varicella, then you have to initiate IV acyclovir for a period of 10 days. Next.
One more thing regarding the breastfeeding, you have to isolate the mother till the lesions are crusted. That is more important.
Yeah.
For this particular scenario, this baby is a high-risk baby.
So you will isolate, probably used express breast milk until the active lesions have crusted, that is the infective period is over. So this is another case scenario of another post-exposure prophylaxis of a 5-year-old male child who has been diagnosed as hepatitis A. He has a 15-month-old brother who has not been immunized against hepatitis A. How will you proceed in handling this situation, Dr. Amal?
This is a very common scenario which we face in our day-to-day practice. The practicing pediatrician is puzzled what to do, whether he wants to give a vaccine to prevent or whether he wants to give an IM immunoglobulin. So what is the preferred? We'll see the science behind it. If you look very closely, vaccines are preferred over your intramuscular immunoglobulin. So, as we all know, hepatitis A vaccine, we have two types of vaccine. One is your live vaccine and other one is your inactivated vaccine. So it's always better we go for a method which involves the active immunity process, because you're going to give a longer duration of protection, and it's also an ease of administration, and it is also very easily available. So in an ideal scenario, we'll prefer a vaccine over your intramuscular immunoglobulin. And keep in your mind, friends, with regard to live vaccine, it is only a single dose as per the ACVIP guidelines. And if you are giving an inactivated vaccine, you have to complete the vaccination schedule by giving the second dose at 6 months of age, 6 months later. But the guidelines clearly says this is for contacts between 1 to 40 years. So if a child is less than 1 year, or if an individual is more than 40 years of age, we'll opt for the intramuscular immunoglobulin in a dose of 0.1 ml per kg, which offers protection for a period of 1 month.
Thank you for that. Thank you, Amal. I think the vaccine, because of a longer incubation period in hepatitis A, and when it is less than 2 weeks of exposure, a vaccine is preferred to intramuscular immunoglobulin. Here it is intramuscular immunoglobulin, the human normal immunoglobulin, which is 16.5%, which is available as a 2.5 ml vial. Next case scenario of a post-exposure is a baby who's been born to a hepatitis B positive mother. What will be the dose and schedule of hepatitis B vaccine for this baby, Dr. Dakshayani?
Ma'am, this is a relatively common scenario that we encounter. So at this point, we'll have to give hepatitis B vaccine. The birth dose of hepatitis B vaccine has to be given, and hepatitis B immunoglobulin 0.5 ml has to be given within 12 hours of birth using 2 separate syringes at 2 different sites, both thighs preferably. So hepatitis B immunoglobulin may be given up to 7 days of birth, but efficacy after 48 hours we are not sure, but it's been recommended that it can be given up to 7 days after birth. And after giving the birth dose of hepatitis B vaccine, we'll have to give 2 more doses of hepatitis B at 1 and 6 months of age. So hepatitis B immunoglobulin, if it's not available, as we encounter in many situations, this vaccine can be given at 0, 1 and 2 months with an additional dose between 6 to 12 months. All such infants who received 0, 1, 12 months and 6 to 12 months dose, they have to be tested for hepatitis B surface antigen and anti-HBsAg antibodies at 9 to 15 months of age to identify if they are carriers or non-responders, if these children are protected and they've been covered adequately against hepatitis B. So this testing has to be done at least 12 weeks, that is 3 months after the last dose. So if the last dose is given at 6 months, you'll have to do this testing at 9 months, and if the last dose is given at 12 months, you'll have to do this testing at 15 months.
Very well analyzed, Dr. Dakshayani. We have to remember, we have used hepatitis B immunoglobulin. So if you do the test within a month of the completing the vaccine, sometimes these immunoglobulins can persist. It is the passively used immunoglobulin and not the antibodies that are produced by the baby. That is the reason Dr. Dakshayani had said you must have a 3 months gap from the dose. And moreover, whenever we give a hepatitis B vaccine, this has the hepatitis B surface antigen, and there can be a transient hepatitis B surface antigenemia, which can last for about 4 weeks, 2 to 4 weeks. So to avoid false positive results, it is better to do these both hepatitis B surface antigen as well as the hepatitis B surface antibody to know the success of your vaccination. Suppose at 9 months you're doing the test and this baby is HBsAg negative and anti-HBsAg positive, then that proves that you have protected the this young infant. So we have seen 3 case scenarios of post-exposure prophylaxis. Now let us go into another situation of rabies. As you know, rabies in the Indian scenario, this is from Times of India just 4 days back. It's been a very high number of rabies deaths, almost close to 305 rabies deaths which have been in thing. This is actually underestimated because many of the deaths are not reported, and it is said there are about 37 lakhs of that is dog bites in India. That means close to 10,000 bites per day we are having. And if you see, the UP has the highest number of stray dog population, and the number of dog bites are highest in Maharashtra, next only to Tamil Nadu. So it becomes mandatory that we all manage rabies effectively to bring down the high mortality due to rabies. Because you know, this is one disease which is really preventable. But death can happen because the almost 99.9% is the death, the high fatality. So to understand the management, let us quickly go through the wound. The wound has been categorized into 1, 2, and 3. Just touching or feeding the baby or the dog, animal, or just licking on an intact skin is category 1. Whereas when you have a scratch, which is nibbling of the undercovered skin, and there is an aberration, but there is no bleeding, this will be category 2. And single or multiple transepidermal bites or scratches, licks on broken skin. And suppose the dog licks the lips or the mouth, then that is also taken under category 3. So this category is important for further management. That's why I'm just quickly revising. So any wound where even if you see a little blood ooze, that will be taken as category 3 wound, category 3. And most of the exposures that come to us are category 3. So why is it important? Because category 1, you just counsel the patient and wash the area of the lick. Category 2, you will take a good wound care, wound washing, and then you will just give the anti-rabies vaccine alone. Whereas category 3, we will do the wound management, we will vaccinate, but at the same time, because of a high-risk situation, we will use rabies immunoglobulin or rabies monoclonal antibody. And we have to now know what is this pre-exposure prophylaxis for rabies. Now, as you know, people are all pet lovers and they have dogs or cats at home. In such a situation or even otherwise, you can ask the parents to give off the vaccine like any other routine vaccine. This is called as pre-exposure prophylaxis. This consists of 3 doses of intramuscular vaccine on day 0, 7 and between 21 to 28. You can remember as 0, 7, 28. When you give this child will have preformed antibodies. So even if the child is exposed, and always after any vaccination, antibodies are in a very robust amount for about 90 days, that is 3 months post-vaccine. Within 3 months, you need not do anything for any exposure. Any exposure after 3 months of age, In that case, because they already have preformed antibodies, even if there is a dog bite, the advantage is when you have given pre-exposure prophylaxis, you need not give any rabies immunoglobulin or monoclonal antibody. You just have to give a re-exposure vaccine, just 2 doses on day 0 and day 3. So that is the advantage of pre-exposure prophylaxis. You do not have 10 situations. So we should all promote pre-exposure prophylaxis to the children coming to us, especially if they have dogs at home. The post-exposure prophylaxis is standard intramuscular regimen, which is 5 doses, day 0, 3, 7, 14 and 28. See, as private practitioners, we all use the intramuscular regimen, but we know that in the government hospital, they give the intradermal, which is 0.1. We are mostly, because we all use only intramuscular regimen. And on the day 1, if it is a category 3 bite, the first day you'll be giving the immunoglobulin along with this by infiltrating the wounds. And all the injections have to be given in the anterolateral thigh based on the age under 5 or in the deltoid region. Any injection that is given in the gluteal region as intramuscular is considered invalid. So, and this dose has to be repeated. Do remember, it should never be given in the gluteal region. So within any pre or post exposure prophylaxis, within 90 days, do not give any vaccine or anything like any immunoglobulin. You just do wound care. After 90 days, after 3 months, always you'll have to do what we have done previously, that is any re-exposure day 0 and 3. So with this basic understanding, let us go into further case scenarios. This is a child who was bitten by a rabid dog. And then a child with a rabid dog bite died in North India last month. This child had this is the wound, and this will be analyzed by Dr. Jalil. Both rabies immunoglobulin, anti-rabies vaccine was all given. So he was managed because this is category 3 bite. In spite of that, he died. What should have been the probable cause for such a bad outcome, Dr. Jalil?
This is another important thing. In spite of giving, as Madam told, the RIG and ARV, this baby died. So I just wanted you to know that the calculated dose of immunoglobulin and the vaccines, category 3. So here, the infiltration of there are multiple aberrations are there. After cleaning, perfect cleaning, we have to infiltrate the calculated dose, not missing even a single wound. All the wounds has to be infiltrated. So, therefore, even a small number of wounds were left uninfiltrated. This will give way for the viability or the progression of the disease. So, in this case, because of the avoiding or missing the other wound, this baby succumbed to rabies. So, here we have to any amount, even the volume calculated the immunoglobulin in, you can even dilute 2 to 3 times. Even 5 times you can dilute and then you infiltrate. I want all of you to go through the video. It has been described by the Anurag sir. Infiltrate, the technique of infiltration is more important. Calculation of the dose is more important. And don't miss even a single wound. That is the reason why in this scenario we lost the child. So the lesson is wash, completely calculate, completely infiltrate. Don't miss even a single aberration in category 3 bites.
Yes, washing is for more than 10 minutes in running water with soap, and you have to give the infiltration of all the wounds. And there is no dose, you should not give partly infiltrate and give part of it as intramuscular. There is no intramuscular immunoglobulin or monoclonal antibody dose. Entire thing has to be infiltrated. So that's understood. So vaccines do fail because we have to understand that the vaccine when given produces antibodies around 7th day, and which is the maximum by about 14 days. So there is a window period before this. So we know rabies is one disease with a very variable incubation period. It can be as short as 5 days to as long as 2 months, 3 months, or even up to 6 months and 1 year. So whenever the incubation period is short, as early as 5 days, you have the vaccine alone cannot be sufficient. So you have to have ready-made antibodies for immediate protection, and rabies vaccine alone will not give protection in such cases. Next case scenario, this is also rabies. This is a 13-year-old child who has been scratched by a stray dog. He was bitten by the same dog 8 months later, and he's completed his full course of a post-exposure prophylaxis. This child comes to your OPD and is bound to leave to the country the next day. What is the post-exposure prophylaxis of rabies in this child, Dr. Amalraj?
Yes, madam. As you have explained very clearly, while treating any child with a dog bite, first of all, we have to categorize. Categorization is very, very important. And second most important thing is to know the vaccination status of the child. So if we categorize this child falls under category 2 dog bite as per the WHO guidelines. If you look at the vaccination status of the child, this child has already received a complete course of rabies vaccine 8 months back. So this child needs just a follow-up vaccination because this child has already been given the full dose. So when it comes to management, the most important part is the wound management actually. So wound washing, as madam clearly elaborated, under running tap water for a period of 10 minutes. So ideally this child needs to be vaccinated with 2 doses of your rabies vaccine. If you're going to choose the intramuscular route, it is going to be both, whether it's going to be intradermal or intramuscular, it is going to be 0 and 3. But this is a very rare scenario where the child is going to travel the very next day. So he needs to get a super speed vaccine. So what is the choice left for us? We have only one choice. You will go for a single site intradermal vaccination. We give it in 4 different sites. So this is the only option left to us, madam.
And this is a clear situation where rabies immunoglobulin is not indicated, already has received a course, but 8 months have elapsed, so you'll have to give a re-exposure. Thanks, Dr. Amalraj, for analyzing this. This is a 6-year-old child with a category 3 dog bite. This child was given a single dose of ARV in the right gluteal region on day 1. They come to you on day 8. What is to be done next, Dr. Dakshayani?
Yes, ma'am. As you had emphasized in the introductory slides for rabies, this first dose was given in the gluteal region. Because it was given in the gluteal region, this is an invalid dose and needs to be repeated. So you will have to start post-exposure prophylaxis afresh on day 0, 3, 7, 14 and 28, plus rabies immunoglobulin or monoclonal antibody as the case may be, which has to be infiltrated into and around the wound. And as Jalil sir emphasized, if the wounds are multiple and if the wound is very huge and if the volume calculated for RIG or MAB is very little, you will have to dilute it with normal saline 2 to 3 times or even more. And you will have to infiltrate into and around the wound. No wound has to be left uninfiltrated.
Thank you. So we end the discussion on rabies now. We have only about 6 minutes, so we'll make it faster. We have now case scenarios which are under special situations. This is an 18-month-old child who had received packed RBC transfusion for a very severe anemia. And then this child is due a second dose of MMR. What are your recommendations, Dr. Jalil?
Yes, madam. This is also a common scenario we come across in the neonatal unit. So all you have to know that all the live vaccine is contraindicated to particular period of time. In this scenario, you have to wait at least for 6 months for the RBC infusion. You must also know the other condition where we have to postpone our vaccination is important things for Kawasaki 11 months, ITP 8 to 10 months, IVIG replacement, it is in the dosage of 400 milligram per kg. So in this scenario, I will definitely wait for 6 months for going for all the live vaccine because of the parental transfer or the immunogenic reaction that can occur, because that is the reason why we are postponing the live vaccines. Yeah. Thanks.
So we know that the packed RBCs or any blood-related immunoglobulins, they contain antibodies, so they'll interfere with the immunogenic response of live vaccines, be it varicella or MMR, etc. but not with the killed or the inactivated vaccines. So when we are using live vaccines, you have this timetable. Now we all have the purple book. You should always have it in your clinic on your table. Take these references and postpone the vaccines. So this is a 26-year-old mother. She had a severe SLE and she was given rituximab until 28 weeks of gestation. This baby delivers a normal baby this mother delivers a normal baby at term. What are the special recommendations for immunization of this child? We have to understand that rituximab is a biological response modifying drug. It's a biological and it is a monoclonal antibody in fact, and it is supposed to inactivate the CD20 and therefore the B cells. So the B cells are the cells that are necessary for the immunogenic response of vaccines. So this is a special situation. And so how is the immunization for this child going to be recommended, Dr. Amal Raj?
Yes, madam. As you already elaborated, rituximab is a chimeric monoclonal antibody which targets the CD20 antigen on your B cells. It just knocks off your B cells, leading on to lymphopenia. As we all know, your B cell immunity is needed for your to give protection against your extracellular organism. So in this situation, a mother who has been exposed to rituximab during the antenatal period, we should never administer a live vaccine during the first year. This includes your BCG, or your OPV, rotaviral vaccine, MMR and varicella vaccine. So we are supposed to administer these vaccines only after the first year of life. However, the inactivated vaccines could be followed. The immune response, however, is suboptimal. However, we have to give this vaccine. So depending on the monoclonal antibody used and the gestation period during which it was administered. But however, rituximab may be administered to a mother during breastfeeding because the secretion level of this particular molecule in the breast milk is low. So there is no contraindication for breast milk feeding.
Well explained, Dr. Amal. So this is a particular case scenario where we have a 5-year-old boy. All of them are weighing only 20 kilos. They are being treated for nephrotic syndrome in the first of these 3 situations, that is 1, 2, and 3, except the last one is an asthmatic child, with varying doses of prednisolone and for varying periods of time. So all of these, because he's 5 years old, they require the second booster of DPT, IPV, and MMR. Are we to give all the vaccines? Or because this child is on steroids, are we not to give any vaccines? Or are we to give some and postpone others? This will be beautifully analyzed by Dr. Dakshayani. Over to Dakshayani.
There are certain rules of vaccination in children receiving steroids. The rule of 2. If a child receives less than 2 mg per kg of steroids, the child is not immunocompromised and the child can receive all the vaccines. If the child receives more than 2 mg per kg of steroid per day for less than 2 weeks, the child is immunocompromised only while on therapy. And immediately after stopping steroids, the child can receive all the vaccines. If the child receives more than 2 mg per kg per day for more than 2 weeks, the child is immunocompromised not only during therapy and for also at least 4 weeks thereafter, the child is deemed to be immunosuppressed. So for these children receiving steroids, no live vaccine should be given until 1 month after stopping steroids, because for 4 weeks these children are deemed to be immunosuppressed. Inactivated vaccines are safe, but they may be less efficacious but can be given. Patients on alternate day steroids as a nephrotic syndrome, inhaled steroids and topical steroids, they are not immunosuppressed and can receive all vaccines. So coming to the scenarios that were put across, this first child, a 5-year-old, weighing 20 kg, first episode, child is on prednisolone 40 mg. So the child has received more than 2 mg per kg per day for 3 weeks. That is more than 2 weeks. So this child is immunosuppressed, may receive DPT and IPV, but not MMR. The next case scenario, the 5-year-old child is 20 kgs, the first episode of nephrotic syndrome. So we know we give it 6 weeks daily and 6 weeks on alternate day steroids. So this child is on prednisolone 30 mg on alternate days for 3 weeks, 1.5 mg per kg every other day for 3 weeks. So the child has received full course steroids, and this is the 3rd week. So the child is still immunocompromised because it is still in the 4-week period. So this child is immunosuppressed, may receive DPT IPV but not MMR. The next case scenario, this child is in the 5th week of alternate day steroid. So 4 weeks time has lapsed. So this child is not immunosuppressed as of now, so can receive DPT, IPV and MMR. This child, the 4th one, is an asthmatic on inhaled steroids. So inhaled and topical steroids do not immunosuppress the child. So this child can receive all the 3.
Very well analyzed, Dr. Dakshayani. So now we just come to a very quick rapid fire. Can just permission of the organizers for a minute or two to wind up. Vaccination post-recovery from an illness. Typhoid fever. Will you give vaccine after the disease? Dr. Jalil?
This is post-recovery from illness. I would definitely suggest the vaccination. Yes.
Why? Because this child,
Yeah, the child is recovering and this antibody protection may not be adequate, so we need to vaccinate the child.
next, post-recovery from varicella. Will you give vaccine or not, Dr. Amal?
Definitely, it's not a big no, madam, because a natural infection typically provides lifelong immunity post reinfection, madam.
Recovering from measles. Will you give vaccine, Dr.
No, ma'am.
Dakshayani?
One attack of measles confers lifelong immunity.
Hepatitis A. Will you give vaccine?
This is again a viral exposure. There is definite big no for the vaccine.
Pertussis,
Yeah,
Dr. Amal?
A big yes, madam, because post pertussis infection, we need to give the strengthen the immune system, because it is essential to immunize those recovering for pertussis, because a natural infection does not offer complete protection.
So we've seen about 5 or 6 diseases where you have to, how will you manage by giving the vaccine? It is yes only for typhoid and pertussis, because the bacterial diseases, after disease, the antibody titers that are produced slowly wane off over a few weeks to months. So it's very important that we give the vaccine for typhoid and pertussis, whereas all the viral diseases, be it measles, varicella, and hepatitis A, there is a big no, because they give lifelong immunity. So when it is pertussis, Dr. Amal, how will you go about with the vaccine?
Yes, ma'am. If a child is going to be less than 7 years of age, we'll go with the DTAP or a DTWP vaccine. And if the child is more than 7 years of age, we'll prefer a Tdap, as we have already discussed.
And the last case is the 6 weeks old infant who's brought for vaccination. There's a history of 2 sibling deaths. The cause is not known at 4 months and 5 months of age, with the feature something to say sepsis. So what are the implications of such a case scenario, of such a situation in vaccination of this child who's been brought to you at 45 days? Dr. Dakshayani?
This young infant, 2 siblings, died at 4 months and 5 months. We usually think of sepsis. But in this scenario, we should have a strong suspicion of congenital immunodeficiency or inborn error of immunity. This child should not receive live vaccines until immunocompetence is established in this baby.
Yeah. So we have to do the test for immunocompetence, especially SCID, and therefore after that only you can use the live vaccines. The inactivated or kill vaccines can be given. Therefore, rotavirus and polio cannot be given. If you are using oral polio, cannot be given until you establish that this child is immunocompetent. So we have done with the case scenario. So the take-home messages are with DTP, 3 primary doses and 2 boosters. The second booster has to be the uppercase DTP and not Tdap. And Tdap can be used only after 7 years of age for catch-up vaccines, and also at 10 years of age. And everybody should receive once again a Tdap or a TD as a decennial vaccine, that is every 10 years. For post-exposure prophylaxis, it depends upon the age of exposure, immunization status of the person, whether the person is competent or compromised, and what is the risk of when the person develops the disease. So we have situations where we have specific immunoglobulins and vaccine, and non-specific immunoglobulins, as we saw in hepatitis A. Watch out for the disease in the expected incubation period and a little slightly beyond also. Success is disease protection in the individual, both short term by giving the immunoglobulin and long term by giving the vaccine. Regarding rabies, always now try to encourage a pre-exposure prophylaxis when there is a high-risk situation of rearing dogs or cats at home. Wound washing with soap and water is very, very, very important for the first 10 minutes in running tap water. Use rabies immunoglobulin or monoclonal antibodies for category 3. Infiltrate all the wounds and do not inject any of these immunoglobulin or monoclonal antibody intramuscularly and never in the gluteal. Completion of the vaccine course should be done as per schedule. In immunization in special situations in immunocompromised children are at a greater risk of the diseases as they are susceptible to infection, but at the same time, when you use vaccines, the immunogenicity and efficacy of the vaccine is lower, and there is a risk of, especially when live vaccines are used, they can even develop a mild form of a disease. There are situations like in HIV, immunosuppression due to cancer chemotherapy, solid organ transplants, steroids as was beautifully analyzed, biological response modifying drugs as was also beautifully analyzed in the case are such examples. So we have the very important role as pediatricians in immunizing the children coming to us, and Mission Indradhanush, which was started by the government in 2014, was a rainbow color. It was for 7 diseases: the polio, tuberculosis, diphtheria, pertussis, and tetanus, along with the measles and hepatitis B. So these were the 7 diseases. That's the rainbow colors for Mission Indradhanush. And now we are through the 5.0 of Indradhanush, where they are trying to add more vaccines to protect the children and to reduce the morbidity and mortality. And we pediatricians have a very, very important role. And our Bibles for this will be the Red Book from the American Academy of Pediatrics and the Purple Book of the Indian Academy of Pediatrics. And I thank my eminent panelists for analyzing the situations well, and to all the delegates for their patient listening. Thank you. Thank you.
Thank you, ma'am. There is one question from the audience, which I'll be reading out. A 6-year-old child who has received rituximab 3 months ago, what vaccines should be repeated and when?
Dr. Amal, you want to? This is for a child. We analyzed the situation where it was for a pregnant mother. So, Dr. Amal.
Can you repeat the question, ma'am?
This is a 6 months old. Please repeat.
A 6-year-old child who has received rituximab 3 months ago, what vaccine? 6 weeks old child who has received 6 months child who has received rituximab 3 months ago, what vaccines should be repeated and when?
So the same situation which we encountered. In any case, it is going to be 1 year period only, because rituximab is going to knock off your B cells, and your B cells are, once you give rituximab, because the B cells are being knocked out, the child is more prone for infections, as well as if you're going to give a live vaccine, you can actually induce a natural infection also. It's better to follow the same scenario for 1 year period.
Yeah, as said, there's a wiping out of the B cells. And then once you stop the rituximab, it takes about minimum 6 months for the bone marrow to recover and replace these B cells in the bone marrow. So it has to be a minimum of 6 months to a maximum of 1 year as was thing. You have to repeat all the vaccines. The schedule that was given before has to be repeated.
Thank you, ma'am.
Thank you, thank you.
We thank our moderator, Dr. Nandini ma'am, and our esteemed panelists for that eye-opening session on immunization. Kindly accept a token of gratitude from our side. I request Nandini ma'am to felicitate all our speakers with mementos. I request Dr. Jalil Ahmed sir to felicitate Nandini ma'am with a memento. Thank you all. With that, we proceed to the next session for the day. We are happy to welcome the chairperson for the next session, Dr. M. Dorekannan Sir, Senior Pediatrician from Ganapati, Coimbatore. He practices at Sri Guhapriya Clinic and has also served as the Joint Director of Health Services, Coimbatore District. He has been an active office bearer of both the IMA and IAP, and we are pleased to have him here with us today. Welcome, sir. I would also like to invite the first speaker for the day, Dr. R. Soumya Ma'am, Consultant Neonatologist at GKNM and former IAP President of Coimbatore, to speak on new CCHT screening guidelines.
Good morning, everybody. Moving on to a totally different topic. First of all, I would like to extend my thanks to the Scientific Committee of KONGU PEDICON for inviting me to speak on such an important topic that is mainly targeting pediatricians who are also freelancing neonatologists and doing well baby checks in small clinics and nursing homes as well as corporate hospitals around the state. We are going to be talking about screening for critical congenital heart disease. Why should we screen for congenital heart disease? As we all know, this is the most common birth defect, and studies show that it affects at least about 8 per 1,000 babies. We all know that most newborn babies may not show all the classical signs or symptoms of congenital heart disease like tachypnea, murmurs, and cyanosis. So, limited specificity of physical examination in the first 24 to 48 hours of life because of a transition between the intrauterine circulation to the extrauterine circulation. Many newborn babies develop symptoms only after 48 hours of discharge, and this is because of the duct shutting down. So when we have duct-dependent lesions, they can present to you after the baby is sent home. Now, early diagnosis of heart disease not only prevents end organ damage, but it also improves the survival of these babies with congenital heart disease and their quality of life. Now, our current approach to screening for congenital heart disease is fourfold. First, we have the prenatal ultrasound scan. Prenatal ultrasound scan detects approximately about 50% of congenital heart disease. As we all know, it is dependent on expertise of the person who's doing the scans and his experience. And for single ventricular lesions, it can be as low as 25% will be picked up by the prenatal ultrasound. Then we have the postnatal examination by the pediatrician. This should be accompanied by routine pulse oximetry. And finally, clinical examination as part of our routine child care to detect problems that may present later when the pulmonary vascular resistance falls down. So what is critical congenital heart disease? Critical congenital heart disease is defined as any heart defect requiring surgery or catheter-related intervention in the first year of life. So we are targeting lesions by our pulse oximetry that present with hypoxemia and which need immediate intervention in the first 1 year of life. Mainly, we are targeting these 7 lesions, namely hypoplastic left heart, pulmonary atresia, TOF, TAPVR, transposition, tricuspid atresia, and truncus arteriosus. Now, when we look at all cases of congenital heart disease, critical congenital heart disease accounts for about 25%, and that is a significant number. We also have our secondary screening targets. Now, why are these called secondary screening targets is because most of these anomalies may present with hypoxemia, and therefore detection of these lesions by pulse oximetry is a possibility, but it's not always possible. So when we look at the classification of lesions, we have the left-sided lesions, and the ones with a green arrow will always present with cyanosis, and they are duct dependent, and therefore these are easy to pick up on pulse oximetry. On the other hand, when you look at the lesions which have been marked with a red cross, like moderate aortic stenosis or a moderate coarctation of aorta, they may not always present with hypoxemia, and they are not always duct dependent. So they are more difficult to pick up with pulse oximetry. Similarly, for right-sided lesions, a severe pulmonary stenosis may not be easy to pick up on pulse oximetry, but when it is a critical pulmonary stenosis and which is duct dependent, always it can be picked up by pulse oximetry. And other lesions like transposition of great vessels can be picked up by pulse oximetry. Total anomalous pulmonary venous return, although it is not duct dependent, it always presents with hypoxemia and can be picked up. Other lesions like VSD, AV canal defects, and may not be picked up. Truncus arteriosus may be picked up. So what are the consequences of not screening? We know that at least 30% of babies with congenital heart disease, which is critical, appear healthy in the newborn period when we are seeing them for the first 2 or 3 days of life. We know that cyanosis may not be apparent if the saturation is more than 80%, difficult to pick up in anemic babies and dark-skinned babies. So many of these babies present to the hospital or to our OPD only when the PDA closes. So what are the consequences of the PDA closing in a congenital heart disease which is critical and then picking it up later? They can present with severe metabolic acidosis, they can present with seizures due to hypoxia, they can present with cardiogenic shock, cardiac arrest, and they can also present with end organ injury like acute kidney injury. So this delayed diagnosis leads to poor outcomes. Then we have to separate lesions like total anomalous pulmonary venous drainage and also truncus arteriosus. Although these lesions are not duct dependent, they can be picked up by pulse oximetry and they need to be picked up because again delayed diagnosis in a TVA PVC or a truncus results in extremely poor outcomes. So what is the target of our screening program? We are targeting healthy term newborn babies, and we are not applying this to babies who are in the NICU and out of hospital births. The screening has to be done 24 hours after birth to minimize the effects or to minimize errors produced by a transitional circulation. And how do we reduce false positive readings? One is to screen when the baby is alert 24 hours after birth. But if the mother is delivering today and wants to go home today, then we screen as late as possible. And for NICU babies, we screen after weaning off from oxygen. In NICU babies, we can either screen after weaning off from oxygen or straight away proceed to an echo if that is not possible. Studies have shown that when this screening program is conducted at altitudes more than 6,800 feet, there is a high incidence of false positives, and this should be borne in mind. So we apply the pulse oximeter probe to the right hand or to either foot. The right hand denotes the preductal saturation, and it can be either the right lower limb or the right foot or the left foot. The application of the pulse oximeter probe can be done simultaneously or sequentially, and you have to use a motion tolerant pulse oximeter. Invest in a good quality machine. We also should understand that when the baby is crying or when there is a movement, there is likely to be artifact. Ambient light can interfere with the pickup of the probe, and we should also be cautious about probe detachment. And conditions where there is poor perfusion, the pulse oximeter may not work correctly. So this is the algorithm that has been postulated by the American Academy of Pediatrics. So any child at birth, we make sure that it is off supplemental oxygen, and at 24 hours of life or as late as possible, if it is less than 24 hours, we screen them with pulse oximetry. We apply the probe to the right hand and to one foot. If the pulse oximetry reading is less than 90% in either the right hand or the foot, then straight away it is a fail and we go off to do an echo test. If the pulse oximeter is more than 95% in both the right hand and one foot, then it is straight away it is a pass and we don't need to do any further examinations. For babies whose reading is in between, for example, the pulse oximeter reading is between 90 to 94 and the difference in saturation is more than 3% between the upper limb and the lower limb, then we re-screen after 1 hour. And after screening for 1 hour, if we apply the same criteria, that is, if it is more than 95% in the right hand and in the right foot or the left foot, and if the difference in oxygen saturation between the upper limb reading and the lower reading is 3% or more, then it is considered as a pass. So the The previous algorithm was postulated by the American Academy of Pediatrics in 2011, and this new algorithm has been postulated in the year 2020. And the advantages of this new algorithm is that we don't repeat the test one more time. Previously, we used to repeat the test after 1 more hour, but this new algorithm eliminates a second rescreen and allows us to intervene earlier and get the echo done earlier. And the oxygen saturation requirement for passing the test, initially it was a bit ambiguous. They had written more than 95% in the hand or the foot. Now we know that it has to be more than 95% in both the right hand or either foot. It should be both upper limb and lower limb sats should be more than 95%. You cannot just say, okay, the right hand shows a sats of 95%, we are all right, we don't need to do anything else. And the difference in saturation between the upper limb and the lower limb should be at least 3% or more. So this change in the AAP algorithm, it reduces the time to echo test and also reduces the time to intervention for these babies. You may ask that there is a slight increase in the false positive rate, but there are other advantages to this pulse oximetry, because most of the babies who had a low pulse oximetry, who had low oxygen saturations, had non-cardiac disease, and therefore there were additional screening benefits to this pulse oximetry program. And they found that there was no change in sensitivity to the 2011 algorithm. So these were the non-cardiac causes of hypoxemia which were picked up by babies who presented with low oxygen sats. One was hypothermia, sepsis, RDS, persistent pulmonary hypertension, transient trachypnea of newborn, and hemoglobinopathy. So the Cochrane review of 2018, which was done on the 2011 algorithm, said that this screening program for critical congenital heart disease using pulse oximetry had an overall sensitivity of 76.3%. The specificity was almost 99%, and the false positive rate was 0.14%. What does this mean? It means that for 10,000 healthy term newborn babies, we'll have 6 babies who have congenital heart disease. But out of these 6 babies, we can detect 5 by pulse oximetry. And 14 out of the 10,000 had needed to have an echo unnecessarily, but we could decrease the rate of unnecessary echoes after screening after 24 hours, allowing for transitional circulation to take place. So the benefits of screening babies using pulse oximetry is, one is we send them home after knowing whether or not they have congenital heart disease, so they won't present to the OPD or to the ER once the duct closes or with congestive cardiac failure. So there is decreased mortality and morbidity, and it also detects a lot of non-cardiac cases like sepsis and respiratory issues, and this is a secondary benefit. We can ask, what is the harms of screening with pulse oximetry? One is obviously the parental anxiety, but they found that when the parents were reassured by getting an echo, the parental anxiety levels decreased. There are obviously problems associated with transfer to an advanced center once the baby is diagnosed, but this is a non-avoidable issue. And we should know that we commonly miss quite a number of stenotic defects which are not critical, like aortic stenosis or pulmonary stenosis, coarctation of aorta where the left ventricular tract outflow obstruction is not severe, large ASDs, VSDs, AV canal defects can all be missed by pulse oximetry, therefore it is not absolute. So when we look at the criteria for screening tests and see whether this applies to pulse oximetry, we know that congenital heart disease is the commonest birth defect, so there is sufficient evidence. And we know that therapy before the onset of symptoms can improve the outcome. We know that 30% die without a diagnosis. And this test has got an acceptable sensitivity and not too many false positives. And we diagnose a disease before the onset of symptomatology, because we know that when we do physical examination alone, we can miss 50% of congenital heart disease. Looking at the cardiac surgery outcomes, these were studies that were done in the US, and most of these studies were done in the early 2000s. And we find that the surgery outcomes, the interventional procedure outcomes for many of these lesions has dramatically improved. And in our own hospital, we find that mothers who have undergone TAPVR repair or tetralogy of fallow repair are coming back to deliver babies. So the treatment for cardiac lesions, critical cardiac lesions, has dramatically improved even in India, and therefore we should diagnose these babies before we send them home. What are the challenges in India? Although this is not the case in Tamil Nadu, home deliveries are still a challenge. We have limitations in equipment and infrastructure as well as in personnel. And we know that in India, a sensitivity of 60 to 76% means that still a large number of babies will be missed and sent home, and a small false positive rate of 0.14% can translate into a large number of unnecessary echoes. We have limitations in diagnostic tests because we need to send them to another center to get an echo done, and also limitations in treatment and transport once they have critical heart disease. And we also encounter many barriers, mainly because of economic factors, but also due to geographic and socio-cultural factors. So concluding, pulse oximetry is a very safe, non-invasive bedside screening tool for congenital heart disease that should be adopted by practicing neonatologists and pediatricians taking care of deliveries in small hospitals, clinics, and corporate setups. It promotes early detection of critical congenital heart disease before discharge, allowing for intervention to take place in the first 1 year of life. It reduces morbidity and mortality because they do not present when the duct closes, and therefore they present to you in a good state, and you can send them to the cardiac surgeon or to the interventional cardiologist in a good condition. We know that a combination of a good prenatal scan, routine surveillance, and pulse oximetry can detect as much as 98% of congenital heart disease, and only 2% may escape. And when we encounter false positive cases, those who present with a low pulse oximetry SATs, they can still present an additional benefit to screening because we may diagnose patients who have sepsis or who have respiratory issues in the newborn period. Thank you.
Thank you, madam. Thanks for an excellent talk. Pulse oximetry is the only instrument where we can find for a long time. Not only in the COVID time, all neonatal ward and labor ward should have a pulse oximeter, and all the persons to be trained, all persons of staff nurse or obstetrician. But mandatory is it has to be done after 24 hours. They have to do a pulse oximeter screening at the time of discharge also. We find more cases on the discharge also. And most of the neonatalists should know how to do a echo. That is what recommended by UK and Saudi Arabia studies, where whenever they suspect, immediately they should take an echo and they'll tell the cardiologist. So this is what recommended by UK. So thank you for the excellent speech, madam. Over to any questions. Come to the yes, thank. Come on. Sir, I'll give the
Yes. Yes, sir.
And the lower limb, now it's lower limb shows that lower saturations because supplied by the pulmonary artery. Yes. That is what one thing we should understand that for completion's sake. And if there is transposition of great arteries with interrupted aortic arch, it will be reverse differential cyanosis. Upper limb and lower limb differences will be seen. Yes. Then one more thing is the duct dependent pulmonary circulation, you see cyanosis and all those things. But hypoplastic left heart syndrome, they present with cold, clammy, and listless, and low cardiac output. These things we can diagnose clinically before we go for echocardiogram.
Yes.
Thank you.
Thank you.
Thank you, madam. Come
Thank
on
you,
up
sir.
with the chair.
Thank you, ma'am. I now invite the next speaker, Dr. R. Ramesh Kumar sir, who is going to be speaking on All That Wheezes Is Not Asthma, The Asthma Masquerades. Welcome, sir.
Dr. Ramesh Kumar, my old friend from Kerala. We worked together for the past 10 years on the respiratory diseases along with him. And excellent orator and always on the field, not in the clinics. You go to the field, you find out what is, you teach the people about what is asthma, how the respiratory diseases are coming. So over to you, Dr. Ramesh.
Respected Chair, Dr. Durey, my colleague, Dr. Soumya, esteemed senior friends and beloved colleagues. Good morning and vanakkam and greetings from Kochi. And I must congratulate the team, Coimbatore, Dr. Ismail, Jalil, Rajendran, Mullai, Shashikumar and team, as well as the TNSC team going into the 50th year next year. I must congratulate them. Somasundaram, the next year's president, Rajendran, as well as last year President Balashankar, Narmada, and the whole TNSC team, and all your stalwarts out here, youngsters, Amal, Dashayani, and I can see the whole bunch here. So happy to be back with you, and it's a great time for Coimbatore, the Pedicon coming up in 2027, the big mega show for the year, and we are all quite happy that Tamil Nadu has this great opportunity at hand, and Coimbatore is hosting us for the year ahead after Calcutta. So well, folks, my session for here today is something on asthma, or something like we say, all that wheezes is not asthma, or the asthma masquerades. So there's an old niche cliche, what do you say, all asthma does not wheeze, and all that wheezes is not asthma. And to reinforce the second part of this adage, all that wheezes is not asthma. We say about asthma confounders, asthma mimickers, pseudo-asthma. There are many situations, and I remember many a time when you come for the post-admission day, the juniors will start saying, sir, 5 febrile illness, for the admission list, 4 febrile illnesses, 3 wheezes, 2 seizures, and so many a time it turns out that most of these wheezes, or at least less than 30% only turn out to be an asthma, and most others are maybe episodic viral wheeze or transient wheezing of childhood, or maybe some other reason for the child starts wheezing. So we need to know, but then basically quick look at what Gina says about the qualifiers of asthma. A quick look, and I am very sure that all of you are very familiar with this, but recap, triggers, seasonal variations actually there, and most important is the atopy, whether it's a personal history of atopy in the form of a childhood atopic dermatitis or a eczema, or a family history of atopy, 1 parent, 2 parent, elder siblings, all these very much contribute to asthma, exacerbations, remissions, and nocturnal symptoms. It's very important, the night cough, especially after the early morning cough from 1 a.m. to 4 a.m., and then the polyphonic wheezes. The obstruction occurs in the various phases of respiration, and most important, good response to bronchodilators and steroids. So these are certain qualifiers for asthma, which many a time we always incorporate it whenever we diagnose asthma. And then diagnosis is basically clinical and difficult, especially in young children. Appearances can be deceptive. Just like you see the carrot greens out there, which is called the fronds. You see plenty of abundant fronds out there, but then the carrot stem is quite weak. But when you see a very frail carrot green, the carrot is quite big. So the appearance can be very deceptive. Everything that looks good need not be similar. So when to think of asthma mimics? Just have a quick look at it. Younger child, especially under 12 months of age, unlikely or most unlikely to be an asthma. It can be something like a chronic respiratory problems subsequent to a prematurity, or it can be a GERD, or it can be cystic fibrosis, or even PCD, anything. So it's less than 1 year, unlikely. Again, children with sudden onset of symptoms with no obvious trigger. Asthma cannot come on a fine morning even without a viral prodrome or nothing. It just always think about a foreign body or some similar situations. Again, isolated chronic cough in the absence of wheeze. We always say asthma variants or asthma, atypical asthma. Okay, done, well taken, but still wheeze is something which is mandatory for asthma. It's very rare. Asthma equivalents can be there, asthma variants can be there, but for a diagnosis of asthma, cough, because isolated is a protracted PBB, like persistent bacterial bronchitis, or similar situations can be there. Again, children with poor or no response to standard asthma management, usually they respond to beta-2 agonists quite well, and they respond to steroids or the other way. And unless and if they don't respond, look beyond that and revisit the case and review the case. And again, absence of nocturnal cough is something which can take you away from asthma. So, well, friends, these are a few indications that or red flags which makes you, or zebras which makes you some unusual or atypical diagnosis or atypical signs and symptoms which takes you to an alternate diagnosis. You need not be an asthma always. Does timing of cough help in diagnosis? I always remember then Dr. T.U. Sukumaran told me about this some 10 or 15 years back. We can put it into practice. I tell my boys also daily when you go for the rounds, cough soon after going to bed, peaceful thereafter, most likely to be an upper airway cough syndrome or postnasal drip. The child falls down and the postnasal drip is there. So maybe a cough, a child falls to bed at 9 o'clock, 9 to 11 it is postnasal drip or USCS, 11 to 1 or something like it can be a GERD, because by the time the supine position is acquired, there can be some aspiration or GERD, and a cough coming after 1 a.m. to 4 a.m. most likely to be an asthma cough, because that's the time when the endogenous, the steroids are at their bottom, they are at the trough. So that's the time when the body, the airways doesn't have any support from anywhere. So that's the time a child can, any chance of going into a bronchospasm, the child must get some nocturnal cough between 1 to 4 a.m. So this is a rough outline where you can delineate a nocturnal cough. Cough 2 to 3 hours into bed, quite before and thereafter, it's a GRD. Cough in early morning hours, 2 to 5 a.m., very likely to be an asthma. Cough during feeds, more likely to be a reflex, and no cough at night all is mostly a functional spasm, or we can say habit disorder. Again, lookout signs which should alert you to an alternate diagnosis out there is, one is feeding difficulty, choking, drooling. These are all aspiration syndromes must be thought about. A laryngeal cleft can be there, even a GERD can be there, echinacea can be there, esophageal fistula can be there. So feeding difficulty, choking and drooling are not usually accompaniments of asthma. Asthma doesn't come like that. We are talking about asthma, we are not talking about this. So again, the daily moist cough. Daily moist cough can be even in a cystic fibrosis. It can be there in a primary ciliary dyskinesia, or it can be due to many other situations. So daily moist cough with a copious sputum, you have alternate diagnosis. Again, a failure to thrive or a clubbing or something is there, failure to thrive, PCD or cystic fibrosis, because asthma children are otherwise well nourished. They are mostly well nourished, and they are overweight or they are chubby, they look so good, they are good, can be taken for a show and everywhere, but they keep wheezing most of the time. And again, a digital clubbing, look for other alternate causes. Digital clubbing always have alternate thoughts, hemoptysis, alternate thoughts. Persistent hypoxia, cyanosis, murmurs, takes you to a cardiac diagnosis, and again, persistent voice change. This is important. Many a time we have got a laryngeal involvement is there, laryngeal verb can be there, or then voice disorders can be there. They tend to take you away from a diagnosis of asthma. So these are certain zebras, or the red flags, which thinks about an atypical signs and symptoms, which takes you to an alternate diagnosis. So ABC of wheezing, a quick look. These are something which always all of you should quickly recap, and every day during the rounds I used to tell my juniors to have recap the ABC daily. Aspiration syndromes, asthma, bronchiolitis, bronchiectasis, cystic fibrosis, cardiac failure, congenital malformations. Drugs can be there, beta blockers, NSAIDs, endobronchial tuberculosis can be there, extrinsic compression of the bronchus, less like an avascular rings, or a dilated left atrium compressing on the bronchus, or a foreign body can be there, gastroesophageal reflux and interstitial lung disease, infections, and then vocal cord dysfunction syndrome. So this is a quick overview, something which a mnemonic which people can recap quite frequently. And common mimic case, let's quickly go through certain scenario. Scenario 1, a predominant history of cough, wet sounding cough and absence of wheezing. No wheezing, but wet sounding cough. Cough which is more in early part of night when child gets into supine position in morning on waking up. Hardly any cough in early part of night, 1 to 4 a.m. Associated clinical features of allergic rhinitis. That's like you have the allergic shyness, you have the allergic salute, and it's the circs, sneezing, itching, rhinitis, congestion. Circ is there. Poor response to standard asthma medication. So as we have discussed earlier, this is very much of an upper airway cough syndrome. The postnasal drip produces that cough. When the child is put to the supine position, initially the cough will come and it will be clearing out, and in the early morning hours again the child is waking up, that is again going to disturb the oropharynx and nasopharynx, and again child gets cough. So this is a cough or something this. So the upper airway cough syndromes mainly due to the postnasal drips. Scenario 2, Symptoms from birth, early infancy, right from birth, brassy, metallic cough is there, stridor, with or without stridor, usually worsen with colds, and persistent monophonic wheeze. So I'm sure you all got into this. When you say monophonic wheeze, the wheeze is persistent or specifically in certain one phase of the respiration only. So monophonic wheeze, one is Malaysia syndromes, second is foreign body, and third again extrinsic compression of the bronchus due to a dilated left atrium or a pulmonary artery dilatation or something due to a cardiac cause. So these are all, asthma per se is polyphonic wheeze. You get one type of wheeze and one phase somewhere here, another type of wheeze. It is polyphonic and different musical sounds will be there. So monophonic wheeze with worsening with cold, again right from infancy, it is Malaysia syndromes. So laryngomalacia, tracheomalacia, and bronchomalacia, these are the three usually you can see the normal trachea out there. Tracheomalacia, you have the weak cartilage of the trachea. The cartilageous rings are quite weak and they are defective. That is why they collapse easily during expiration. So what is it? Typically, this is something important I want to highlight, where we have many times we start salbutamol for a child with Malaysia syndromes. Please, you are on the wrong foot. Don't give salbutamol or any beta-2 agonist for a child with a Malaysia syndromes. So you get what is called a paradoxical worsening or paradoxical bronchospasm after giving a salbutamol nebulization. What happens is actually when there is a Malaysia, then there is some amount of the basic airway tone is there. That stenting effect is by the basic airway tone. When you give a beta-2 agonist is a smooth muscle relaxant. It further relaxes that stenting effect or the bronchial smooth muscles. And whatever stenting effect that is also lost. And again, during the expiration, there will be some airway resistance will be more if there is a salbutamol after nebulization. So salbutamol or beta-2 agonist nebulization will always worsen a scenario with a Malaysia syndrome, bronchomalacia or tracheomalacia. Again, occasional use of ipratropium instead of salbutamol might help. But ipratropium, of course, it doesn't affect the smooth muscles tone, but again, it creates some secretions. So some amount of improvement will be there with the ipratropium, but never with salbutamol. And most children with tracheomalacia or bronchomalacia will just need observation and monitoring. Very severe cases may need stenting, iotropexy, etc. The important take is here: never give salbutamol if you are thinking about a bronchomalacia or tracheomalacia. Scenario 3, infants presenting with a recurrent wheeze, not triggered by viral infections, not having other risk factors, more prominent in the supine position, especially at night and after feeds. Children having a typical history of reflux like recurrent vomiting episodes and a poor response to asthma medications. As I told, the nocturnal cough coming after 9 to 11 is likely to be a upper airway cough syndrome. 11 to 2, after 1 or 2 hours after lying down, the GERD starts in. The gastroesophageal reflux. So nocturnal cough is a predominant symptom of asthma, and predominant nocturnal cough, no other qualifiers of asthma should alert to a diagnosis of GERD. GERD can present as chronic cough or as recurrent wheezing. There are multiple studies about GERD. You can see GERD is now currently, they are still confused after so many years whether it's an associated finding in asthma, whether it induces asthma, whether it's exacerbated is still not clear. But GERD should also be always be isolated. You need to give the PPI, proton pump inhibitors in quite the omeprazole and the sufficient dose for a period of 3 months will definitely take care. And with the proper positioning of the GERD, the foot and the upper and head and elevation and all those feet, thickening of feet will definitely help prevent the recurrent episodes of wheezing, not asthma. They are not asthma, they are wheezes. Again, scenario 4, 7-month-old child with the complaints of recurrent fever, moist cough and wheezing since 1 month age. Multiple hospitalization, antibiotics, nebulization, clubbing is there, weight is inadequate, and chest bilateral cross cycles. Infant in the first 7 months with a failure to grow, and in other aspects, cystic fibrosis, which we don't see much here, but persistent wet cough, recurrent chest infections, FTT, sinusitis, and malabsorption can be there. So that is about cystic fibrosis. Again, chronic wet cough with recurrent chest infections, early onset symptoms, early clubbing, chronic rhinosinusitis and otitis media. You got it now. Dextrocardia, situs inversus. So recurrent infections or recurrent wheezing in the early part of infancy, will take you through either cystic fibrosis or even a primary ciliary dyskinesia, or even something like a chronic respiratory diseases after bronchiolitis obliterans or bronchiolitis, something like. So primary ciliary dyskinesia, PCD, is always to be considered when there is a recurrent rhinosinusitis. So that is about the child with infant with a wheezing. Again, Scenario 6, an older child, daily persistent wet cough lasting for more than 4 weeks. Normal chest X-ray, normal physical examination, prompt response to prolonged antibiotic course, I must say co-moxiclav, and no wheeze. So this is something, an entity which is there very much for the last decade or around. I am not sure whether in my early postgraduate days we have not heard much about what is called as a protracted bacterial bronchitis. But currently, for the last decade or a little more than that, we talk about PBB everywhere, because PBB is something like, if you give appropriately diagnose it, you get it. You can see on the left side, persistent wet cough. Cough typically worsens when changing posture, and rattle is there, rattle sound. This is what is called about PBB. Non-musical voice generated by secretion. If you feel the chest, or if you touch the chest wall, you will see something like some sound will be there. So it is called a rattle sound. Non-musical voice generated by secretion, the larger airways. That can be felt on the chest, and clinical improvement after the antibiotics. So sometimes if they start coughing, they even gasp for breath. Whereas asthma, this nocturnal cough mostly, and there won't be any. This is the cough during the daytime. This is not much of nocturnal cough is there. So PBB is one condition. If you diagnose it properly, as I noted here, normal physical examination, you don't get anything. But then persistent wet cough lasting for more than 4 weeks, and normal X-ray, no wheeze. You think about PBB. So PBB, you treat with a co-moxiclav for around 3 weeks. You get absolute good response. The child will be perfectly okay afterwards. Scenario 7, abrupt onset of cough and wheeze, that is monophonic, unilateral or localized with collapse or hyperinflation of lung. Absence of response to beta-2 agonist, you got it. Abrupt onset of cough, abrupt onset. Some fine morning child starts cough and then collapse or hyperinflation. History of choking, highly suggestive, but absence does not exclude. You do not get a choking episode. Acute symptoms, absence of viral prodrome, nothing is there, and it is the foreign body of the airways. So refer to bronchoscopy at earliest, rigid bronchoscopy under GA, and it must be referred at the earliest for bronchoscopy. Scenario 8, adolescent with stridor or monophonic wheeze, suprasternal retractions, and no symptoms during sleep. I have faced a similar situation many a time, because I have got even my relative of mine who is, she had a mild asthma in childhood, and after 10 or 11 years, she is the only child, and is the only child of my cousin's daughter itself. So then she starts wheezing, suddenly falls sick, and every time she got wheezing, and her mother calls me up. One time when I was there in their house only, it happened that she had this similar episode, and she was mostly a vocal cord dysfunction. She was always occurs in children over 10 years, and they often have a prior diagnosis of mild asthma. They know how to mimic asthma. So they always catch hold of attention seeking, and for some other causes, some unpleasant situations, they always pretend to have wheezing. Sudden worsening of asthma, not respond to. I faced it personally, I know, and for these children, they need counseling. This is a vocal cord function. What happens during vocal cord dysfunction? No symptoms during sleep. Is actually there is, instead of there is a paradoxical adduction during inspiration rather than during the abduction. Paradoxical adduction. Can I take 2-3 minutes extra? Just 2 minutes. So diagnosis, bronchoscopy, and treatment is relaxation exercises and speech therapy. So that is then dry honking cough without any sleep disturbance or disappearance cough when child distracted and increases with attention. That is actually a functional cough disorders or habit cough and cough tics. So absence of cough during night when asleep and when the child is distracted, that is called a functional cough disorders. Scenario 10, can this be due to TB? Many times patient will ask, sir, is it TB or can it be due to TB? Isolated cough of wheeze is rarely a manifestation of TB, but there are situations where endobronchial TB and TB lymph nodes causing extrinsic airway compression can initially present with wheeze. Extrinsic compression of the hilar area or endobronchial TB can present with the tuberculosis. So take-home messages, if presentation below 6 months of age, consider congenital airway anomalies like Malaysia syndromes, vascular rings or something, and congenital heart diseases. It depends on the age. If persistent wet cough is there with unusual features like consanguinity, FTT, multifocal infection, consider cystic fibrosis, primary ciliary dyskinesia, or immunodeficiency. Again, if localizing signs are present, unequal air entry, unilateral emphysema, consider congenital anomalies and foreign body. If presentation with upper airway signs like recurrent and persistent rhinorrhea, sneezing, postnasal drip, consider allergic rhinitis or rhinosinusitis and upper airway cough syndromes. So basically it's good history, clinical examination, and high index of suspicion. So friends, all that wheezes is not asthma, and all asthma need not wheeze. So let's be very sure you are treating asthma when you go on for beta-2 agonists and similar drugs. Thanks again for team Pedicon, KONGU Pedicon for the opportunity to be here on this platform, and my best wishes for the great events coming ahead and the great, a president from Tamil Nadu coming up in the year ahead. Thank you very much. Thanks, Chair.
Thank you, Dr. Ramesh. It is time for your question. The floor is open.
So, as there are no questions currently on the floor, we request delegates to post any questions on the platform and the speakers to respond to any questions that the delegates may pose. Thank you, sir.
Thank you.
Thank you for the very enlightening session put forward by both our speakers as well as the chairperson. We request the panelists to kindly accept a token of gratitude from our side. We request our chairperson, Dr. Dorekanan sir, to felicitate the speakers with a memento. Thank you, sir. We request Dr. Ramesh Kumar sir to felicitate our chairperson with a token of gratitude. Thank you all. We will be proceeding to the next session.
Joining us next is Dr. Alok Bandari, a distinguished neonatologist heading the department in Kukraj Hospital, New Delhi, awarded fellowship of the IAP and National Neonatology Forum. He has held key leadership roles, including president of IAP Delhi and the National Neonatology Forum. A passionate academician and trainer, he continues to shape neonatal care both nationally and internationally.
Welcome, sir. I would also like to invite the first speaker for the session, Dr. Sri Devi ma'am, Professor of Pediatrics at the Institute of Child Health, MMC, speaking on reducing medication error in pediatric inpatient care.
Good morning, friends. It's my pleasant duty to introduce none other than Professor Sridevi Narayanan. She did her MD Pediatrics and PG Diploma in Epidemiology. She is a professor of pediatrics at Institute of Child Health, Madras Medical College. Has been into childhood diabetes, clinical research, 19 years of UG and PG teaching experience, co-PI in 2 ICMR projects on NRSN and RVIS, currently PI in an ICMR project on genetics of type 1 diabetes, has around 30 publications and index journals, editor in IJPP, Annals of Child Health Journals, received Bal Gopal Raju Active Pediatrician Award in 16 and Dr. Mehta's Pediatric Excellence Award in 2025. Welcome, Dr. Sridevi, please.
Thank you for your kind words, sir. Respected chairperson, my seniors, my friends and my students, at the outset I would like to thank the organizers for giving me an opportunity to speak in the conference. My topic today is a offbeat topic. It is not a conventional topic. It is about reducing medication errors in pediatric inpatient care. So I would first talk about certain real life situations. I would start with a disclaimer. Actually, these are all my personal experiences, first-hand experiences. I hope there are no medico-legal implications to it after I share my experiences. Then I will talk about what are the types of errors which can occur, what causes them, what do you exactly mean by that, and what is the burden, what all harms it can cause, and mainly the measures to be taken to avoid the medication errors. So the first patient whom I am going to talk about is a 3-month-old girl who presented to the hospital with respiratory distress and was found to have a large VSD with CCF. In rounds, the consultant suggested to start the child on diuretic furosemide and continue with careful breastfeeding. Her weight was 4.2 kg. Resident wrote down the prescription as careful breastfeeding, room air, injection furosemide, 40 mg IV BD and vitals monitoring. Can any of you say what is the problem with this prescription? The furosemide dose is wrong. It is 10 times the recommended dose. What happened to the child? She developed increased urination followed by cold and clammy peripheries. She went into shock, then she was resuscitated and luckily she improved. So what is the problem here? The problem here is a prescription error. So how to avoid prescription errors? There are few ways to avoid prescription errors. If you are going to have a software in which if you are going to key in the patient's weight and the standard drug doses is already in place, so that when you key in the patient's weight, you automatically get the prescribed dose, it's well and good. Otherwise, what we can do is, there's nothing wrong in checking the dose. Never be overconfident. You can double check the dose with a book before you write the prescription and use a calculator to calculate the dose for that patient's weight and then do. Errors definitely cannot be accepted. The second was a child with 1 year, 2 months old girl who was admitted for fever since morning and 1 episode of tonic-clonic seizure lasting for 3 minutes. The child regained consciousness immediately. On examination, the baby was alert, looking around, febrile with normal vital parameters. Systemic examination was normal. Her weight was 10 kg. So what is this case of? A simple febrile seizure. The consultant examined the child and advised to start paracetamol and clobazam. The resident's prescription was syrup paracetamol 5 ml 6 hourly and tablet clonazepam 5 mg BD. So here what is the problem? Instead of clobazam, clonazepam was prescribed. So this is a transcription error. The consultant has told out what drug to be given and the resident has written it wrongly. So it's a transcription error. Why does this happen? Due to sound-alike drugs. There is a concept called look-alike, sound-alike drugs. So some drugs look alike and some drugs sound alike. So this is clonazepam and clobazam, sound-alike drugs. So because of that, this transcription error has happened. How this could have been prevented? First, the resident should have been doubly sure before writing. And the resident should know that this is a child with simple febrile seizure, so the prescription will be clobazam. And when in doubt, the person has to definitely ask and get it clarified. And equal responsibility, or in fact more responsibility, is on the consultant, who should have checked the prescription and affixed his signature before it is carried out. So that is also an important measure to avoid such transcription errors. Next is a 4-year-old boy who was admitted for fever for 7 days with no localizing signs. The child was febrile with conjunctival congestion and discharge. The overall well-being was maintained. So the diagnosis was viral fever with conjunctivitis and the child was prescribed paracetamol and tobramycin eye drops. All is well till now. But during rounds when the drugs were checked, the parent had paracetamol tablets and tacrolimus eye drops instead of tobramycin eye drops. Here again it is sound-alike drug. Due to that, there has been a dispensing error. The nurse had dispensed the wrong drug. Instead of an antibiotic, an immunomodulator was given to this child. So how to avoid such errors? Nurses have to be doubly sure when they dispense the drugs. And they also should have, they are a paramedical person, they are not non-medical people. They are supposed to know what is the clinical condition of the child, what is the disease being treated, and what is the drug which is logically expected to be issued in this child. And when in doubt, they have to ask and get it clarified. And another responsibility is also from the doctors to check what the patient has during the rounds. I always tell my residents, it is not our doctor's duty, doesn't stop with writing the prescription. We should ensure the patient gets the appropriate drug. For that, during rounds, you have to check what drug the patient has and see whether it is right. So this is the prescription of a 2-year-old girl admitted for fever, written by one of my residents. So can you make out anything? It's too difficult. If you write a prescription like this, what will happen? There will definitely be dispensing error due to illegible handwriting. So how to address this? If you can generate a printed case sheet, if you have everything in electronic form and you generate a printed case sheet, this will be avoided. Otherwise, what should we do? Always prescription has to be written in capitals. This is as per any quality improvement program, as per any quality assurance initiative, the prescription has to be written in capitals and not in cursives. A 5-year-old boy presented with nocturia, easy fatigability, loss of weight for preceding 1 month. His random blood sugar was 436. His urine ketones were negative. He weighed 14 kg. He was diagnosed to have new onset diabetes, probably type 1, non-DKA onset. So his prescription was Actrapid 4 units TDS. Well and good. The nurse administered 4 units Actrapid intravenously, following which the child's CBG dropped and he developed hypoglycemia. So here you have administration error, which is due to a prescription error. As you can see, the prescription is not complete. It just mentions 4 units TDS. The route of administration and timing of administration is not been mentioned. Ideally, it should have been written as Actrapid 4 units subcutaneously thrice a day before, half an hour before each meal. So ideally, that is the way it has to be written. So the prescription has to be complete. And nurses also, they are expected to know the standard route of administration in standard conditions, and when in doubt, they have to ask and clarify. Next is a 5-year-old boy with developmental delay and seizure disorder, already on levetiracetam, presented with breakthrough seizure. After stabilizing his ABC, he was administered 2 doses of lorazepam, followed by full loading of phenytoin, then half loading, but still continued to have seizure. Then he was given Levy maintenance dose as IV. Still seizure was there. He was started on Midas infusion, after which the seizure stopped. Fine. But later, on checking the vial, it was found that the drug used was an expired drug. So this should never happen. This is an administration error, administering an expired drug. So the date of expiry has to be checked periodically in the ward, and drugs to be arranged as per the expiry date. The earlier expiring ones to be kept before and the later expiring later. And before administering each and every injection, the date of expiry has to be checked. On a busy day in a pediatric ward in a busy hospital, the ward census was 40, out of which 25 children were prescribed injections. Only 2 sisters were posted in the ward and they had to finish the morning dues within an hour. So they made a list of injections to be given. One of them reconstitutes the medicine and loads them, while the other runs from bed to administer. Is this fine? Not at all. Because when one person is loading continuously, another person is giving, there will be a mix-up of drugs and administration error. So the person loading has to give. Then on a lazy morning, there are only 5 patients who are prescribed injections and there is only a single nurse. So she doesn't have a problem. She makes a list, reconstitutes the medicine and places them in a tray, goes bedside and administers. Here only the same person is giving. Are there any issues? Yes, still. Because there will still be mix-up of drugs. So ideally, how should you give the injection? First, when the nurse has to give the injection, they have to verify whether a patient's identity, then take out the drug, check the expiry, load the drug, give the drug, then go for the next patient and load the next drug and give that is how it has to be done. A 2-year-old boy comes from an urban primary health center with fever for 2 days without any other symptom. The child is alert and playful during afebrile period and the appetite is good. So it is just a simple acute febrile illness. He is prescribed paracetamol 5 ml SOS at minimum 6-hourly interval. The mother is giving the advised quantity of drugs she has in hand at more frequent intervals for next 3 days because the fever is not subsiding. We have told 6-hourly, but she is giving more frequently. After 3 days, the child becomes irritable and on evaluation found to have raised enzymes. So this, everybody would have encountered this scenario because the child was prescribed 125 mg per 5 ml of formulation, but actually she was giving the double strength formulation at more frequent intervals and the child landed up at paracetamol toxicity. So this is also an administration error due to different formulations of same drug. So from our end, what can we do to tackle this? Always you have to check the formulation the patient has and to ensure. In IP, you have to check during rounds. In OP, you have to make the patient come back with the drug, show you the formulation and then tell the dose. But regulations wise, if there are regulations to have a single formulation and if you have a color coding, it can make life more simple. Then a 7-year-old girl who's a known asthmatics on preventers prevents to casualty of hospital with fast and labored breathing. On examination, the child has respiratory distress without hypoxia and normal perfusion. Started on 3 back-to-back nebulization with oral prednisolone. After an hour, it worsens and she develops central retraction and hypoxia. Why? Lack of monitoring. So whenever any drug is administered, the required monitoring has to be done. Without monitoring, no medication should be administered. So with those scenarios, we'll just sum up. Errors can happen at the prescription level, at the transcription level, at the dispensing level, at the administration part, and the monitoring part. So why do these errors happen? It is either due to the error in the process or due to human factors. So what do you mean by these? Process error means lack of a written policy on prescription writing. Like as I said, you should have a rule saying all prescriptions should be written in capitals if you can't take a printout. And you should have a policy on LASA drugs, look-alike, sound-alike drugs. You should know to sort according to expiry date. You should have SOPs on duties of consultants, residents and nurses. And human errors, distractions, interruptions, fatigue, overwork, insufficient knowledge, illegible handwriting, heavy workload, all these cause the human factors. A word about the look-alike and sound-alike drugs. So we have many drugs which look alike. So how to tackle this? So ideally, vials should not be kept separately. They should be kept inside a box in which the name has been labeled, so that we don't have any confusion. So the box should be labeled with the name of the drug. So you open the box, take out the drug, instead of going just by the cover. And sound-alike drugs, these are some examples. This is also very dangerous. So how do you have to be very clear? They should avoid transcription error, and for that the consultant has to check the prescription so that the sound-alike drugs are also there is no problem with that. Look-alike drugs, they have to be kept separated. They should not be kept next to each other. They should be put in a box, labeled and kept far from each other to prevent the errors. So how do we define them? Any preventable event that may cause or lead to inappropriate medication use or harm when the medication is in control of the healthcare professional, patient or consumer. So is it very common? Yes, it is common. US data says there are so many 237 million in a year, and out of which 1/4 are clinically significant, and it costs them quite a bit. What about India? There is an Indian study which says in pediatric population, inpatients, 3 to 8 out of 1,000 doses of for pediatric inpatients error do occur. In ICUs, they say it is even 5-fold. So what are the problems caused by these errors? First thing is patient dissatisfaction. When they come to know that an error has occurred, they are definitely unhappy about it. So they do lose the trust in the healthcare system, and it does cause physical as well as psychological harm. And so finally it may lead to complications which may increase the healthcare cost, and rarely it can even cause death, which is very unfortunate. So how can we reduce the errors? You should have standardized protocols. You should have training and briefing of personals. You should have patient education sessions. Technology can be used. There should be reconciliation procedure in place, and the packaging has to be appropriate. So we should have written SOPs in place to fix the individual responsibilities. Consultants are the head of the team. They have definite responsibility to check the prescription and to affix the signature in every case record. Resident has to write a clear prescription in capitals, double check the dose and calculation, and prescription has to be complete, including the route of administration and frequency. And during rounds, you have to check whether the patient is getting the right medicine. Nurses have to store the drugs in labeled containers, check the expiry date, reconstitute appropriately using the correct diluent, administer immediately one by one, to be proactive, well informed, and they also have to keep updating their knowledge. Regarding the human errors, to avoid them, we have to be focused, avoid distractions, update our knowledge, avoid fatigue by decreasing the workload, and when in doubt, always clarify. And discuss with your peers, your superiors, and work as a team to reduce these medication errors. So in a nutshell, we need to, whenever we use any medication, we all know the first policy, the main policy of us is first do no harm. So when we use medications, we need to verify the dose and formulation. Prescription has to be written in capitals, there is no compromise on that, and it has to be complete regarding all the details, and we have to take special precautions for the look-alike, sound-alike drugs, and check the expiry date every time before administering, and check the drugs which the patient has. So if we need to avoid medication errors, we've got to have the 7 rights whenever we administer medication. So what are those 7 rights? First, we should verify the identity of the patient. Am I administering the drug to the right patient whom I am intended to administer? So there should not be any mixing up of identities. So second is whether I am using the right medication. As I said, clonazepam instead of clobazam, tacrolimus instead of tobramycin, all these things. Then am I giving the right dose? Right dose has to be definitely checked. It cannot be, there cannot be any compromise, because any overdose is going to cause adverse effects, and any underdose is going to have lack of clinical response. Then is this the right time? Am I giving according to the correct dosage schedule? So that has to be verified. And am I giving by the right route? Like, is it intravenous, intramuscular, intradermal, subcutaneous? So what is or is it oral? What is the right route? So that we have to be sure. And the right reason. Both doctors as well as nurses have to be well informed about the common clinical conditions and what are the drugs commonly indicated in the condition. So they should have an appropriate knowledge that I am using this drug because the child has got this condition, and not mechanically give the drug. And last but not the least is the right documentation. Always documentation is the one which is going to save us in case of any medico-legal issues. So always document. So that is most important in the medical protocol. So that's all from my side. Thanks for listening.
Thanks, Dr. Sridevi, for a very lucid and crisp presentation. I think audience must have been mesmerized, and everyone must be revising ki yes, we have to prevent the medication errors. It's a big challenge for the medical profession. There are n number of jokes also on our handwriting, so we have to be careful. And with the advent of computer, life is simple for the doctors, but still we should be careful, at least prescribe in capital letters. That is all that is I will say. And any queries, any comments, or you can put it on the WhatsApp. Dr. Devi will be happy to answer.
Yes, sir. Thank you, sir. As we are relieving ma'am for an urgent commitment, we request our chairperson, Dr. Alok sir, to felicitate ma'am with a token of gratitude. Thank you, sir. Thank you, ma'am. I invite the next speaker for the session, Dr. Jayaprakash sir, Associate Professor at Tirupur Government Medical College, for a session on 5 misdiagnoses in well child visits. Welcome, sir.
Good morning, all. I'm going to discuss about 5 common misdiagnoses in well child visits. So in well child visits in our country, in the first 2 years, most of the well child visits are for vaccination visits, and after 1.5 years, every 6 months till they go to school, and then after they get into school, once in a year is recommended. So this is what we call as delivery point screening. This is done in the newborn period, preferably within the first 24 hours. And if you do systematically, head to foot and system-wise, we will not miss most of the physical abnormalities, right from head, eyes, mouth, limbs, abdomen, hips, and lower limbs. This is what RBSK recommends. This is a flow chart. So if you go through the flow chart, we will not miss out anything. General appearance, head and spine, face, eyes and ears, mouth and lips, chest, abdomen, genitalia, urinary tract, and limbs, and chromosomal abnormalities, especially for Down syndrome. And we have to discuss, document. Then only we can do things. And again, we have to documentation is important, because if we miss out anything in the examination, while we documenting, we will go back and redo, and we can find out the things which are liable to be missed. So this is a child, 3.5 months, coming for vaccination. The history says that there is no social smile, and we see coarse face and dry skin. We all know this is a child with possible hypothyroidism. Here, detecting hypothyroidism at 3.5 months. How can we detect early? Here comes the importance of neonatal screening. So we have to make sure that all babies have their serum tests done and the reports collected and reviewed. And if possible, OAE testing is also recommended. These two are, we do various screening for many diseases, but these two are more important, because we all know that congenital hypothyroidism is the most common preventable cause for mental retardation, and delay in treatment causes poor intellectual outcomes. Likewise, we all acquire knowledge through our senses. The two most important senses are vision and hearing, and we should make sure that these two are optimally monitored periodically. And then the other scenario, or 1.5-year-old child coming for vaccination, still not started to walk, and there are asymmetric skin folds over the buttocks and thighs, and there is limb length discrepancy, and there is limited hip abduction, and this is a child with possible development dysplasia of hip, but diagnosing development dysplasia of hip at 1.5 years not going to help them much. We have to detect it early in the newborn period. Even if newborn exam is normal, we have to repeatedly look for at least the last one, limited hip abduction at every well baby visits, at every vaccination visits. So by doing repeat examinations, we can, even if the test could be normal, they become abnormal later on. So the evolving and emerging conditions can be detected if we repeatedly keep on checking for certain things. And this is another scenario where a 5-year-old child, a 3-year-old child coming for routine visit, and the growth chart is showing a normal growth till 1.5 years. Thereafter, there is slowing of height, and there is history of neonatal hypoglycemia. This is a possible growth hormone deficiency. So just plotting the growth chart will help us to make the diagnosis early. The other child coming for vaccines at 10 years, and there is an excess weight gain and fatigability history. And the growth chart is showing this plateauing of growth for last 1 year, along with increase in weight. And this shows that the most probable cause is an endocrine cause, and we look at blood pressure, it will tell you that whether it is hypothyroidism or Cushing's. So if BP is normal and if bradycardia, possibly hypothyroid. We can make it out just by looking at the growth chart. So serial growth chart monitoring is also important. The other child coming for again vaccination, is turning in the history of turning blue while crying, breath holding spells. So how can we detect the nutritional deficiency early? Like always, we should develop the habit of looking at the palms, because anemia is very common in certain areas in India. There are more than 70% of children getting affected with anemia. We have to actively look for severe pallor. Nobody will miss, even mother will tell, but we should be able to detect early so that appropriate nutritional advices are given, because nutritional demands vary with age. So every time when they come, for whatever the reason, we should also ask for nutrition history, like right from exclusive breastfeeding to how to initiate complementary feeding, so how to give, when to give, how much to give, and also concentrating on micronutrients. The other end of spectrum of malnutrition is obesity. The recent pandemic, we are going to see more number of cases in future. Like in certain cities in our country itself, there are 30-40% of school children are obese. So what we see is acanthosis nigricans, says the insulin insensitive resistance. And the growth chart again will be showing increase in height and weight, but weight will be more than height. And serial monitoring will help us to catch them early, educate them better. We can use these charts to even show the parents how it is abnormally increasing so that they take some measures. And a 6-month-old child brought for vaccination is having social smile, and there is normal head control. Hand regard is present, but child is not fixing and following light. In examination, red reflex is present. And we all know the possibility is benign, delayed visual maturity. This is a rare thing, but it's a normal thing. We need not be worried. But this stresses the importance of repeated examination every visits. And once we should not miss this developmental delay. So always we should use at least Trivandrum developmental screening chart at every visits. There is 0 to 3 years and 3 to 6 years. We have to draw a vertical line through the age, and whatever falls to the left should have been already attained by the child. So at least we should develop the habit of using TDSC at every visits. And then the next common developmental problem is, again is on the rise, maybe because of our awareness. So detecting a child with pervasive developmental disorders with history of speech delay at 3 years, the prognosis would be little bit not good compared to a child who is caught at 1.5 years. So for all children at 1.5 years of age, when they come for vaccination, we should use this M chart. It takes just 20 questions the parents are going to fill. It takes just 1 or 2 minutes for them to fill. So once we get this one, we can score it, and if needed, we will refer. So at 1.5 years, all children should have this M chat done. And then comes the vaccination thing. So far we discussed they have coming for vaccination and telling minor compliance from them. We are getting serious things. Here, for whatever reason they come, we should develop a habit of educating them about all the possible vaccinations available. So UIP is National Immunization Schedule is good. More vaccines are being added every year, but that is not complete. There are other vaccines which can prevent serious illnesses like even typhoid, even seasonal flu shots, hepatitis A. These vaccines have to be told, they have to be informed. Let them take the decision, but it's our duty to educate them about the pending vaccinations if they come for whatever the reason. Then comes the anticipated guidance. Anticipated guidance, there are many things we can guide them, we can educate them at every visit, but these things I felt this should not be missed, like safety concerns. Like by 4 to 5 months of age, once the ATNR disappears, child can roll over and can easily fall from cot. So whenever they come for this 3.5 months vaccination, I tell them to put the mattress over the ground so that we can avoid fall. Likewise, use of cribs. Likewise, at 9 months, once they develop this pincer grasp, they can easily handle tiny objects, so they can easily choke it. So you have to give them the advice at 9 months of age, the small detachable objects containing toys should be avoided till 3-4 years of age, and also the hard edible items like cashews, badam should be always grounded and given. Many times the elder sibling would have offered these peanuts and all. That's the most common foreign body what we see in our hospital. And then even medicines, how they should be stored, inaccessible to the children has to be advised. And then sleep. Sleep, there are recommendations for each and every age. We will see that. And again, the screen recommendations. Screen, absolutely no screen till 2 years of age. This we have to tell them, because most of the times they use screen for to feed the baby. So we have to educate them about the screen hygiene. And then the practices, by that I mean the traditional practices. Certain traditional practices can be allowed, but many should not be allowed because they are harmful. We have to ask them right from pre-lactal feeds to Vasambu, the age-wise. We have to ask, and then only they will come out. We can educate them about these, what are the bad child rearing, including feeding bottle. And then the important physical activity that we will see. Again, dentition. Again, dentition, the dental hygiene starts right before the teeth erupts. We have to educate them at each and every visit about this dental hygiene, at least to offer them water after each and every feed, and they have to brush their teeth after teeth erupts, and initially with half the dose of fluoridated thing like 500 ppm, and then after 8-9 years they can use the adult 1000 ppm fluoride containing paste. So this is the IAP guidelines for normal sleep. Sleep, our memory consolidates, our body repairs, so it is essential. In this era of too much academic commitments, they don't find time to even sleep normally. Not even playing the physical activities less, they don't even sleep normally. If you see, like in adolescence, they recommend at least 8 to 10 hours of sleep. But most children, including my child, don't sleep for so many hours. And then this is about the physical activity. Physical activity starts right from birth, this tummy time and all. But after 1 year, at least 3 hours of physical activity is a must. And in a child, 3 to 5 years of age group, the physical activity should contain moderate to vigorous physical activities like cycling, running and all. And above 5 years itself, they recommend strength training at least 3 times a week. Strength training means weight training. So this is what AAP recommends for preventive pediatric care. The whole list is there. But even our the government setup, they are issuing this MCP card, Mother and Child Protection card. This contains almost everything except the anticipatory guidance. So these are the 5 things which we should not miss. Development, anticipatory guidance, vaccines, anthropometry and nutrition. That one means giving, and what gives more pleasure than giving. So prevention is always the best, we all know, but if not possible, let's catch early so that we can intervene early to have an optimal development and outcome. And for further reading, IAPindia.org gives all the guidelines, parental guidelines, even guidelines for us, and then National Health Mission, RBSK, and from AAP. Thank you for your patient listening.
Thank you, Dr. Jayaprakash, for a very insightful upliftment of the session with 5 important things you have summed up. And I think if there are any questions or comments, or you can just put it on the platform and it will be shared to Dr. Jayaprakash and you'll get the reply. Thank you, please. Thank you.
Yes, sir. Thank you. Thank you very much, sir, for the enlightening session. We request our volunteers to present our speakers and chairperson with a token of gratitude. I request our chairperson, Dr. Alok Bandari, sir, to felicitate Dr. Jayaprakash, sir, with a memento. Thank you, sir. I request Dr. Jayaprakash, sir, to present our chairperson with a memento.
Next, we'll move on to next session. We are privileged to have with us Dr. Kamalesh Srivatsava as chairperson today. Sir is an eminent pediatrician who has served as a chairperson of the Pediatric Intensive Care Chapter and as a president of IAP Mumbai. With his leadership and commitment to advancing pediatric care, Sir has been a guiding force for many colleagues and students alike. It's a pleasure to have you, sir.
I would also like to invite the first speaker for the session, Dr. Sumita Nayak, ma'am, consultant pediatrician at Shishu, the Children's Clinic, Bengaluru. Ma'am has 35 years of experience and was a former president of IAP Bengaluru. Ma'am will be speaking on mitigating vaccine errors. Welcome, ma'am.
Can I start? Is there a slide changer here? Slide changer. Yeah, but not on, this is only a laser. This is only a pointer. There's no changer. So I have to work over here. Okay. Good morning and welcome to all of you, and a big thank you. A big thank you to the organizers of KONGU PEDICON for having me here this morning. My topic for this morning is mitigating vaccine errors. As we all understand, vaccination is our bread and butter. At least it was till very recently. We have lost a major part of our vaccinations to the national program, but we still have some amount in our hands. And it's very important that we learn and not make mistakes, because that's the only way we are going to attract more patients for us. So whenever you make a mistake, there are three things you should do. The first and foremost is accept it. Accept that you have made a mistake. The second is learn from it. So learn from your mistakes. And the third is the most important: never, ever, ever repeat the mistake. So you have to learn from it. So let's talk about what is a vaccine error. So it is a preventable event, and it arises from the inappropriate use of vaccines. It can happen at any step in the entire process of immunization, starting from prescribing, that is selecting what vaccine has to be given, dispensing it, preparing it, monitoring, storage. So through the entire course, you might have errors. And what does it result in? The immune protection is not adequate. There are adverse effects. And in today's world, we are all worried about the legal aspects. Of course, patient confidence goes down, and there could be potential injuries to the health system users. So what are errors and what are faults? So very quickly, let's try to understand. An error is something which has happened without intent. Okay, in a given context, something has happened which is not correct, but you are not really sure. You do not, the person who is doing it is not aware that a mistake has happened until it has occurred. Whereas a fault is a violation of a known rule. That means it is done with a full knowledge. It could be deliberate or it could be negligent. And both of them, importantly, there is a liable, you become liable. So legally as well as morally, adverse effects can happen. So very quickly, let's look at what are the types of vaccine errors. So we have understood why we should not commit errors. There are different types of errors which can happen. The whole list is here. This is again not comprehensive, but the common ones. And let's try to see if vaccine errors are common. Many times we commit an error, we are not willing to accept it. So lots of studies are there, a whole bunch of studies. The bottom line is that the prevalence is 1.15 per 10,000 doses. So there are a lot of vaccination errors which happen. The commonest is the wrong vaccine administered. Please note, off-schedule administration. So these are the two very common errors that happen. And this is a study of from 2000 to 2013. And it has shown that there is a progressive increase in the number of reported vaccine errors. So there will be a lot more. Now, this is very, very recent data, 2024. The Institute of Safe Medication Practices shows that almost 25% of the vaccine errors are by giving the wrong vaccine. So please be alert, please be aware. Expired vaccines, contamination, 20%. This is pretty high. So please don't ever keep expired vaccines in your storage. Wrong dose, overdose, underdose, etc. So these are all the other causes. So my presentation is actually an interactive session, but I'm not sure I have time to go through it, so I will try to present the questions and the answers without asking the audience. But wherever it's possible, I will ask for a response and kindly try to give it. So the first case, a little bit detailed. The basic thing is that there are two kids who are brought in for immunization. One is a 1.5-year-old and there's a 10-year-old. Both are there. The nurse has prepared the vaccination, and you are talking to the parent. You have been distracted. There's been a phone call, and you give the Tdap to the 1.5-year-old child, and the other one, that is the 1.5-year booster vaccine to the 10-year-old. Now, is this an error? Yes or no? So what type of error? This is the incorrect vaccine which has been given, and to the incorrect patient. How are you going to manage this? Now, for the younger child, first of all, let's understand that Tdap is licensed only and only above the age of 7 years. And what are you giving for a 1.5-year child? The child needs DTP, Hib, and IPV boosters. Now, why is it essential to give DTP? Because the antigen quantity in the DTP is higher than in the Tdap. Okay? So you definitely need to have a better protection at the younger age. Together with the Hib and the IPV, standalone is not available. So what are you going to do to this child who has received only Tdap? You're going to correct the error by giving him another dose of the correct vaccination. Okay? So what do the guidelines say? First of all, inform the parents that you have made a mistake. Tdap given younger than 7 years of age, either as dose 1, 2, or 3 is not valid. But if you have given it to a child younger than 7 years, either as dose 4 or 5, it can be valid. But as I said, there is no standalone Hib, there's no standalone IPV, so you have to go ahead and revaccinate this child. What about the older child? Older child should get Tdap, but he has received pentavalent. So what's going to happen? The child will have a higher reactogenicity. He has got extra doses of IPV and Hib, but no adverse effects of these extra antigens. Only that he will have a little more of reactogenicity. So please inform the parents if this mistake has happened, and how are you going to prevent this error? Ideally, make sure you get one child in at a time, prepare that particular vaccine, give it, and then ask the second child to come. So this way, you're not going to have any errors. Another situation, while administering the meningococcal vaccine, there's a brand where you have to mix the diluent. So only the diluent, you are so busy talking, you have forgotten to reconstitute it, and you have only given the diluent. So what is this? Is this an error? Yes. Component omission, inadequate antigen administered. What's this? What is the consequence? Well, this is the brand of meningitis vaccine which has to be reconstituted. What does it contain? The liquid contains only the serotype C, W, and Y. A is missing. So if you are not reconstituting it, the child is not getting protection against serotype A. So this is incomplete protection. The child is not completely protected, and you have to repeat the vaccine all over again, right? So that is how you're going to manage this case. A very common situation while taking out, this is especially the single-dose MMR vaccine, the nurse has dropped the box, the diluent ampule has broken. Can you take 0.5 ml of sterile water and utilize it as a diluent for the vaccine? Yes or no? No. Diluents, please note, diluents are never, ever, ever interchangeable. Please don't ever use a diluent of any other vaccine. Wrong diluent, you do not know what the efficacy for the vaccine is. You do not know what the immunogenicity is, not guaranteed. So never, ever do that. Take a fresh dose of MMR and diluent, reconstitute it. If it is noted, if you can do it on the same clinic day, yes. If not, as it's a live attenuated vaccine, after an interval of 4 weeks, right? Now, a 6-year-old has sustained a category 2 dog bite. The child is taken to a nearest clinic. TT and ARV are given into the gluteal region. Is this a valid dose of ARV? Yes, no? So what is the error? Wrong site of administration, okay? And never, first of all, never ever administer any vaccine to the gluteal region. It is a wrong site. ARV, the sites are only the anterolateral thigh or the deltoid. So no other sites for especially ARV. Rabies is a deadly lethal disease. You cannot take any chances. So here, both the vaccines, the tetanus containing vaccine as well as the anti-rabies vaccine, both are invalid. You need to repeat it at the correct site. Start the count from there. For the ARV, you start counting the correct dose as dose 0. Okay? Never ever, and then complete the rest of the whole course. Now, this is a young adolescent. While giving the Tdap, many a times they are very, very restless. They are very apprehensive. The boy has flinched his arm. The needle has come out, and what has the doctor done? He has taken it and reintroduced, jabbed the same needle and completed the vaccination. So is this, first of all, a vaccination error? Yes or no? This is definitely an error of administration. Please note, you cannot use the same needle and syringe. The moment it has entered the body, it encounters the capillaries. There's mixing of the blood which happens. Antigen, pH, etc. changes. You're not sure about the immunogenicity. So if you are meeting such a, or encountering such a situation, you definitely need to change the vaccine and use a fresh dose of vaccine with a fresh syringe and a needle. I'm sorry I have to go a bit fast because I have a lot of case scenarios and my time is running out. Now, similarly, while administering PCV, the nurse aspirates before administration and she notices blood. First of all, do you need to aspirate when you're giving a vaccine? Yes or no? How many no's? Okay, I still see a few hands down. So, please, for those who are still in a dilemma, never, ever, ever aspirate. Because if you aspirate and if you get blood, your technique is wrong. You have to change the entire vaccine. You know how expensive PCV is if you are giving it in your private practice. So never, ever aspirate. If you are sure about the site, you do not need to have an aspiration because you will not be hitting any major blood vessels there. Okay? Now, a child is given hepatitis B vaccine by the subcutaneous route. Is this valid? Can you give hepatitis B by subcutaneous? Doesn't really matter, right? IM, subcutaneous, all the same. Can you give hepatitis B by subcutaneous route? Yes, no? How many yeses? How many no's? Okay, why not? So this is the incorrect route, okay? So generally, the live attenuated vaccines are given subcutaneously because we understand that there's a multiplication of the virus and then it spreads, the antigen presenting cells are there in the subcutaneous tissue. The immunologic process is much better and easier. There's a lot of multiplication, organisms spread via the bloodstream and you get a very good antibody response. Hepatitis B is a conjugated vaccine. Now, especially in the case of, please note this, HBV, HPV, inactivated influenza and rabies vaccine, the route of administration is absolutely crucial to get the right amount of immune response. So if you have by any chance given it subcutaneous, it's a wrong route. You have to repeat it and it is definitely a vaccine error. Okay? Now, you have, this has actually happened, an inactivated Hep A vaccine was given and the sticker, well, it can happen with any vaccine. In this particular case, it was a Hep A. Sticker was affixed and you have sent the patient out very happy that you have finished one vaccination. But the father is somebody who's, he is very tech savvy. He wants to check what you have done and he's checking and he finds that the vaccine has an expiry date 3 months ago and you have given it. Now, of course he's angry, so how are you going to manage him? What are you going to do? This is an expired vaccine. This is definitely a vaccine error. It is an invalid dose. You need to re-administer it. So, how do you interpret expiry dates? If a date is given, it indicates till the midnight of that particular date, you can use the vaccine. It is valid. If only a month is given, it is till midnight of the last day of that month. That's how you're going to read the expiry date labels. In this case, of course, you have to explain to the father and calm him down. I put this slide here for all to understand the intervals because you may not, the parents may not agree. They may not allow you to do another jab on the same day. So what is the valid intervals? If it is 2 or more inactivated vaccines, you can do it if they are agreeing. You can do it at the same session or at any time. They want to come a week later, 10 days later, no problem. But if it's an inactivated and a live, again, you can do it at any interval. However, once it is 2 live vaccines, for an example, MMR chickenpox vaccine, if there is any error, if there is any need to repeat, you need definitely to keep a 28-day minimum, that's a 4-week minimum interval, if not done on the same day. So if they are saying that I'll come back after 1 week, no, you have to call them back after 4 weeks. So that's the interval required between live attenuated vaccine. Probably this would be a last case for us. A 35-day-old infant has been administered a dose of DTP, Hib, IPV along with the pneumococcal and rotavirus vaccine. Is this valid? Yes, no. What kind of a vaccine error is this? Wrong, incorrect age, right? So there is a concept of grace period. Many of you would have heard that. So what is the concept of a grace period? It is a minimum or a maximum of 4 days before the minimum interval. So we do not give it at 35 days, we call them at 6 weeks, which is 42 days. So you have to count backwards, okay? So 27, 26, 25, 24th day, right? So that is the interval. Any vaccine which is administered 23 days or before is invalid. So this is the concept of the grace period. So what it definitely means is that any vaccine which is given 5 or more days earlier than the recommended date is an invalid dose. So you definitely have to call this child back. Sorry. Call this child back when he is 42 days and give the vaccine, okay? I am running out of time. For lack of time, I have to cross all the other cases which I have. I want to present to you what you need to do to avoid such errors. As I mentioned at the start, vaccination immunizations have been our bread and butter. A better way of ensuring that you keep your patients and get more patients to you is to ensure that you avoid errors. And how can you do it? Follow the 4A approach. What is that? Accept, apologize, assure, and administer. So if you have committed an error, which I hope you will not commit after today's session, please apologize, please accept, and please apologize that, yes, I have committed an error. Assure the parents, talk to them, because they're going to be very angry that something bad is going to happen to my child. You've given a vaccination which is past its date, it's going to have a harmful effect. Please explain that there are no adverse effects which can happen after an expired vaccine. The only thing which we are concerned about is probably the immunogenicity may not be up to it. Administer the dose of vaccine. So administer the correct dose. Of course, you should not charge them for that extra dose. Make sure you take the correct vaccine, which is a valid dose, and administer it preferably at a different limb. So I've told you all the intervals. I've told you the expiries. Finally, I would like to leave you with how to prevent vaccine errors. Okay, you have to be able to have a pre-vaccination checklist. What are you going to do on the checklist? What are you going to ask? First of all, when you give a vaccine, make sure you are documenting it. So then when they come back again, check to see, is the date correct? Check your vaccine. So the dictum is check the vaccine vials 3 times. So we have an inborn kind of a system where you talk, or when you say something or check something 3 times, you're kind of making sure that you will not be going wrong. So check if the vaccine quality, if it's not out of date, if it's stored correctly, if there are no contraindications, check to see that it's the right vaccine and the right dose. I have just 2 or 3 more slides and I will finish. Okay, during the vaccine preparation, make sure that you are very calm and you're very focused. Try to turn off your mobile phone. Try not to be disturbed. If necessary, have a separate session, ideally only for immunization, and you are staying calm. They have all the necessary equipment. Make sure that it is reconstituted. If it's a vaccine which needs reconstitution, make sure that the needle has been affixed and it's tight. There's no chance of leakage. Make sure you know what the route of administration of the vaccine is. As far as the patient is concerned, try to make them relaxed. After the vaccination, make sure that disposable disposal of the vaccines is in your sharps container. Patient has to be under supervision for at least 15 minutes. Make sure that you have documented it in the health record correctly. Very important, something that we tend to miss out is ask them or inform them when they have to come for the next vaccination date. And importantly, also tell them what are the adverse effects which can happen to the child, whether it's fever, whether it's pain, whatever it is. Please tell them. If there's anything else that happens, also they should be able to reach out to you and convey to you. So if there is any other adverse effect which you have noted, you have to definitely notify it. Okay, finally, 5 important questions to ask before each and every vaccination session. Anytime the child walks into your clinic for an immunization, ask the parents, how is your child today? Has your child received any vaccine in the past 4 weeks? This is especially for new patients who walk into your clinic. Check out and ask them if they have, of course, a document. Kindly look at it and check what was the last immunization given. Ask them if they have been hospitalized. Again, this is especially for new patients because they might have had doses of immunoglobulin given, steroids given, high dose, low dose. You definitely need to check. Is the child on any regular medications apart from vitamins? Again, especially when they come in for the first time, you don't know the past history, or you haven't seen them in a long time, there's been a long interval, ask them if they have any other medications. And most importantly, any reactions to the past vaccine. So this will give you an idea if the child is allergic to any components of the vaccines. Thank you very much for your patient hearing. Okay.
Hello. Thank you very much, madam, for the highlighting the mistakes are being done while inoculation of the vaccines. And I feel that in every vaccinology conference, these topics should be taken on priority basis.
Sure, there's a question.
Any question or comments? And
Please give him a mic. Yes, ma'am.
Ma'am, first of all, very excellent presentation. Just want to make a small addition that mixing up of vaccine, Tdap given to less than 7 and DTAP with Hib and IPV given to a child above 7 years. When two children, two siblings from the same family come, what I do is, I ask the mother, you want which child to be given first? I give the option to the mother. So that first one she chooses, that particular vaccine I take and load and give. The second one, I give it to the mother. I think mother is better person than me. So mother keeps it safe. When I finish the first one, then I get it from the mother and give it the second.
Thank you for sharing your practice, ma'am. You have to be very careful about the mother not dropping it because you might end up losing the vaccine. So ideally, prepare each vaccine separately, finish one, then take it out of your fridge or your ILR and then administer it. So that way you are safe as well. Yes, ma'am.
Dr. Sumita, that was an excellent lecture, as always, on vaccines from you. And I just wanted to know, this 35-day-old baby who was given a vaccine error on the date, can you repeat it? Because already there is a load of antigen, but we know immunogenicity is questionable before 42 days, that is, or 45 days. So can we repeat it by that 45 days, that is 10 days? Or should you give another 4 weeks time? Because you had, I just wanted to know your thoughts
Madam,
on
the
that.
parenteral vaccines are, in any case, they're not live attenuated. You're going to do the DTP and you're going to the PCV. So there is no harm in repeating that.
No,
there
how
is
about
some doubt about the rotavirus.
Rota, because
Yes.
it's a live vaccine, I just wanted to know.
Yes, ma'am. The rotavirus, there is some confusion now. As per current CDC, the latest CDC, what it says is that for rota, you have to wait for 4 weeks. Only for rota, not for the injectables.
Okay, thank you.
Thank you.
Thank you, ma'am. I invite the next speaker for the session, Dr. D. Rajkumar sir, Professor of Pediatrics at Madurai Medical College and Treasurer of IAP-TNSC, for a session on updating on management of tuberculosis. Welcome, sir.
morning, one and all. A warm greeting from Temple City, Madurai. First of all, I would like to thank the organizers of KONGU PEDICON for giving me this opportunity. Thank you very much. It was wonderfully organized. The question was excellent. With that, I'll start the topic. Right. What I'm going to talk in the next 18 minutes, it's about recent advances in TB management. I don't have time to go into each and nitty-gritty of TB. We all know everything about TB, so I'm going to talk about the recent advances only. Okay. What happened now? Since time immemorial, TB has been ravaging the humankind. It has been plaguing us, and it's causing immense suffering to us since time immemorial. And after the advent of in 1943, Selman Waxman, he discovered streptomycin. Then a slew of drugs, they came, and we thought that we can conquer TB in another 20, 30 years. Slowly, the time we thought we'll conquer TB, it was postponed. We thought by 2000 it would be eliminated, and now we are in 2025, and look at the stats. Last year, it was 2014 actually statistics. Still it is, maybe we can increase another 10 to 20%. 7.5 million children are infected, out of which 1.2 million has developed TB. And out of these 12 lakh children, 200,000, that is 2 lakh children, they died. And that's a sorry state we are living in. So can we conquer TB? So due to time constraint, as I already told, I'm going to talk about only the recent advances. So what has happened is WHO and other experts, they have again gone into the war room. They redone the battle plan, and now they made a lot of recommendations that they think that we can, with these recent advances, we can conquer TB in another 10 to 15 years. We'll see what are those recent advances. So I have divided my speech into two parts. The first part would be about recent advances in TB diagnostics. Right. What are the challenges before us? These are the challenges. TB is a paucibacillary disease in pediatric age group, and it's very, very tough. Our postgraduates, they might be knowing that because they are the one who will be obtaining these respiratory samples. It's very, very tough. Most of the time we will fail, and the high rates of extrapulmonary TB also, it's not going to help us. These are the challenges, right? So what are the recommended specimens currently? We all know that induced sputum is the very good one, and gastric aspirate, that's right and left. It's a bread and butter we are doing against TB. And nasopharyngeal aspirate is also, we have been doing, but the recent recommendation says that stool samples can be used for CBNAT. And urine also can be used, and urine, it's especially for HIV affected children. Those who are having HIV and with tuberculosis, the sensitivity specificity is very high. So the use of stool samples and urine is the recent recommendation. What is the strategy they advise us? We have to go for concurrent samples. So not only the respiratory, go for the non-respiratory samples like stool and urine in HIV positive, of course, but stool for other children. So if you do both, you may hit the jackpot that you may identify. So these concurrent samples might increase the sensitivity. That is the current recommendation. What about now what test we have to do? The first line tests. So all those things, the smear microscopy that we have been doing for last 60, 70 years, Zeal-Nielsen technique, everything is gone with the wind. Culture, phenotypic, DST, nothing is recommended now. So postgraduates, they have to forget all about those things. We will not ask in another few years, we will not ask about Zeal-Nielsen technique, all those things, blah, blah, no. So the only test currently WHO recommends is the CBNAT, expert MTB RIF. That's the only initial diagnostic test for identifying TB. Of course, the sample already I told, sputum, gastric aspirate, nasopharyngeal aspirate, and stool. Right. What about TB meningitis? Yes, the same expert CBNAT can be used in CSF sample, right? Extrapulmonary TB, yes, the same CBNAT can be used in the whatever specimens, lymph node aspirate, a biopsy, pleural fluid, peritoneal fluid, pericardial fluid, a synovial fluid, or urine specimens. You can use as a diagnostic test. And in HIV positive children, we can, to identify disseminated tuberculosis, this same CBNAT can be used in a blood sample. And what about repeat test? A lot of controversies are now in doing this repeat test. Initially, we were doing 2 tests, day 1 and day 2. Then due to the scarcity of material, CBNAT and other things, in government setup especially, they told us to do 1 test. So what the recent WHO guidelines say, we have to do 2 tests. It's not 1 or it's not 2. They say you do first 1 test, and if it comes negative, especially in high prevalence countries like in India, okay, whenever you have very high suspicion of tuberculosis, so which conditions will make you suspect TB, HIV co-infection, household contact with TB. Of course, they come from poverty, malnourished children, and specific demographics like migrating population, tribal population. So in whom we can repeat CBNAT after 2 days, because we get the results in government setup after 2 days. In private setup, they get it within hours. Maybe next day in private setup we can do it if you have a doubt that the child still you have a doubt the child suffers from tuberculosis, but the first result has come as negative. So 2 is the current recommendation, right? And what are the current recommended rapid diagnostic aggregates? Whenever we say CBNAT, we always thought this, only one. It's like 1 test. No, a lot of other tests are there. The CBNAT one we use is low complexity NAT, nucleic acid amplification test, and we have moderate complexity NATs also is there, and then the next generation sequencing also is there. Then of course the one urine lamp for HIV positive children. As I told, the CBNAT, the one we are using is the Expert MTME ref, and there is a recent advanced Expert Ultra has come with more sensitivity and specificity. And TrueNAT MTB also is there. I'll tell a few words about TrueNAT in our next slide. So this is the one which is recommended as an initial test in all presumptive TB cases. Of course, you know about the stool GA and the stool samples, and stool sensitivity is almost 50 to 65% versus culture. So it's a very good test. We can use it. This is the one we use right and left, the CBNAT. Right. TrueNAT, it's actually a portable one, battery operated platform. It's very, very effective when you're going to use it in a peripheral settings. But the word I got it from pulmonologists from Madurai region, what they told, it gives a lot of false positives, TrueNAT. So if your institution has CBNAT, don't go for TrueNAT. TrueNAT gives you a lot of false positive. Coming on to the moderate complexity, the types are BD Max MDR TB and Roche Cobas MTB RIF INH. So they are to be used when the first initial screening test has become positive. Now you are going to use it to identify if there is any resistance. The first CBNAT will give you only regarding rifampin resistance. This one is going to test against all other drugs, resistance against other drugs. And this has to be used as a reflex test. This recommendation is for the laboratories. The idea is, once the first test has become positive, the previous one, CBNAT, they have to do this moderate complexity NAT immediately without being asked to do. They have to do it as a reflex, and on the sample they obtained previously if the first one becomes positive. And NGS, if your hospital can afford, that's the best one to identify. Because it can detect mutations for more than 5 antitubercular drugs rapidly. The examples are Dplex Mike TB and ARM4 TB. It's a recent one. It's a nanopore based. It's portable. You can see in the picture. It fits into a palm. What about this recent recommendation of using urine sample? You see, it's not suitable for all. It's not a general diagnostic test. Please have it in mind. It's a point of care test for TB detection in HIV positive children, because the sensitivity and specificity is very, very high in HIV positive children, especially those who are having low CD4 cell count. We don't know why, but in these children, the sensitivity specificity is very high. It cannot be used for general population. Right. This is a test, which is, it's like a card-based test. So let us I'll sum up with the diagnostic algorithm. So start with low complexity NAT and gastric aspirator stool. If positive, the lab has to do reflex immediately without asking, DST, or if your hospital can afford, NGS, that's a better one. And repeat testing if the clinical suspicion persists. So with that, I'll move on to the second part of my talk, the recent advances in pediatric TB treatment and care. So what are the challenges here we face? You know, challenges are very, very many. The formulations, the palatability is very, very tough. The drugs they have to take for 6 months and resistant cases for 9 months, 12, 18, 24 months. The complaints, you know, it's very, very tough. Even for adults, the complaints is poor. In pediatric age group, it's really tough. The parents, they find very tough to continue for so many months. And of course, the presence of MDR, XTR, TB complicates the picture. And the caregiver engagement and follow-up also is very, very tough because, you know, the parents, they have to go for work. So it's very, very tough. These are the challenges we face. So the current recommendation is WHO recommends make it all the pediatric TB tablets as a disposable one and flavored to increase the acceptance. And it has to be the fixed dose combinations to make it easy, to make the life of pediatrician as well as the baby easy, so that they can take only one drug in the morning instead of taking 4 or 5 drugs. You know, we know as parents how tough it is to give to multiple tablets at the morning, right? And simplifies the dose, right? Moving on to the management, the recent recommendation in drug susceptible TB. This is the major recommendation they made, shorter treatment for non-severe drug susceptible TB. So what is this shorter treatment? Before going into that, let me define what is this non-severe TB. WHO says that if it is a single lymph node TB, basically, you know, lymph node enlargement due to TB or an uncomplicated effusion or intrathoracic lymphadenopathy without any other organs affected, or a single lobe disease, non-cavitary, and without a miliary pattern, of course. So this constitutes a non-severe TB. So for this, WHO recommends up to 16 years, 2 HRZT and 2 HR. Only 4 months of TB treatment. And what about for older people, those aged more than 12 years, adolescents? It recommends a 4-month regimen of 2 HPMS and 2 HPM. This, we know, INH and rifampicin and moxifloxacin and pyrazinamide. And what is the evidence for 4-month regime? Now it is being endorsed by WHO, CDC, IDSA, because so many trials, it's validated the 4-month regime. The most important trial is the SHINE trial, the shorter treatment for minimal tuberculosis in children. It showed that the 4-month treatment is non-inferior to 6-month regime. Moving on to the severe pulmonary tuberculosis, the tuberculosis which doesn't come under the non-severe one, we know the one we face often, and extrapulmonary TB treatment. The standard one, the 6-month 2 HRZT by 4 HR, and for, of course, TB meningitis, the 4 HR is extended to 9 to 12 extra months. But we all know that IAP and RNTCP, we do not follow WHO, so that's why I put this slide, because the category, all this category have been now clubbed into one. It's only one, new microbiologically positive or microbiologically negative or CB0 positive. The recommendation is 2 HRZT by 4 HRE. So why this E, IAP and RNTCP, they recommend, no. What has happened is, in South India especially, the INH resistance is very, very high. In Madurai, they told almost 20 to 28% they found out the INH resistance is there. It could be either primary or during the treatment. It can come as a secondary. The overall, the prevalence is about 10 to 14% INH resistance. So to prevent this, they added ethambutol even during the maintenance phase. That is the reason for adding this ethambutol in the maintenance phase. So what is the current recommendation regarding dosing? Previously we used to give once in 3 times a week, 3 times a week, all those dots, all those blah blah, now it is all thrown out. We have to give every day. That's the most important one. What they found out, the giving 3 times a week actually favors the development of more resistance. So thrice weekly dosing is not at all recommended. It has to be given daily. And one more thing, at the end of the intensive phase, previously what we do a smear positivity test, and if it is positive, we continue the intensive for maybe another 1 or 2 months. No, now they say no, don't do it. Give intensive for only 2 months, then go for the maintenance phase. So moving on to the drug-resistant TB, here nowadays we are facing a lot of, with the advent of all these moderate complexity NAT and NGS, we are finding a lot of our cases are having drug resistance. Before going into that, let me define the resistance. The mono resistance means resistant against any drug constituting the ATT except rifampicin. And MDR-TB, it's resistant to some other drug with rifampicin. So rifampicin resistance is the most important one, which is going to define the MDR-TB. And what is pre-XDR and XDR? Pre-XDR, it is MDR plus any one of the following: resistance to quinolones or to any other second line injectable drugs. If MDR plus resistant to quinolone as well as second line, it comes under XDR. So with that definition, let us move on to some statistics regarding this DRTB. It's a very important public health challenge, and because of this DRTB only we are losing the battle. So we have to have a plan how to tackle this. In 2023, we had 400,000 new cases of MDR-TB in India, and nearly 15% of them they died within a year. That is the amount of problem we have. And why this is happening? Why we couldn't identify this MDR-TB earlier? Because we didn't have all those tests, NGS and other things easily available everywhere. Most importantly, the treatment options were very, very poor, suboptimal. The prolonged treatment regimes, 18 months, 24, 36, it was like that. And higher number of pills. They have to take like 100, sometimes 50 to 100 number of tablets a day. And all these drugs have very severe side effects, and the outcomes are very, very less favorable. And most of the trial done before that, they excluded children. They were done only on adults. So we didn't know what is the problem with children, about how to treat. Now, recently, last 3-4 years, a lot of trials have been done. That's why WHO has modified, has given recent recommendations. So the most important recommendation they have done now is they have given green light for 2 drugs, bedaquiline and delamidine. They can be included in pediatric drug therapy. That's the most important recommendation. And linezolid also. We are using linezolid right and left in our ICU and other things for a shorter period, 10 to 14 days only. But here we are going to use it for longer period. And linezolid can cause a lot of side effects. That's why the toxicity monitoring is very crucial when you are using these drugs. It requires every month clinical examination, especially the CNS examination, ECG, audiometry, visual acuity test, all these they have to be done. So what is the current recommendation for TRTB? Now only 6 months we have to use all these drugs. Not 9 months, not 12 months, 18 months, 24 months, all gone. Only 6 months. It's for MDR-TB as well as free XDR. For pulmonary and all forms of extrapulmonary, only exceptions are TBM and osteoarticular and disseminated TB. So what is the regime? There are 2 regimes. The first one, and this is the one we are recommending, WHO recommends for children, is BDLLFX regime. It contains bedaquiline, delamidine, linezolid, levofloxacin and clofazimine. Actually, all these 5 drugs are not to be used simultaneously. What they say, depending on the quinolone susceptibility. If quinolone is susceptible, that MDR-TB, we have to go for only 4 drugs, drop the clofazimine. If quinolone resistant, drop levofloxacin and go for other 4 drugs, PDLC. And this is the most popular regime we must have heard in media, BPLM regime. This one extensively validated in African countries, in South America, even in India. It's mainly recommended for adolescents and adults. For pediatric age group, yes, if BDLX cannot be used, we can use. And here also, if fluoroquinolone resistance, quinolone resistance is there, we can drop moxifloxacin and use as a BPL regime. And what about HRTB, the INH alone resistance? Here you have to use for 6 months continuously without any change. REZL, that is rifampicin, ethambutol, pyrazinamide and levofloxacin, 6 months continuously. And here one can add INH, because what they say, even when there is resistance, if you give INH, it improves the success of the treatment protocol. What about 9-month regime? Still it is there. WHO recommends it's only for those who are having some problem, like there is a resistance to bedaquiline or linezolid, or intolerance. As I told, linezolid longer course of treatment can cause a lot of side effects. So if you want to exclude, what they say, you continue the 6-month course without this drug for additional 3 months. That is only recommendation now. What about MDR TB, the one XDR and others? We have to give it for 18 to 20 months, the duration, not 24, 36, it's for 18 months. And it's for extrapulmonary TB and TB meningitis. There are 3 group of drugs are there, A, B, C, right? So what to do? 4 drugs we have to use. Take 3 from the group A and 1 from the group B. If you take 2 from group A, take 2 from group B, and if you cannot take any one from, you cannot make it 4 from group A or B, you add 1 from the group C, right? That is the current recommendation. So what is the evidence for all these? These 2 trials, the pivotal trials, I could say, BTB and NTB trials, they were in support of the shortened regimes. They say the evidence was very, very strong, with a very high treatment success rates and very good safety profiles in children more than 3 years, right? What about the recent recommendations for LTBA and TPT? No INH monotherapy. Please, please, postgraduates, please, this one you to remember. For high prevalence areas, no INH monotherapy. This is only for low prevalence area for US and other countries. For us, no INH monotherapy, it's only 3HR. And 3 HP for children who are taking ART, and 4R, that is 4 months of rifampicin if there is INH resistance. And this is the most important recommendation. They say now we are now in a tech world, tech savvy world. We have to use all these things to increase the compliance. Digital pill boxes we have to use. WHO recommends, and Indian government also is going to give these the pill boxes which can chime every day at a particular time, so that the patient remembers to take the tablet, and it also counts number of tablet inside, how much are used. And the digital adherence tools, like previously they go, the dots, all those dots is now taken out. Now 99 dots and watts. What is 99 dots? It's nothing but a custom packaging. When they open the tablet, that slip flap has a hidden number inside. What I have to do, take the tablet and then send the number by SMS or by WhatsApp. And Watts video observed treatment, that is the currently recommended one. No need to go there and do it. They can do it by video Watts. What about vaccine? Our time-tested old BCG still holds good. There is no recommendation for changing it. BCG at birth remains standard. But now there is talk of giving prime and booster dose with subunit vaccines, or a lot of research is going on to improve that BCG strain which have been used for the last 100 years. So these 3 are the only promising candidates. The first HEHR and H107. These 2 are to be used as a prime one, booster dose. The first one would be our current BCG, and followed by later with HEHR or H107. And if holds good, this TNBCG or SAP-M will come and replaces our old BCG in another 5 to 10 years, because it shows better immune response than the current BCG. Okay, coming on to the summary. In diagnosis, rapid NOTs are the nucleic acid amplification tests are the cornerstone of pediatric TB diagnosis. All those smear culture, smear Zeal-Nielsen and all are gone. And gastric aspirate and stool, they are the key specimens for children. And reflex testing and NGS is a must. It has to be done for each and every case which becomes positive with the LC-NAT. And regarding treatment, there is a 4-month treatment for non-severe drug-sensitive TB. And for drug-resistant, there is a 6-month regime now. That is the one recommended. No need for 12 or 24 months. And for ensuring compliance, we have to use all those FDCs and digital support tools. These are my references. Thank you very much. Thank you for this opportunity. Thank you.
Thank you, sir.
Thanks, sir. Hello.
Yes,
Hello.
yes, sir.
tuberculosis. I would like to ask one question to you.
Yes, sir.
What your experience about the urine analysis in diagnosing the tuberculosis?
So I asked the pulmonologist, sir, we are not doing it. As I told, it's not a point, it's a point of care test only for HIV positive children who are having TB. So in them only the sensitivity specificity is high. It's not to be used as a routine test for our children. So.
Okay, it's open for the questions and comments.
Sir, can I make a comment, sir?
Yes, ma'am.
So this is especially the drugs that you have mentioned, DLM and bedaquiline and linezolid. So I think it's very important because I'm finding that a lot of the, in the community, linezolid is being used as a first-line drug for treating other infections. So I think the message has to go out loud and clear that we have to protect all these drugs. We were talking about rifampicin earlier. I think now we have to also include linezolid along with that and save it up as a tuberculosis drug.
Definitely, ma'am. Linezolid should not be used in the community for first line as a first line drug.
Thank you, sir. With that, we will be proceeding to the next speaker. Kindly be seated on the dais, sir. I would like to introduce the next speaker for this session, Dr. K.S. Murthy, sir, Senior Consultant and Pediatric Cardiac Surgeon of vast experience at KMCH, Coimbatore. Sir has been instrumental in advancing dedicated pediatric cardiac services in the region. He will be speaking today on challenges, advances in the road ahead for pediatric cardiothoracic surgery.
Respected chairpersons, dear friends, at the outset I would like to thank the organizers for giving me the opportunity. Today I will be talking on dedicated pediatric cardiac services in India, challenges, advances and the road ahead. Look at the history. Helen Tossing, she was the pediatrician working in Johns Hopkins. She used to see a lot of children with cyanosis and congenital heart disease. She knew that cyanosis is because of the decreased pulmonary blood flow. So she requested the Blalock, is the general surgeon, why don't you do some surgeries to increase the pulmonary blood flow? So he has done the Blalock tossing in 1944. To their surprise, that cyanosis disappeared, they started living longer. This encouraged her that, to pursue her career as a pediatric cardiologist, and she has written a first textbook on pediatric cardiology, and also she was the first woman president of American College of Cardiology in US. That is how we are so close to the pediatricians, and that's what I wanted to stress on that. The evolution of the pediatric cardiac surgery, the earlier days, the adult cardiac surgeons used to perform the pediatric cardiac surgery. The dictum is like, child should be 5 years or 10 kilograms. And also they used to share the infrastructure from the adult cardiac program. But if you look at that congenital heart disease, by 5 years of age, 50% of the children, they die, or whoever surviving the rest of the 50%, 20% of them having ICMNGR become inoperable. So how to address this issue? That is how the dedicated pediatric cardiac services started in 1960 in USA, where they can operate younger children, that neonates and adults, to save this unfortunate disease. And so in India, from 1990, we started dedicated pediatric cardiac services. Two visionaries which is worth mentioning. One is Dr. K.M. Cherian in South, in Madras Medical Mission, and Professor Venugopal in the North from All Institute of Medical Sciences. They are the key personnels who started this dedicated pediatric cardiac services. So I am one of the first generation pediatric cardiologists in the country. So look at the incidence, 8 per 1,000 live births. In 1.2 billion population, at least 2 to 2.5 lakh children are born with congenital heart disease. Unfortunately, less than 10% of the children having corrective surgery. Rest of the children, either they are suffering or dying with congenital heart disease. Of course, the infant mortality is very high when compared to developing countries in our country. And the reason being the malnutrition, infectious disease, the third is the congenital heart diseases. But in developed countries, the first two factors are abolished, and mainly the congenital heart disease. And what is the status of the pediatric cardiac services in India? American College of Cardiology recommendation is 1 pediatric cardiac center in 5 million population, but India needs at least 280 centers. But at least we have maybe the 20 or 25 centers in the whole country. One pediatric cardiac surgeon in 3.5 million population in USA. That means you need to have 400 pediatric cardiac surgeons in the country. We may be less than 40 pediatric cardiac surgeons in the country now. And also there is a disparity in distribution. And south and some part of the western India and some part of northern India, we have good pediatric cardiac centers. But the middle part of India and also the western part of India and the eastern part of India, hardly we see any pediatric cardiac centers. And also these cardiac centers are mainly located in metros and also the big cities, not in the B-class cities. So why you should be separated from adult cardiac unit? As you know that children are not miniature adults and the physiology entirely different because of the tissue immaturity, increased inflammatory response after cardiopulmonary bypass. They require judicious fluid management and the energy requirement is high and that body cannot handle the metabolic acidosis and alkalosis like adults. Their immunity is less. If they stay in the ICU for a longer period, they catch up infection. So if you have a dedicated pediatric cardiac services, they can do more number of cases, thereby increase the surgical skills and get excellent results. So why you don't see many pediatric cardiac surgeons in the country? Because it is a highly skilled job, technically demanding. There is long hours of hard work and scarcity of the committed people, and the safety margin is less. Once you operate, you have to stay with the patient in the ICU till they stabilize, and less monetary benefits. And now that another term called work-life balance, it's not possible for a pediatric cardiac surgeon. So it is an intellectual paradox. The pediatric cardiac surgeon maybe is intelligent and skillful, but he's supposed to earn more money, but he has to go with a begging bowl to collect donations to treat these children. And how many people can do this sort of sacrifices? And if you look at that health economics, WHO is not included congenital heart disease in the health for all because it is a prohibitive cost. And the insurance also don't cover that congenital heart disease because it's financially not viable for the market. So how to address this issue? We have to improve the awareness among the public as well as the medical professionals, and we have to attract more young professionals to join the pediatric cardiac services and collaborate with the government schemes and an NGO, non-government organization to collect the donations to do surgeries, and the indigenization of the medical products, thereby you can reduce the expenses, and the innovative management. Multi-stage corrections like for complex congenitals, you can do in a single stage correction, and some cardiac conditions we can do that without cardiopulmonary bypass and beating heart. And intraoperative assessment, the complex congenital heart disease, you do that and intraoperatively assess your correction is perfect or not. If it is perfect, then only you shift the patient, otherwise correct then and there only, otherwise they'll have long-pronged ICU stay and they eat up of the resources. Nowadays we are doing that on-table extubation. At least 98% of the cases we extubate on the table. Thereby you can reduce this ICU stay and hospital stay. That is the innovations. So the incidence of congenital heart disease, as I said, 8 per 1,000 live births. Mainly the 1/3 of the cases ventricular septal defect. This is where if you manage how to do the ventricular septal defect management, then most of the congenital heart diseases you can manage. There are different types of ventricular septal defects. Laser is not working. Okay. This common is that perimembranous VST, then inlet VSTs, outlet VSTs, muscular VSTs. Why I'm talking about it? Because I have seen a lot of children, grown-up children come with Eisenmenger syndrome. Some of these children's parents are educated, and when I ask them why you delayed so much, they say that I contacted the doctor, but the doctor said the VST get closed spontaneously. That was the reason we waited. But unfortunately, the doctor given a wrong advice. it is unfortunate that the child and the parents have to suffer for that. If you look at the natural history of the spontaneous closure of the VST, if you have seen a child with 1 month of age, that VST get closed spontaneously, 80% chances were there. The same child you have seen at 6 months of age, that incidence reduced to 50%. At the age of 12 months, the incidence reduced to 25%. And more older than 1 year, the VST rarely get closed. Some of the VSTs like large perimembranous VST, supracrystal VST, malaligned VSTs and conotruncal VSTs, they never get closed. So you cannot generalize the spontaneous closure. You should be aware when to say the spontaneous closure. I refer to the pediatric cardiologist and cardiac surgeon. And this is another common congenital cardiac anomaly, AST. Most of the ASTs can be closed with the device, but sometimes this device is not possible. This AST can be closed with posterior thoracotomy as a cosmetic incision, especially this is useful for the girls. So, what are the indications for surgery and when to do what sort of surgery? The rule of thumb is presence of congenital heart disease itself is indication for surgery or intervention. Neonatal corrections are indicated, conditions like transposition of great arteries, duct-dependent systemic circulation, duct-dependent pulmonary circulation, obstructed TAPVC, severe coarctation or interrupted aortic arch. Why you have to do in neonatal period? If you don't operate them before 1 month of age, 90% of the children, they die. So the infant corrections are indicated, the conditions like VST, TAPVC, complete AV canal, truncus arteriosus, and aortopulmonary window. But no, it is ideal age is 3 to 6 months of age. If you operate them before they develop pulmonary arterial hypertension, it is like you are giving like a cure. Cure is longevity and also the quality of life as good as normal children without any medication. And once you operate in delayed cases after they develop pulmonary arterial hypertension, they will have premature death, more of a palliation rather than cure. And preschool corrections are indicated, less severe form of congenital heart diseases like AST, moderate size VST, double outer right ventricle, PDA, coarctation, tetralogy of Fallot, single ventricle pulmonary stenosis, and the restly where conduit procedures are required. So almost all cases should be operated before they go to school, young age, and low birth weight should not be a risk factor in our experience. So what are the advantages of early correction? You can avoid repeated hospitalization, prevent complications like pulmonary arterial hypertension, prevent complications cyanosis. So they can have early normalization of cardiovascular physiology, life expectancy is like near normal. They have physical growth and prevent emotional instability. So I will talk briefly about my experience and my contribution in the pediatric cardiac services. And this is the one technique. This is a very complex congenital heart disease with a hypoplastic arch and with intracardiac anomalies. And usually they do in 2 stages procedure, but I divided a new technique, a single stage correction and without circulatory arrest. My results were published in the Asian Annals. This is another complex congenital heart disease where this is tetralogy pulmonary ataxia and major aortopulmonary collateral arteries. There is no pulmonary blood supply from the right ventricle. The lungs are getting blood supply from the aorta. See, this is the right aortic arch. Left lung is supplied by the one major aortopulmonary artery coming from the ascending aorta, and 2 MAPCAs are coming from the descending aorta, supplying the right upper and lower lobe. Another MAPCA from the left subclavian artery, crossing all the way to the midline and supplying the right lower lobe. For this sort of patients, many surgeons can't do this operation, but even if you do that, at least 3 stages are required. But I have adopted a single stage correction, and before going on bypass, we disconnected all the major aortopulmonary collateral arteries and see longitudinally we incised, reconstructed into a new pulmonary artery, anastomosed the opposite side of the pulmonary artery and close the VST, put a RV2PA conduit, a single stage correction. This is the post-operative echo. It is like a normal heart. So our early results are published in the Asian Annals of Thoracic Surgery, the American Journal. My midterm results I presented in European forum, that the same thing was published in European Journal. And I have a largest series in the country. So I have written a chapter in Advanced in Cardiac Surgery in Mosby publication. This is another new technique and Al-Kappa, anomalous left coronary artery coming from the pulmonary artery. And this is the transposition of great arteries. You know that arterial switch operation, you have to translocate the coronary arteries, which is 1 millimeter size. But I devised a new technique without translocation, reallocating the coronary arteries into the neopulmonary artery. And this can be done without much risk. This is called Dr. Murthy's technique. And this is another complex congenital cardiac anomaly, transposition of great arteries with single coronary artery. Both right and left coronary artery arise from the single coronary ostium. So various techniques I have described, but with this technique, the at least mortality is about 20 to 25%. But I devised a new technique without coronary relocation and the cutting the flaps and going around that. And we can do this anatomical correction. And I have done more than 25 cases without any mortality. This was published again in European Journal. And this is another complex congenital cardiac anomaly, double outer right ventricle. Usually DORV, there will be 70% of the aorta arises from the right ventricle. And here, both aorta and pulmonary artery arises from the right ventricle. There is no left ventricular outflow. And this was first I recognized, and I evolved a new model how to recognize preoperatively and how to correct intraoperatively without causing left ventricular or right ventricular outflow obstruction. So this was a new terminology. Because of that, this diagram was published in the European Journal cover page. This is another anomaly, the tetralogy with the pulmonary ataxia. For this, you require a valve conduit, and these are the homografts. This is pulmonary homograft and the aortic homografts. Like once after death, how you collect that eyes for the donation, we also ask the heart for donation. These heart we take it from the dead bodies, and we dissect the walls and sterilize into antibiotics. And we put store them in a homograft wall bank with liquid nitrogen minus 170 degrees centigrade. And once the patients appear, then we take a suitable size homograft from the wall bank and we implant them. This homograft costs you about, all this procedure about 10,000 rupees, but is commercially available wall conduits cost you about 2.5 to 3 lakhs. So this is one of the children. This is the youngest homograft I have implanted. 40-dose child had a brain dead because of the cerebral bleed. The parents are kind enough to donate the heart. We taken out both the pulmonary artery and aorta, implanted on 4 months old children. The youngest children had homograft walls in the country. And I have devised a new circuit. And this is a single ventricle. Usually they require cardiopulmonary bypass to do the complete repair. But this circuit avoids the cardiopulmonary bypass. Thereby, on a beating heart, we can do the same surgery. Thereby, you can avoid long hospitalization and save money for this procedure. 3 days after I joined in KMCH Coimbatore, I got a call from the PICU. This is the one patient, 30 weeks of premature baby, 3 weeks of ICU stay. Instead of gaining weight, they lost weight from 1.3 to 1.2. They're not able to ventilate, extubate the patient. And the diagnosis was like he has a congenital heart disease, AST, VST, and large PDA. At all 3 levels, there is a shunt, increased pulmonary blood flow with severe pulmonary arterial hypertension. So I told that neonatals, unless we address the congenital heart disease, you cannot extubate. So then we explained to the parents. Parents, they agreed for surgery. So this is the intraoperative photograph, the video. This is a pulmonary artery so much dilated with pulmonary arterial hypertension. Heart is grossly dilated. The PDA is as 4 millimeters, as big as the descending thoracic aorta. So we close the PDA, and we close the PDA under the pulmonary artery branding to control the pulmonary blood flow. After that, and see that hemodynamics is improved, and the pulmonary artery pressure was systemic before. Okay, then come to normal. Then we could extubate the patient around 36 hours after surgery, and so this scenario, case scenario tells that the most important thing in the team is the pediatrician. First you have to diagnose or suspect the congenital heart disease, thereby we can save this sort of children. And the pediatrician plays a very important role for this identifying this congenital heart disease. So my 30 years experience, and I have done about 13,500 cases. My experience is like 0% in the and straightforward cases, less than 10% in complex congenital heart disease. This is the transpositional gate arteries. We have done arterial switch operation, where that aorta comes from the right ventricle and the pulmonary artery from the left ventricle. And this is a very complex, technically demanding surgery, where the coronary arteries, we have to make buttons and see that this is like 1 millimeter size coronary artery buttons. So we have to transplant into the neo aorta, and this is the right coronary artery sutured to the neo aorta. Just patient will wait. It's a 6-hour surgery. Just I'll finish in 30 seconds. Okay. This. So this neo aorta is the distal aorta. So the aorta comes from the left ventricle now. This is called the anatomical correction. And the pulmonary artery you have to augment with the pericardial patch. And this is anastomosed to the distal pulmonary artery. The pulmonary artery now arises from the right ventricle. This is after completion of the procedure. And since this neonate, they have an inflammatory response and edema, and we cannot close the chest, and we have to put a patch and, to close the chest. And this is a peritoneal dialysis to remove excess fluid from the extracellular compartment. And see that good hemodynamics of the surgical correction. So I end my talk with this video. The 15-day, this same child, 15-day-old weighing 2.2 kilograms, and this is very precious baby for their parents, 8 years of marriage, and they got this product of assisted reproduction. The father was an Air Force pilot. They flew from Nagpur to Hyderabad, and I operated the child. See that physical and mental development as good as a normal child. This is the beauty of the pediatric cardiac surgery. Thank you very much for your attention.
Hello. Thanks, Dr. Murthy.
Thank you, sir.
I would like to ask one question to you. What are the indications for the VSD closure, and when you should operate? This is for the information for pediatricians actually.
Yeah.
When to refer to you rather?
Yeah. See, if the patient develops, he has a long, very large VSD, this is indication for surgery. And before if they gradually developing pulmonary arterial hypertension, and also the patient, you are not able to control congestive heart failure with decongestive therapy, they are the early indication for the surgical closure. But as I said, before they develop a pulmonary arterial hypertension, if you close, actually we are doing more good, because it is more of a cure. There is longevity and quality of life as good as normal children. Even you delay it because of the thinking that is risk, but once they develop pulmonary arterial hypertension, even though done a good correction, but they have a premature deaths.
Thanks.
Thank you, sir.
Thank you.
On behalf of the organizing team, we extend our sincere gratitude to the panelists and the chairperson for putting together a great discussion on such a vast spread of topics. I invite our volunteers to facilitate the prize giving session. I request our chairperson, Dr. Kamlesh Srivastava sir, to felicitate our speakers with a memento. I request Dr. Murthy sir to felicitate our chairperson, Kamlesh sir, with a memento. Thank you all. With that, we are proceeding to the final session for today, a panel discussion on the art and science of pediatric practices, lessons for everyone. It is my privilege to introduce the moderator for this session, Dr. S. Sunil Srinivasan sir, a dynamic pediatrician and former president of IAP Tamil Nadu in 2018. He currently serves as Chief Happiness Officer at Ma Kaveri Hospital, Trichy. Beyond medicine, he wears many hats, an international Tai Chi instructor and an AI coach, bringing a unique blend of science, wellness, and innovation to everything he does. I invite you onto the stage, sir. I would like to introduce the panelists for the session and invite them onto the stage. Dr. M. Ismail sir, Dr. R. Selvan sir, and Dr. Aram Chandal sir.
Good morning. Can I request all of you to come in front, please? I'm going to give 5 chocolates, but I can't come all that way. So if you want chocolates, you can come in front. Your choice. We can start? So I sincerely thank KONGU PEDICON organizer, the boss of which is sitting here. So I think we can take some extra time. Boss ji? Okay, yeah, right, thank you. So I'll start with the quiz, okay? Now, our part of Podopore, tell me from which film it comes. I hope this opens. Thank you. Jailer. Who was the director? Very good. Thank you. Great. Nelson textbook தெரியுதோ இல்லையோ நெல்சன் நல்லா தெரியுது. So nice, so nice. அதாவது ஜெயிலர் படத்தில் ஒரு 3 சூப்பர் ஸ்டார். நான் எப்படி இவ்வளோ பேர் 3 பேர் எப்படி சமாளித்தார் அவர்? ரஜினிகாந்த், சிவராஜ்குமார், மோகன்லால். ரஜினிகாந்த் ஃபஸ்ட் படம் 1975. சிவராஜ்குமார் 1974, மோகன்லால் 1978. அதாவது ஒரு 50 வருஷமாக தே பீன் சூப்பர் ஸ்டார்ஸ். அதற்கப்புறம் நிறைய நடிகர் வந்துட்டாங்க. பட் ஸ்டில் தேர் நம்பர் 1 சுப்ரீம். அவங்க ஊரில் அவங்க தான் பாஸ். ஸோ எனக்கு ரொம்ப க்யூரியஸ், எப்படி ஹவ் ஆர் தே பாஸ் இந்த அவங்க ஊரில் இருக்கிறாங்க? வாட் இஸ் த சீக்ரெட்? ஸோ நீங்கள் சொல்லலாம், நடிப்பு இருக்குது, திறமை இருக்குது, உழைப்பு இருக்குது, அண்ட் மனித நேயம் இருக்குது. ஆல் ஐ அக்ரி எவ்ரிதிங் தே காட். பட் ஆல் மெனி அதர் ஆக்டர்ஸ் எவ்ரிதிங் தே ஹேவ். பட் these superstars ஒரு 50 வருஷமாக in a volatile industry like film industry, 50 years to, it's amazing. So today I got 3 superstars with me. Please give a big round of applause to all the 3 superstars. And or almost 30 years மேலே practice, all of them. roughly 30 billion. So, இதுக்கப்புறம் pediatricians have come, but இருந்தாலும் அவங்க ஒரு தனி என்ன சொல் நெய்வேலி அப்படின்னா செந்தில். I mean, this is synonymous. They become synonymous. நெய்வேலி means செந்தில். மேட்டுப்பாளையம்னா இஸ்மாயில். என்ன சொல்றீங்க? ஈரோடுனா செல். I mean, I can't think. My other amazing person. It is a real. I am just like Nelson trying to balance 3 superstars. And so let us start. So I asked them, அப்பா வளவளன்னு பழசெல்லாம் பேசாதீங்க. Tell us your secret. What makes you great? What has made you great over all these years? And let us start with Dr. Selvan. நான் CV எல்லாம் போடலை. I mean, CV போட்டால் இன்சல்ட் பண்ணுற மாதிரி. நான் ரஜினிகாந்தை கூப்பிட்டு அவரை பயோகிராஃபி போட்டால் I mean, it doesn't make sense. I mean, they're all superstars. So no CV here. But let us start with Dr. Selvan. You can come here. Dr. Selvan, please.
Yes,
இங்கே வரீங்களா? You can have. And செல்வன் பற்றி ஒரு வார்த்தை அப்படின்னா இன்னோவேஷன், புதுமை. Especially bringing all the pediatrics to the parents. So much innovative ideas he has got. So Dr. Selvan, please share with you 4 of your secrets. You have 8 minutes. Thank you.
So thank you very much for giving me this opportunity. Be there, be on time. Punctuality, very, very important. நேரத்தில் சொன்ன நேரத்தில் நாம் இருக்கணும். நாம் இருந்தோம்னா நம்மளுக்கு முன்னாடி நம்ம ஸ்டாஃப் இருப்பாங்க. சில நாளைக்கு சொன்ன நேரத்துக்கு முன்னாடியே போயிடணும். அப்போ தான் நம்ம ஸ்டாஃப் செய்கிற கலைபுரம் கும்மாளம் எல்லாம் கண்டுபிடிக்க முடியும். ஸோ ஆல்வேஸ் பி ஆன் டைம். ஸ்டாஃபை ட்ரெயின் பண்ணுங்கள். நீங்கள் புறப்பட்டு வந்துட்டு இருப்பீங்க, அந்த நேரம் பார்த்து தான் தேர் வில் பி அன் எமர்ஜென்சி. உட்கார வச்சுருவாங்க. உட்காருங்க டாக்டர் வந்துட்டே இருக்கார். So staff should be able to identify whether the patient has got a problem. She has to either inform the emergency person or get back to you or do something which you have already trained them. Third thing is minimal waiting. In the earlier practice la poi ukkandu earlier time பண்ணும்போது patients need not wait for some time. For a consultation practice, many places you go 10 appointments, it is not a problem at all. Many places we have people coming in. அப்படி வர பார்த்துட்டே இருந்தீங்கன்னா it is not going to be really a problem for all of us. Patient, all of us can treat a patient. Anyone can treat a pediatric patient. Even if you don't treat them, most of the diseases go away on its own. So நம்ம treatment கூட what we should do is we should educate. பேரண்ட் வர்றாங்க, டயட்டில் பெரிய அட்வைஸ் இருக்கும். இன்னைக்கு பீடியாட்ரிஷியன் தான் we are giving the minimum diet advice. Everyone including housewives, parties, tatas, everyone gives advice through Instagram, reels, shorts, எல்லாருமே. So at least for us we should use some kind of posters which are being from IAP or videos. You can make your videos. You can just in your time, in your clinic you can take a video of whatever the topic you want the patient to be told. அவங்க கேட்குற கேள்வி எல்லாம் கலெக்ட் பண்ணி வச்சிங்கன்னா there are only 20 or 30 questions, common questions. You can have these 30 common questions answered by you, and you take a video with your mobile phone and you can upload it in your clinic outpatient waiting area in the TV. So most of the time you can have it. Or you can have a booklet like a smart book which is available from IAP-TNSC website. You can download it. You can print it using your clinic address also. You can use other videos from Global Health Media or IIT Mumbai. Or you can use any kind of a posters which you can put it outside. You can make your own posters. It is very, very useful. And you make the patient, when they go out of your consultation, they should be enriched with little more knowledge than about the disease. Whenever they come in, you ask them the problem, then you always, before you discharge, before you send them out, please give them one advice by which they can avoid the repeat infection. That's very, very essential. Not only getting the patient into the chamber and telling the patient not to come. If a patient comes with a diarrhea, you treat them, but you always insist them avoid a bottle feeding. And if the patient comes with malnutrition, there is no point in just giving them a tonic. You have to counsel them with the nutritional advice. If you can't do it, use your staffs, use the education materials available online or in your clinic, and you can teach them. It is very essential. It's one of our duties. Vaccination, that is a big, very good topic was there. That is, you can use a digital reminders. That's very essential. I'm getting more vaccines now for in my clinic because we have an Axon app. You can use either Axon app or your clinic Word file, or you can use some reminder apps available in the Play Store that sends the patients frequent reminders. Sometimes, even if you use your vaccine card, that is adequate. Many times when the child crosses 2 years, most of the patients don't remember about other vaccinations. They think, sir, 5 vayas, 2 vayas ஆயிடுச்சு மறந்துட்டோம் சார் அவ்வளவுதான் நினைச்சிட்டோம். So you can use either an app or a digital reminders or a chart. And when you give a vaccine, strict cold chain is very, very important. That's essential. The previous session in which the speaker spoke about, it's very good, and you have to follow all the points which she made it out. So she has covered most of the practices for safe immunization. Few things are always check for which vaccine the patient has come, whether the same brand, if available, use it, recheck before opening it. Always take out and keep out the vaccines which have a short expiry out of the fridge. And please tell the patient when to come next, and always tell them what are all the things to expect, and have any resuscitation tray with you before you give the vaccination. Always train your staff about the vaccines, about the side effects, when to come, when they need to wait. Sometimes நம்ம என்ன சொல்லுவோம் 6 மாசம் கழிச்சு வாங்கமோ, நம்ம ஊர்ல 6 months, 5 months is over, they consider it as 6 months. So always mention it has to be in days. 9 months na 270 days க்கு அப்புறம், 1 year முடிச்சதுக்கு அப்புறம், first birthday முடிச்சதுக்கு அப்புறம், always make sure that the patient knows exact date. You can always use these apps or the Axon software or whatever you are using it to tell them in advance. Last one is put the patients first. I always feel we should put patients' interest in the first place. We should put ourselves in their position. When you ask the patient to do some test, or you are going to give a medicine, or you are asking a question, or you are so much worried, or you think, why ஏப்பா திருப்பி இதுக்கே வந்துட்டு இருக்க, அதே சளின்னா 5 நாள் இருக்கும், காய்ச்சல்னா 10 நாள் இருக்கும், வயிற்று போக்குனா 3 நாள் இருந்துதான் இருக்கணும். Always put yourself in the patient's position, parent's position, and just think as a parent, what will you react, how will you react. Then if you take that half a second extra time, you know their emotions, then you will respond to them clearly, slowly, and you accept their doubts and you clear them. Specialist consultation, if there is. We had a patient recently, the child had a functional constipation with a urinary problem. So we treated the patient. They came first review, second review also patient had the same issue. And usually we think, என்னம்மா திருப்பி அதே தொல்லை, இது வந்து it will take 6 months time. But if we think back, if you ask the mother to explain, again they had the same issue. You get the second opinion, you know there is a problem, there is a neurogenic bladder, there is a condition, there is a neuroblastoma affecting that. So you get the diagnosis and treat them. Timely referrals is very, very important. I used to have a referral doctor to me, always he will send the patient on Saturday night and he will tell me, sir, சனிக்கிழமை ராத்திரி நான் தூங்க போகணும், அதுக்கு தான் உங்களுக்கு இந்த பேஷண்ட் அனுப்பிச்சிருக்கேன். So don't be like that, sending the patient on Saturday night, and don't keep the patient till the last minute. Many times we think, அங்க போய் என்ன பண்ண போறாங்க, நாம பண்றது தான் they are also going to do that. So we always try to, in the early, especially in the early part of our career, we think that it is, அங்கேயும் அதே தானே பண்ண போறாங்க, same medicine, same treatment, same monitoring, நாம் பண்ணிடலாமா. But there are now not only the medical legal obligations, now there are people who can do better job than a general pediatrician. So always refer them at the earliest and always be cost conscious. Still, in a peripheral practitioner, always be cost conscious. Don't always jump into the new drugs, jump into always admitting the patient for a one-day fever. Even if the patient says we have got insurance, sir, அதனால admission போடுங்க சார். அட்மிஷன் போட்டிங்களா, give the fever ஜாஸ்தியாக எழுதி கொடுங்க சார், ஹிஸ்ட்ரி ஜாஸ்தியாக பண்ணுங்க சார். Then you will end up doing which is whatever is wrong. So please try to be very cost conscious in a routine practice and treat the patient as and when needed only.
Hello.
Thank you very much.
Thank
Thanks
you,
for your time.
Thanks, Dr. Selvan. Thank you. We were struggling with the mic, but anyway, thanks for finishing on time. And now I invite the boss of today, this KONGU PEDICON, Dr. Ismail. And again, I don't know, he's the son of the soil. But if I have to describe Ismail in one word, it is joy. Pongum Magilchi. The Basha படத்தில் படுவாங்க, அவர் சிரித்தால் சிரிப்பழகு, அவர் நடந்தால் நடையழகு. அது மாதிரி whatever it does with all joy and energy. Dr. Ismail, share with us 4 of your secrets.
Thank you,
Northern
Dr.
Director, Nelson, and 8 minutes ago. Thank you.
Thank you, Dr. Sunil. Thanks, the organizers, for giving me the opportunity. My respects to my beloved teacher, Dr. Ramsamy. என்னதான் சூப்பர் ஸ்டாராக இருக்கணும்னு சொன்னால் கூட சூப்பர் ஸ்டாருக்கு ஒன்றும் தெரியாது. பின்னால் இருக்கிற டைரக்டர் ஆட்டி வைக்கிறது தான் அவர் ஆடுவார். சூப்பர் ஸ்டாரோட வேலை என்ன? ஒவ்வொரு படத்துக்கும் படத்தை நீட்டாக கலெக்ட் பண்ணிவிட்டு அவர் பாட்டுக்கு அடுத்த படத்தை பார்த்துட்டு போயிட்டே இருப்பார். சிமிலர்லி நம்மளோட pediatric practice is not dependent on academics alone. It is not the knowledge alone which will make you a good practitioner. It is ultimately the peer, public relationship, and how you present it yourself to the public, how you articulate, how you communicate, how you give confidence, and how you take it account, how the conversation happens in your clinic. That is very important, and that is more vital in your practice. ஒரு ப்ராக்டிஸ் சிறப்பாகணும்னா குழந்தைய ரசிக்கணும், அம்மாவை மகிழ்ச்சிப்படுத்தணும், அப்பாட்ட தெளிவாக பேசணும், தாத்தா பாட்டியை சந்தோஷமாக வச்சுக்கணும். அவ்வளோதான் மெசேஜ். பட் த ப்ராப்ளம் இஸ் half of the time we don't listen. ஜிஹெச்சில் இருக்கிற ப்ராப்ளம் சொல்லுவாங்க. ஐம் நாட் பிளேமிங் த ஜிஹெச் டாக்டர்ஸ். ஓவர் க்ரௌடாக இருக்கிறப்போ 1 மினிட்டில் ப்ரிஸ்கிரிப்ஷன் எழுதி கொடுத்துட்றாங்க. நாங்கள் என்ன சொல்கிறோம்னா அவங்க கேட்குறதில்ல. சார், நான் தலைவலின்னு சொன்னேன், வெளியில் வந்து அந்த ஃபார்மசி தெரியாமல் எத்தனை வாட்டி உனக்கு பேதி ஆகுதான்னு சொல்லியிருக்காரு. மாத்திரை பேதிக்கு எழுதி கொடுத்துருக்காங்க சார். ஸோ த கம்யூனிகேஷன் மேட்டர்ஸ். அது என்னென்னா ட்ரக் ஒன்று கொடுத்துருக்காங்க, அந்த 1 மினிட் இல்லை 30 செகண்டில் டெசிஷன் இஸ் டேக்கன், ப்ரிஸ்கிரிப்ஷன் இஸ் கிவன். பட் சிமிலர்லி நான் கொஞ்சம் பீக்கான 100 கேஸ் 120 கேஸ் எல்லாம் பார்த்துட்டு இருக்கிறப்ப சமயத்தில் எனக்கு அப்படி தான் தோணிருக்கு. என்ன ஆகுன்னு சொன்னால், ஃபஸ்ட்டு ப்ரிஸ்கிரிப்ஷன் ஒரு ஆர்டர் ஷீட் கொடுத்துருப்போம், லேபுக்கு அனுப்பிச்சிருப்போம். ஒரு 10 பேஷண்ட் கழித்து லேப்லேருந்து ரிசல்ட் வந்திருக்கும். அந்த பேஷண்ட்டு நம்ம மனசில் என்ன டயக்னோசிஸ் இருந்ததுன்னு நமக்கு மறந்து போயிருக்கோம் சமயத்தில். வி டோன்ட் நோ வாட் வி ஆர், எதுக்கு கொடுத்தோன்னு தெரியாது. கொஞ்ச நேரம் அப்படியே சமாளித்து என்னம்மா பிரச்சனை ஏதுமா பிரச்சனை அப்படி கேட்டு அப்புறம் ஒரு ஓரியன்டேஷன் வந்து அப்புறம் தான் அது நடக்கும். Why this happens is because we don't allow the patient அவன் ஃபுல்லாக சொல்கிற வரைக்கும் கேட்குற பொறுமை நம்மக்கிட்ட இல்லை. ஸோ ஃபஸ்ட்டு சக்ஸஸுக்கு என்னோட வழி என்னன்னு சொன்னால், லிசன் கேர்ஃபுல்லி. அந்த நல்லா கேட்டு உங்கள் மனசில் ஏற்றிக்கிட்டிங்கன்னா கிளாரிட்டி உங்கள் மைண்டில் வரும். அண்ட் தட் கிளாரிட்டியோட நம்ம பேசணும். ஐ ஆல்வேஸ் ஹாவ் அ ஹேபிட் ஆஃப் சேயிங், சிம்பிளாக நான் எல்லா பேஷண்ட்டுக்கும் சொல்கிறது, அடிக்கடி சளி ரிப்பீட்டடாக வருது, ஏன் சார் இப்படி என் குழந்தைக்கு மாத்திரம் வருது, என்னை போட்டு டார்ச்சர் பண்ணுறப்போ, நடக்கிறப்போ, போடுறப்போ, கார் ஏறுறப்போ, கல்யாண வீட்டில் சோறு திங்கிறப்போ, சார் 1 நிமிஷம் சார் என்னம்மா பிரச்சனை, சார் நேற்றுக்கு வந்தேன் சார், முந்தா நாத்து வந்தேன் சார், உங்கள் கிளினிக்கில் அப்பாயின்மெண்ட் இல்லைன்னு சொன்னாங்க சார், இப்போ தான் சார் உங்களை பார்த்தேன். ஏன் சார் என் குழந்தைக்கு மாத்திரம் சளி வருது? அம்மா பிரியாணி ஆறிடுமா. தட் இஸ் வாட் அவர் மைண்ட் செட். பட் என்ன சொல்ல வரேன் அப்படின்னா, நான் ஒரு ஸ்டாண்டர்டான ஒரு ப்ரோட்டோக்கால் வச்சுருக்கேன். அம்மா உன் குழந்தைக்கு மூக்குக்குள்ளே காற்றடிச்சு ஒரு கிருமி போகுதுமா, இல்லை ஒரு தூசி போகுதுமா, அந்த மூக்கில் இருக்கிற முடியும் அந்த மூக்கில் இருக்கிற லைனிங்கும் அது மேலே பட்டுச்சுன்னா தண்ணியை கொட்டுது, அந்த முடி இரிட்டேட் ஆகி தும்மல் வருது. இதுக்கு நீ என்னம்மா பேர் வச்சுருக்க? சளி சார். அதே கிருமி அதை தாண்டி நுரையீரலுக்குள்ளே போகுதுமா, அந்த நுரையீரல் நாய் மாதிரி குறைச்சி அந்த கிருமியை வெளியே தள்ளிடுது. அதுக்கு என்னம்மா பேர் வச்சுருக்கிற? இருமல் சார். அதே மாதிரி வயிற்றுக்குள்ளே போகுது, வயிறு அலசி அந்த ஆசிடெல்லாம் பட்டு எல்லாத்தையும் வெளியே துப்பிடுது. அதுக்கு பேர் என்னம்மா? வாந்தி சார். கீழே போய் அலசி வெளியே போயிடுது. அதுக்கு பேர் என்னம்மா? பேதி. இதையெல்லாம் மீறி அந்த ரத்தத்தில் அந்த கிருமி வந்து வளர ஆரம்பிக்குது. ரத்தம் சூரசம்ஹாரம் மாதிரி திடீர்னு கொதிச்சு அந்த கிருமியை அழிச்சிடுது. இதுக்கு பேர் என்னம்மா? காய்ச்சல் சார். இந்த 5 உன் கண்ட்ரோலில் இருக்கா? இல்லை. இந்த 5 என் கண்ட்ரோலில் இருக்கா? இல்லை. இந்த 5 குழந்தைக்கு தேவைப்படுமா? தேவைப்படும். அப்போ போயிட்டு வா. இட் வில் ஹேப்பன். 5 வருஷத்துக்கு இது நடக்கும். ஸோ வாட் ஐம் ட்ரைங் டு டெல் யூ இஸ், நல்லா லிசன் பண்ணிங்கன்னா யூ வில் கெட் இன்னோவேட்டிவ் ஐடியாஸ். டெஃபினட்டாக ஒரு இன்னோவேட்டிவ் ஐடியாவை வச்சு நீங்கள் 30 வருஷம் தாராளமாக ஓட்டலாம். ஸோ நெக்ஸ்ட் விஷயம் என்னென்னா, இன்றைக்கி லாஸ்ட் வீக் சார் சொன்னார் சூப்பர் ஸ்டாரு, சன் ஆஃப் த சாயில், டான் அப்படி இப்படின்னாரு. ஒரு பொண்ணு வந்துச்சு, கூட ஒரு அம்மா. இந்த அம்மா செட், இவர் தாண்டி உடனே ஹாஸ்பிட்டலில் கையில் எடுத்து எங்கிட்ட கொடுத்த மகானுபவன், காலை தொட்டு கும்பிடுறி. அதெல்லாம் ப்ராம்ப்டாக பண்ணிச்சு அந்த பொண்ணு. அதோட கையில் ஒரு குழந்தை. பிரஸ்ட் ஃபீடிங் பற்றி பிரச்சனை. என்ன பிரச்சனைன்னு சொன்னால், சார் அவள் குழந்தையோட நாக்கை கிழிக்கணுமா, அப்போ தான் பால் நல்லா குடிக்குமா, என்னமோ லாச்சிங் சரியாக பண்ணுறதுக்கு டங் டைன்னு என்னமோ ரிலீஸ் பண்ணுறோன்னு சொல்கிறாங்க சார். 75,000 ரூபாய்க்கு அப்பாயின்மெண்ட் வாங்கிட்டு வந்திருக்கா சார், கொஞ்சம் சொல்லுங்கள் சார், குழந்தை நாக்கை யாராவது கிழிப்பாங்களா சார்? நான் சொன்னேம்மா, இவ்வளோ சிவிலைசேஷன் தொடங்கி இவ்வளோ காலம் போச்சு, ஆடு மாடு நாய் பேய் எல்லாமே பால் குடிக்குது, எந்ததுமே நாக்கை கிழிக்கல, நீ ஏம்மா கிழிக்கணும்னு நினைக்கிற? அது ஒன்றுமே சொல்லலை. என்னை பார்த்து ஒரே ஒரு சிரிச்சுட்டு அவங்க அம்மாட்ட திரும்பி, ஐ டோல்ட் யூ நோ மாம், ஹீ இஸ் ஸோ அவுடேட்டட். இந்த ஆள்கிட்ட போய் என்னை கூப்பிட்டு வந்திருக்கியம்மா, நீ வேணா அப்போ நீ படிக்காமல் இருந்த, இந்த ஆள் இந்த நாலேஜோடு இருந்தால் அக்செப்டட். இப்போ நான் எந்த எறால இருக்கேன், இப்போ போய் வந்து நீ இந்த ஆள்கிட்ட கூப்பிட்டு வந்திருக்கேன். ஷி ஜஸ்ட் வாக்ட் அவே. சுனில் சார், சாரி டு சே, என்னோட சூப்பர் ஸ்டார் டம்மெல்லாம் அன்னைக்கு டொம்முன்னு கீழே விழுந்துச்சு. என் பேத்தி சொன்ன மாதிரி டங்குன்னு சொல்லுவா, அதே மாதிரி டொம்முன்னு போயிட்டேன் நான். அதே மாதிரி தான். ஸோ வாட் ஐம் ட்ரைங் டு டெல் யூ இஸ், people will provoke you, people will irritate you by verbally, body language, எல்லாத்துலேயும் நிறைய விஷயம் நடக்கும். ஸ்டே கூல், ஸ்டே கூல். ராகுல் டிராவிட் மாதிரி இருந்துடணும். எதை போட்டாலும் அடி பேசாமல் நிற்கணும். ஸோ தட் இஸ் அ primary request of a good pediatrician, is to, whenever you are provoked by the patient's word, எல்லாம் முடிச்சு வெளியில் போயிடுவார் தாத்தா. அங்கேருந்து ஓடி வந்து, சார் குழந்தைக்கு சாப்பிட என்ன கொடுக்கலான்னு சொன்னீங்க? சார் எல்லாம் அம்மாட்ட சொல்லிட்டேன். சார் அவ சரியில்லை சார், நீங்கள் திருப்பி சொல்லுங்கள். அதுவும் முடிஞ்சு போன பிறகு அந்த பாட்டி ஒன்று சொல்லியிருக்கோம், அது தண்ணியை காய்ச்சி குடிக்கலாமா, அந்த மினரல் வாட்டரை காய்ச்சி கொடுக்கலாமான்னு கேட்டுவாங்க. அதுக்குள்ளே ஓடி வருவாங்க. It is all happening. Happenings will be happening always. But you don't get provoked and get irritated. Stay cool. That is the message. இன்னொரு விஷயம் என்னன்னா, சில சமயம் நம்ம தப்பு பண்ணுறது இயல்பு. என்ன தப்பு பண்ணியிருப்போம்?
செக் ஒன் மோர் மினிட்.
யா, ஒரே ஒரு விஷயம் பார்த்தீங்கன்னா, நம்மளோட லேப் ரிப்போர்ட்டில் கூட நம்ம சரியாமல் கவனிக்காமல் விட்டுருப்போம். ஹீமோக்ளோபின் கம்மியாக இருந்திருக்கும், பக்கத்து ப்ராக்டிஷனர் கண்டுபிடிச்சிருப்பாங்க. When it has been pointed out to you, don't get provoked. நீ டாக்டரா நான் டாக்டரா அப்படியெல்லாம் பேசக்கூடாது. Whatever said and done, if there is a mistake on your part, try to accept the mistake and make them comfortable, feel comfortable that you can easily approachable and you are accepting yourself for a correction. So you are easily approachable and correctable ங்கிறத நீங்க always ஒத்துக்கணும். So final விஷயம், celebrate the kids of your patients, your patient kids. அவங்க அச்சீவ்மெண்ட்டை வந்து சொல்கிறப்போ சின்ன சின்ன கிஃப்ட்ஸ் வச்சு ரெக்கக்னைஸ் பண்ணுங்க. உங்கள் ஸ்டாஃபை சொல்லி பர்த்டே விஷஸ் அனுப்புங்க. அவங்க மெரிட்ஸ்லேயோ ஸ்கூல்லையோ அச்சீவ் பண்ணி வர்றப்போ அந்த அம்மா அப்பாவை பேரண்ட்ஸை பாராட்டுங்க. கிராண்ட் சைல்டை சொல்லுங்கள். உங்கள் சார் தாத்தா உங்கள் பரம்பரையில் உங்கள் வேறு எப்படி வந்திருக்கு பார்த்தீங்களா, we'll make them happy. That is what ultimately needed. Final message I wanted to tell you is, don't be in a nutshell. பாக்ஸ்குள்ளே இருக்காதீங்க. Only pediatrics and medicine is my purview நினைக்காதீங்க. Go out, reach the community, join NGOs. Please try to serve the community. If you help the community, if you reach them through so many other medias, social media இருக்கு, ரோட்டையில் கூப்பிட்றாங்க, பிரஸ்ட் ஃபீடிங் வீக்குக்கு டாக் கொடுக்குறாங்க, ஸ்கூலில் அடலசன்ட் ஹெல்த் வீக்குக்கு கொடுக்குறாங்க, இம்யூனைசேஷன் கொடுக்குறாங்க, எல்லாத்துக்கும் போங்க. Present yourself in all the forums, make the feel happy, you will be rewarded, you will be a great pediatrician. Thank you.
Thanks Ismail, wonderful talk, well within time. I invite the last panelist, Dr. Chendil. செந்தில்னா எனக்கு வர்ற ஒரே வார்த்தை மனசில் தமிழ் தான். ஸோ தமிழுக்கு என்னெல்லாம் நல்ல குணங்கள் இருக்கோ எல்லாமே படைத்தவர் செந்தில், டாக்டர் செந்தில்.
ஒருங்கிணைக்கும் மருத்துவர் சுனில் சீனிவாசன் அவர்களுக்கும் என்னுடைய குழுவினருக்கும் மருத்துவர் இஸ்மாயில், மருத்துவர் செல்வன் அவர்களுக்கு நன்றி. அகர முதல எழுத்தெல்லாம் ஆதி பகவன் முதற்றே உலகு, எங்கள் வாழ்வும் எங்கள் வளமும் மங்காத தமிழ் என்று சங்கே முழங்கு. Okay. The art and science of pediatric practice. It is a delicate balance between medical knowledge and compassionate care. ஒரு வரியில a patient-centered care, effective communication to the parents, relatives involving the family, possessing basic skills like empathy, compassion, critical thinking and problem solving. This is a simplified version. So, the first impressions matter. அதாவது ஒரு நான் எமர்ஜென்சி, ஒரு இம்யூனைசேஷன் விசிட், ஒரு மைனர் எயில்மெண்ட்ஸ், இதுக்கெல்லாம் பேஷண்ட்ஸ் வராங்க உள்ள. இளைஞர்களுக்காக சொல்கிறேன், முதல்ல உள்ள குழந்தையோட அப்பா அம்மாவோ தாத்தா பாட்டியோ வர்றாங்கன்னா ஒரு புன்முறுவல், ஒரு அழகான சிரிப்பு, ஒரு வெல்கமிங் ஸ்மைல், அல்லது வாங்க உட்காருங்க, குழந்தைய பார்த்து, குழந்தை வந்து அழுதுட்டு இருக்கு. இப்போ முக்கியமாக இந்த 9 மாதத்துலேருந்து 2 வயசு வரைக்கும் we say it as terrible twos. அழுதுகிட்டு ராவடி பண்ணோம். ஏற்கனவே வர நீங்கள் ஊசியை குத்தி குத்தி இம்யூனைசேஷனுக்கு வந்து அது அப்படியே கத்தும், அலறும். உள்ளே வந்த உடனே சமாதானப்படுத்தி ஒரு அழகான ஒரு எஸ்டாப்ளிஷ் அ ரேப்போ. யூ மஸ்ட் ஹாவ் அ வார்ம் வெல்கமிங். என்ன பேஷண்ட்ஸ் எதிர்பார்க்குறாங்க, இன்றைய படித்த இளைஞர்களும் சரி படிக்காதவர்களும் சரி எல்லாருமே எதிர்பார்க்கிறது, வாங்க உட்காருங்க, அதுக்கப்புறம் என்ன செய்யுதுன்னு கேளுங்க, காது கொடுத்து கேளுங்க. காது கொடுத்து கேட்டிங்கன்னா அவர்கள் என்ன, சயின்ஸ் என்ன சொல்லுது, கம்ப்ளைண்ட் சொல்ல ஆரம்பித்த உடனே 10வது செகண்டில் நாம் இன்டர்ஃபியர் பண்ணிடுறோம் அப்படிங்கிறது தான் சயின்ஸ் சொல்லுது. அதனால் முழுசாக அவங்க கம்ப்ளைண்ட்ஸ் அவங்க சொல்லட்டும். முழுசாக சொன்னதுக்கப்புறம் அவர்கள் வந்து என்ன சொல்கிறாங்கங்கிறத காது கொடுத்து கேட்டோம் அப்படின்னா அவர்கள் சொல்ல வருவதை முழுசாக உள்வாங்கி கொண்டு இன்வால்வ் த ஃபேமிலி, எல்லாரையும் சொன்ன மாதிரி இஸ்மாயில் சொன்ன மாதிரி எல்லாரையும் சாட்டிஸ்ஃபை பண்ணுறது. யூ டூ அ வெரி மெட்டிகுலஸ் எக்ஸாமினேஷன். அந்த மெட்டிகுலஸ் எக்ஸாமினேஷன் வில் கிவ் தம் கான்ஃபிடென்ஸ். அதுக்கப்புறம் give them relevant information about the disease, alleviate their fear. அவங்க பயத்தோடு தான் வந்திருக்காங்க. இந்த சமயத்தில் ஒன்று ஞாபகம் வருது, நம்மக்கிட்ட வர்றவங்க எல்லாருமே ஏதோ ஒரு கவலையோ அல்லது ஒரு குழப்பமான ஒரு சூழல், அதாவது ஒரு டிசீஸோடு வர்றாங்க, ஒரு நோயோடு வர்றாங்க. அந்த நோயோடு வர்றவங்கள அவர்கள் வெளியே போகும்போது அந்த தன்மையிலிருந்து அவர்கள் குறைச்சு வெளியில் போகணும். வெளியில் போகும்போது இருக்கிறத அதிகமாக்கி அனுப்பக்கூடாதுங்கிறது என்னுடைய ஸ்டாஃபுக்கு நான் சொல்கிறது. அவர்கள் உள்ளே வரும்போது இது ஒரு காவல்துறை அதிகாரியிட்டந்து அவர் பேசும்போது நான் கற்றுக்கொண்டது 25 ஆண்டுகளுக்கு முன்னால். அவர் சொன்னது என்ன சொன்னார்னா, அப்போ அந்த காவல்துறை உங்கள் நண்பன்கிற கான்செப்ட் வந்த புதுசு. ஒரு போலீஸ் ஸ்டேஷனுக்கு வராங்க, வரும்போது அவர்களை அவங்க கஷ்டத்தோடு தான் வராங்க, அவங்கள கஷ்டத்தை கூட்டி அனுப்பாதீங்க, குறைச்சி அனுப்புங்கன்னு சொன்னார். இதை நான் எடுத்துக்கிட்டேன், என்னுடைய ஸ்டாஃபுக்கு சொல்கிறது. அவர்களை நாம் எந்த விதத்துலேயும் ஒரு அன்பான வகையில் அவங்கள அனுசரித்து அவர்கள்ட்ட பேசுகிறது தான் முக்கியமான ஒரு இதாக இருக்கும். அடுத்தது முக்கியமான ஒரு பகுதி இந்த நியூ பார்ன் வராங்க இல்லையா, 15 நாள் குழந்தை, 10 நாள் குழந்தை கவர்மெண்ட் ஹாஸ்பிட்டலில் டெலிவரி பண்ணிட்டு வராங்க, இல்லை எங்கேயோ ஒரு ப்ரைவேட் நர்சிங் ஹோமில் டெலிவரி பண்ணிட்டு வராங்க அப்படின்னா, அவர்களை உங்களுடைய அங்கே தான் நீங்கள் அவர்களை சரியான விதத்தில் கையாளணும். நான் கிட்டத்தட்ட 25லேருந்து 30 நிமிடம் அவர்களுக்கு மட்டும் செலவு பண்ணுறேன். எப்படி அப்படின்னா, நான் செலவு பண்ணுறதில்ல, நான் ஒரு 10லேருந்து 15 நிமிஷம் அவர்களை என்னங்கிறது டீட்டெயிலாக எல்லாத்தையும் கேட்டுட்டு, என்ன எத்தனாவது குழந்தை, டெலிவரி எங்கே, என்ன காம்ப்ளிகேஷன் ஏதாவது ஆச்சா, இதெல்லாம் கேட்டுட்டு அப்புறம் அவங்க தாய்ப்பால் கொடுக்குறாங்களா என்னன்னு கேட்டு முடிச்சுட்டு எல்லாத்தையும் உள் வாங்கி எழுதி, அது முக்கியமான விஷயம் எழுதி வைக்கிறது. சீட்லேயே அந்த ஓபி டிக்கெட்லேயே எழுதி வைக்கிறது, ரெக்கார்ட் இட், எல்லாத்தையும் எழுதி வைங்க. இது ஈவன் ஃபார் மைனர் அலைன்மெண்ட்ஸ் எல்லாத்துக்குமே நீங்கள் எழுதி வச்சிட்டிங்கன்னா எதுவும் மறக்காது. அது இட் பிகம்ஸ் அ ரெக்கார்ட். ஈவன் யோர் டயக்னோசிஸ் ரைட் இட் இன் த ஓபிடி பேக்கெட். ஸோ இதை முடித்ததுக்கப்புறம் யூ கால் த ஸ்டாஃப் நர்ஸ் ஹூ இஸ் ரியலி ட்ரெயின்ட் இன் லாக்டேஷன். ஏன்னா இத்தனை வருஷத்தில் நான் கண்டிப்பாக இப்போ எங்கிட்ட ஒரு 10-15 வருஷமாக ஸ்டாஃப் நர்ஸ் இருக்காங்க, தே ஆர் ட்ரெயின்ட் இன் லாக்டேஷன். அவங்கள்ட்ட அனுப்புறது, ஏன்னா அவங்கள்ட்ட அனுப்பின உடனே தே வில் சிட் அண்ட் see that the patient, அந்த பேபி மதர் எப்படி ஃபீட் பண்ணுறாங்கங்கிறத உட்காந்து அவங்களுக்கு எல்லா அட்வைஸும், ஃப்ரீக்வன்சி ஆஃப் பிரெஸ்ட் ஃபீடிங், பர்பிங் எல்லாமே சொல்லி கொடுக்கறது. அதாவது ஃபர்ஸ்ட் அப்சர்வ் அண்ட் தென் இஃப் பாசிபிள் கரெக்ட், இஃப் தே ஆர் டூயிங் இட் கரெக்ட்லி அப்ரிஷியேட். ஸோ இந்த ஃபர்ஸ்ட் இம்ப்ரெஷன் யூ கேட்ச் தெம் தேர். அந்த மாதிரி அவங்கள சரி பண்ணிட்டீங்க அப்படின்னா, ஏன்னா இன்றைய காலகட்டத்தில் மைனர் எயில்மெண்ட்ஸும் குறைஞ்சிச்சு, மற்ற நோய்களும் குறைஞ்சிச்சு. ஸோ இந்த நியூ பார்ன் கேர் அப்படிங்கிறது ரொம்ப ரொம்ப ஒரு தேவையான செய்தி அப்படிங்கிறத இந்த நேரத்தில் செஞ்சுட்டு அவங்கள்ட்ட நேரம் செலவு பண்ணிங்கன்னா, அதுக்கப்புறம் அவங்க 6 மாதமோ இல்லை அந்த குழந்தைக்கு எத்தனை வயசாக இருந்தாலும் அந்த முதல் இம்ப்ரெஷன், ஃபர்ஸ்ட் இம்ப்ரெஷன் மேக்ஸ் அன் இம்பேக்ட் அப்படிங்கிறத நல்லா புரிஞ்சுக்கணும். ஸோ இன் அ கிரைசிஸ், சப்போஸ் கிரைசிஸ் அப்படின்னா இட்ஸ் நாட் அ கிரைசிஸ், இட்ஸ் அன் எமர்ஜென்சி சுச்சுவேஷன். ஒரு எமர்ஜென்சி, ஒரு ரெஸ்பிரேட்டரி டிஸ்ட்ரெஸ் வருது, ஒரு ஃபிட்ஸ் வருது, ஃபெப்ரைல் ஃபிட்ஸ் இஸ் வெரி காமன். அது வரும்போது யூ ஜஸ்ட் அட்டெண்ட் டு இட் இம்மீடியட்லி and see that the staff are very cohesive and very very approachable. அவங்களை எல்லாம் ட்ரீட்மெண்ட் எல்லாம் கொடுத்துட்டு வெளியில் போய் ஒரு அந்த ரிலேட்டிவ்ஸை சாந்தப்படுத்துங்க, அல்லது என்ன இன்ஃபர்மேஷன் அவங்கள்ட்ட சொல்லி யூ ஐடென்டிஃபை ஒன் பர்சன். ஒரு அந்த இதில் ஏன்னா நீங்கள் இப்போ ஒரு தடவை சொல்லிவிட்டு அப்புறமா இன்னொருத்தட்ட 2வது தடவை போகும்போது வேறு யார்ட்டையும் சொல்லக்கூடாது. ஐடென்டிஃபை அ பர்சன் ஹூ கேன் பி அப்ரோச்சபிள், ஹூ கேன் அண்டர்ஸ்டாண்ட் யுவர் வாட் யூ ஆர் கோயிங் டு சே அப்படிங்கிறது ஒருத்தட்ட சொல்லி மற்றவங்கள்ட்ட சொல்லிடுங்க அப்படின்னு சொல்லிட்டு, அதுக்கப்புறம் யூ டிசைட் அபவுட் த கண்டிஷன். இந்த கண்டிஷனில் இருக்குன்னு சொல்லிட்டு திரும்ப அகெயின் கோ அண்ட் எக்ஸாமின். இஃப் யூ வாண்ட் டு ரிசர்வ், ஐ மீன் இஃப் யூ வாண்ட் டு ரெஃபர் இட் இமீடியட்லி, யூ send a staff nurse with the patient in the ambulance with them, all the drugs and everything, precautions, to the nearby primary intensive care unit. So by learning is a lifelong process. We are learning through this CME, through this conference, through all the information we are getting all these 3 days. இதை அட்டன் பண்ணிட்டு போனதுக்கப்புறம் நாம் we get recharged. இதுதான் வேறு ஃபீலிங். எப்போ எத்தனை தடவை பெடிகான் வந்தாலும் இங்கே வந்துட்டு போனதுக்கப்புறம் இது ஒரு ரீசார்ஜிங் ஸ்டேஷன். இந்த ரீசார்ஜ் பண்ணதுக்கப்புறம் you have gained so many new insights which you can put into your practice. So CME's conferences have helped me all the way through my 34 years of attending Pedicon. This is what youngsters have to do. They have to come into IAP, they have to contribute, they have to learn, they have to unlearn and relearn. This is what Professor Parthasarathi used to say. And we have learned a lot from our teachers. We say Dr. Namarwar, Dr. Tangavelu, Dr. PRC, Dr. Gopal, Dr. Prem Kumar, so many teachers, Dr. Elizabeth John, Madam Pushpa. And so we have to take even from our contemporaries, say Ashwath is here, he's a roaring practitioner in Coimbatore. He just takes the child into his arms. So this is what, like, you can take the child. What is it? Oru nalla kolanda avangkitta odi varudha thooki vechunga. So we have got umpty number of role models in our area. So as Dr. Ismail said, community programs, doing them gives a lot of satisfaction for yourself, inner satisfaction. Going and talking to the parents, teachers, students, and then doing all sorts of breastfeeding weeks, adolescent programs, so many things. You get into contact with so many people, so many NGOs, so many, they will respect you and they will come and your practice will definitely increase. This is what I have learnt all these years. Thanks for the opportunity. Thank you.
Yeah. Time for some audience quiz. I got 4 chocolates with me. Okay? Right. First question. What is the one thing that you should never forget to take before going to see patients? What is it? Smile. Judge decision is final. So I decide the answer. Any other answer? Mind. Wonderful. Bharat. Wonderful.
Goodwill, sir. Goodwill.
Wonderful. Thank you. I told a small story. Or Raja Avatar irundar. Our kettaru, he wanted 3 questions from his people. Who is the most important person in my life? 1. 2, what is the most important thing I should do? 2. And 3, what is the best time to do it? 3 kelvi. So a lot of people came and answered. Finally, one wise old man came. Our Raja kekkarar, why are you asking this question? He said, I want to be happy throughout my life. Wonderful. So the first answer, the most important person in your life is some answers. Our Munja, right? Most other than you. Wife. Yeah. அவங்கவங்க நிம்மதியாக வந்திருக்கா ஏன் பாட்டு டார்ச்சர் பண்ணு. The most important person in the life, he said, not me, the person sitting opposite you. உடனே இந்த ராஜாக்கு ரொம்ப தினம் நிறைய பேர் வராங்கப்பா வராங்க எங்கள்கிட்ட பேசுகிறாங்க. he says அந்த மொமெண்ட்டில் he is the most important person. ஏதோ நல்லதோ கெட்டதோ you solve that problem. So that is probably the most important message I want to say. The most important person is the person sitting opposite you right at that moment. So அதனால் நீங்கள் பார்த்தீங்கன்னா all the speakers made that point. செந்தில் சொன்னார் warm welcome. வரீங்க. So if you VIP come, that's not how you welcome. ரஜினி வீட்டுக்கு வர்றாருன்னா சும்மா வெல்கம். அதே மாதிரி செல்வன் சொன்னார் be on time. So that's how Maryada, by being on time, we pay respect to our patient. We come there. அதே மாதிரி இவர் இஸ்மாயில் சொன்னார் listen to them. That's very important. When I was in practice, and I used to go with 20 thoughts in my mind regarding my wife, my daughters, my tax issues, some sick child, this has happened. With how do you even see patients? So go with clear mind. And so that's the first lesson we learned. And the next question. Can you change? What is the one thing you should forget to or never forget to leave before you go to sleep? எதை விட்டு செல்ல வேண்டும்? Any answer? Come on. Oh, perfect. Catch. Great, great. அதாவது நான் எம்டி படிச்சுட்டேன், ஒரு நாளைக்கு 100 பேஷண்ட் பார்க்குறேன், இவ்வளோ டாக்ஸ் கொடுத்துருக்கேன், இவ்வளோ அவார்ட்ஸ் கிடச்சிருக்கு. இட் டசன்ட் மீன் எனி திங். தட் டசன்ட் மேக் யூ எனி superior to the guy sitting. So, and in fact, probably I believe after all this 40 years of practice, those mothers who are much, much more superior to us. They are living under such difficult condition. We are all living privileged lives. Now, all of us, I can tell you, pediatricians in India are the most privileged people in the entire planet. Entire planet. யாராவது 100 பேபிஸ் கிஸ் கொடுத்து காசு வாங்கிக்க any possible. You get to kiss 100 babies and get still make money. அதனால so we are so privileged. They are all so much superior. They live really tough lives. அதனால so please let your ego go. அதுக்கு inferior இருக்கிறத ஒரு செந்தில் படம் போட்டார், பெரிய டாக்டரை கும்பிடு போட்டார். So let's be humble. Let's put our mind into it. And humility always works. Always works. That's a probably important lesson. I know Dr. Nammadwar பற்றி சொன்னார். I still remember ஒரு முறை கேஸ் ஒரு கிளினிக் எடுக்கிற டாக்டர் நம்மாழ்வார். He tells a diagnosis. அந்த ஜூனியர் பிஜி என்ன பண்ணுறாங்க, she tells, சார் எனக்கு ஐ ஃபீல் தட் இஸ் தட் அப்படின்னு சொன்னார். உடனே சார் சொல்கிறாரு, கொஞ்சம் யோசனை பண்ணிட்டு, ஆமாம் யூஆர் ரைட். And he could have stopped there, but turns to the mother and says, அம்மா நான் சொன்னேன், பட் நான் தப்பாக சொல்லிட்டேன், அந்த பொண்ணு தான் கரெக்டாக சொல்லிச்சு, நீ அதை அட்வைஸ் ஃபாலோ பண்ணு. What an amazing put. That humility we cannot get. Yes, what should you keep on accumulating throughout your life? Money, memory, okay, knowledge. Illa, again, judge's decision is final. So you may be right, I don't know. Fitness, yeah. Thanks, Tindil, thanks. Sorry, my. Two things money cannot buy. One is your time, one is your health. Money can cure your disease, but it will not give you health. So health, I feel so bad when people neglect their health. Nothing else is priority. Even money you can make, but if you're not healthy, you're miserable in your last days of your life, and which is pretty long. So between 60 and 80 is the golden period. Be healthy. Spend every day for health. Dr. Selvan side reporter, put patients first. Or small modification, Selvan, put your health first before patients. Adala, please take care of the health. I mean, you're all doctors, so I don't have to tell you what to do, but follow some regimen rigidly. This health is not a 3-day regimen. Mari, Dr. Rajkumar sonar, 3 days all and nothing, no super. Every day you got to follow it up, and you'll get health. So please take care of health. Last question. What should you never keep on accumulating throughout your life? Again, my decision is final. Money illa, it's not money. Greed. Parasite. Hatred. Okay. Okay, I'll give it. I'll tell you, 40 years of practice, I kept on accumulating without even realizing. Today I feel it's a colossal waste of time accumulating this. What's it? Now, it's luckily this last session, my feeling today, 5 years before I wouldn't have told that, my feeling this is knowledge. Knowledge is totally overrated. The முதல்ல சொன்னா அடிச்சு போட்டுருப்பாங்க கான்ஃபரன்ஸ் முன்னாடி. The reason I'm telling you. So I have accumulated 3 cupboard books full of medical books. I have gigabytes of data in my computer. But still, knowledge keeps on changing. I'll give a small example. For a patient ITP varanga, உட்காந்துருக்கிறாங்க. I know it's ITP. ஓரளவுக்கு I know the treatment. But what is the latest guideline? என்ன சிஆர்எஸ் கொடுக்கலாமா வேணாமா, கொடுத்த எத்தனை நாள் கொடுக்கணும், ஐவிஏஜி கொடுக்கணுமா, அடுத்த எப்போ சொல்லணும், வாட் இஸ் அ ஃபாலோ அப், ஓரளவுக்கு. ஐம் நாட் டெல்லிங் ஐம் இக்னரண்ட், பட் and with all my 3 cupboards of textbook and my gigabytes of data, it will take me 20 minutes to find the answer. And the answer கண்டுபிடித்த பிறகும் இதுதான் latest, I don't know, still I don't know. Whereas, so that is, I am making a case for artificial intelligence, also called AI. AI can get you the answer in 3 seconds. 3 seconds. So the difference between, I'll just explain this. You all of you got mobile. உங்கள் மொபைலில் 100 பேர் ஃப்ரெண்டோட நம்பர் வச்சுருக்கிறீங்க. Suppose I come and tell you, Rajkumar sir, memorize all the 100 numbers. You never know when you got to call. அவர் சிரிப்பார். Yes sir, I phone the number இருக்கு, I can always access. Why should I remember all this? When the entire knowledge of the world is in a phone, why got you remember all that? நான் அதுக்குன்னு knowledge வேண்டான்னு சொல்ல வரல. நீங்கள் கேட்கலாம், படித்தா டாக்டர் ஆகிடலாமா? இல்லை. You need to have fundamental knowledge. You need to have the wisdom to understand what is happening. But don't go after knowledge. Go after AI. நிறைய பேர் ஏஐன்னா ஒரு மாதிரி பார்க்குறேன். என்ன சார் வேணுமா வேணாமா? இது it is not உங்கள் சாய்ஸே போயிடுச்சு. It is no longer your choice. AI is there to come, and I request each one of you to concentrate on AI. I'll just put the link number next. I'll give one more example just to, this entire PPT was AI generated. Entire what you saw so far has been generated by AI. So ennachana or 1 month before, we were all discussing the panelists, and I told them same thing. They all gave all their points, or 7-8 points கொடுத்தாங்க. Now last Sunday I sat and I had to separate. யார் யார் என்ன பேசணும், பாயிண்ட்ஸ் ரிப்பீட் ஆகக்கூடாது, ஒரு கேட்சி டைட்டில் இருக்கணும், இந்த டைமில் முடிக்கணும், all this thing. And normally it would have taken me 2 hours. And I tell you, AI did it in 2 seconds, I promise, 2 seconds. அதற்கு பிறகு then I thought, what, அது என்ன பண்ண, ஒரு பவர் பாயிண்ட் ஆக்கணும், again it will take me 2 hours, again 2 seconds. 4 hours work condensed in 2 seconds. The only thing, image நான் தான் போட்டேன், but all other thing AI did. So what, it's an amazing tool. There are a lot of plus and minus, but I request each one of you to concentrate on AI. That is the happening thing, and the doctors are so backward in AI. We still have a long way to go, but it will revolutionize your personal and professional life. I can assure that. So please note down this number. This is my WhatsApp number. I am not trying to promote anything here, but it's a message only. If you call, I won't answer. But any doubts regarding the art and science of pediatric practice, the ASPP, or any doubts regarding AI, you just send a message and then we'll work out. The best thing about AI, it is not like pediatric software mari kadayadu. Software, to me, it took me 2 weeks to learn. And all doctors, we know structure of heart, we know Krebs cycle, we can interpret ECG, AI la jujubi. One day la learn panikalam. But you got to have the will to learn. We can make you a proficient just in 1 day. So you want to know more about it or organize workshop, I can come to your place, whatever. So note that number. Or regarding the art and science, this is only beginning. So all the 3 superstars have agreed that 6 months they will keep contributing to the group. We'll form a group, and whatever your doubts or you can share along with this. Idu mattum we talked about the art of pediatrics. Now we're going to talk about the science of pediatric practice. I think it will take us 1 more hour. Do we have 1 more hour? Is it all right? Madam, 1 more hour? The science ஆரம்பிக்க போகிறோம் மேடம். ஸ்டன் ஆகிட்டாங்க. don't bother. அவங்க ஷாக் ஆகிட்டாங்க. வடிவேல் மாதிரி ஷாக் ஆகிட்டாங்க. நான் ஏன் வடிவேல் பேர் சொன்னேன்னா யாரோ சொன்னாங்க, அதில் வடிவேல் பேர் சொல்லாட்டி சக்ஸஸே கிடையாது. ஸோ I told his name also. Good. So I'll tell the science of pediatrics. This is courtesy. Is Dr. Kritika somewhere here? Can I see her? Dr. Kritika from Teni Medical College? Left, okay. About a few years ago, I was the national convener for this project, and I did programs all over India. And it used to take us one day. And then Dr. Kritika came to Trichy some few months ago, and she did the entire program in half an hour. So I have to condense the entire program in 1 slide. So please take a photograph. It contains all the science of pediatrics. All this lovely. And any doubt, you ask Dr. Kritika. So before we conclude, a few parting words from our panelists. We'll start from Dr. Chindi. On the line, you want to share some final thoughts or something you want to add?
Yeah, everyone has got their own style, and please stick on to your style, but improvise on your style. The future of pediatric practice is all evolving, it is changing, and now in this day of Parents want immediate gratification. நட்டவுடன் ரோஜா பூ இன்றே பூக்கணும், இன்றைக்கே என் குழந்தைக்கு சரியாகணும், ஏன் சரியாகலைங்கிற கேள்வி கேட்குற இடத்துல நம்ம நிற்கிறோம். ஸோ அதுக்கெல்லாம் தயாராக நம்ம இருக்கணும் அப்படிங்கிறத தெரிஞ்சுக்கிட்டு, virtual reality is going to be the future in pediatric practice also. Gamification is also going to help them, and it is also going to heal them. It is going to heal them in the future, even cancers and so many other things. Virtual reality is going to play a role. This is what is going to be our future, and thanks for the opportunity.
Give more knowledge. Don't worry about questions. I'll always ask them to ask questions. Be ready with the answers. That's what we need to do. And don't have any fixed number of patients to be seen or a fixed amount of money to be collected. Always be happy with whatever number of patients you are able to see and whatever the amount you are able to have it through your practice. Be happy, enjoy your practice.
The same message I wanted to give it to you is simple. Start the day with enthusiasm. Never think your practice is boring, and have fun. Enjoy the fun. Listen to the fun. Introduce fun in your practice. It will be really benefiting both ways. Win-win situation for your patients and yourself. Be happy with lot of happiness in your mind and sympathy and compassion in your heart. That is the message I want to give you. Start the day with enthusiasm. Thank you.
Thank you, thank you. On this lovely, lovely Sunday morning, and we are very grateful on the behalf of our panelists to have come here and share your enthusiasm. We'll keep this going. It is not it's the beginning, so send a message. We'll keep this going, group going for about 6 months. And I wish you all a very, very happy, successful, great career ahead.
Thank you, sir. We extend our sincere gratitude to the entire panel for this comprehensive discussion on pediatric practice in today's world. I request the chairperson to felicitate our speakers with tokens of gratitude. I request the audience to kindly be seated and stay back for the valedictory ceremony.
The award paper results and the poster results will be announced just another 15 more minutes. Please do stay back.
I request Ismail sir to felicitate our chairperson with a memento.
Thank you, Ismail sir and team, for closing off the conference with a wonderful, insightful talk. Thank you, sir. With the same josh, I request all the delegates to stay back for the valedictory function. We'll just start in 5 minutes. Hello, yes. So I would invite the dignitaries to the dais. First, I would like to invite our President IAP-TNSC, Dr. Rajendran sir. Welcome, sir. Next, I would like to invite our President-elect, Dr. Somasundaram sir. Immediate. Okay. Immediate past President, Dr. Balashankar sir. Vice President, Dr. Gopal Subramaniam sir. Our Honorary Secretary, Dr. S. Narmada. Treasurer, Dr. Rajkumar sir. Please be seated, sir. Now, I would like to invite the chief guest for this valedictory function, Dr. M. Ramasamy, sir. Huh? Next, I would like to invite guest of honor, Dr. Ramesh Kumar, sir. Please, sir. Please welcome, sir. It's a pleasure to have you on the stage, sir. Please come. Now, I would like to invite the organizing chairperson for this wonderful KONGU PEDICON that went on for 4 days, Dr. Ismail, sir. Chief Organizing Secretary, Dr. Sashikumar, sir. And Organizing Treasurer, Dr. Mullai Balaji. And the success of the conference, the Chairman of the Scientific Committee, Dr. Ashwath, sir. Okay, so we'll have the pediatrician prayer by our treasurer, Dr. Rajkumar, sir.
I request all dignitaries and delegates, please stand up for the pediatrician prayer. குழந்தை மருத்துவனை நிறைஞ்சுதல் எங்களுக்கு முழுமையான குணமளிக்கும் திறனை தாரும் நோயரின் துன்பம் தீர்க்கும் திறன் நமக்கு வழங்கப்பட்டது எப்படிப்பட்ட சிறப்புரிமை என்பதை நாம் பணிவுடன் உணர்வோமாக எல்லா குழந்தைகளுக்கும் அவரது குடும்பத்தினருக்கும் அவர்களின் சமுதாய நிலை மற்றும் சாதி மத பிரிவுகளை பாராமல் நலம் கற்றல் ஈகை அன்பு அமைதி ஆகியவற்றின் தூதுவர்களாக என்றும் இருப்போமாக நம்மால் முடிந்தவற்றை மாற்றவும் நல்லவற்றை உள்வாங்கவும் மாற்ற முடியாதனவற்றை காரணத்துடன் ஏற்றுக்கொள்ளவும் போதுமான மெய்யறிவும் புரிதலும் எங்களுக்கு வழங்குக உங்களது வாழ்த்துக்களையும் அருளையும் கருணையும் எல்லா சூழல்களிலும் நேரங்களிலும் அனைத்து மக்களிடையே கொடுத்து அருளுங்க. தேங்க்யூ.
Thank you, sir. Now we'll have the introductory speech by our secretary, Dr. Narmada. Sir,
we are extremely delighted to have our President CIAP in 2023, Dr. Ramesh Kumar sir, amongst us today. So he is a person who was all-inclusive, made so much changes, was the most popular president of CIAP. Sir, we are very happy to have you here, sir. Plus, a few words, sir.
It's truly exciting for me more than anything else. President Dr. Rajendran, President-elect Dr. Somasundaram, my immediate past President Dr. Balashankar, and the organizing chairman Ismail and team. I'm not taking the name, Secretary Namada and Rajkumar, as well as Gopal, my dear Narkoil, again Shashi, as well as Ashwath and Mulay, plus all my dear friends out here, like Nandakumar and Vishwanath, I think of course the Insta guy, and all good to be, I'm so really privileged, and I'm really happy and proud that I could make it with you. In fact, I had some constraints, but at least for a day, I thought I must be there with this conference, because my relationship with Tamil Nadu is as exciting as well as is deep-rooted. I must say it's deep-rooted. Please, sir.
We welcome our chief guest, Ramlingam sir, from Ramasamy sir for this function.
Thank you, Ramasamy sir, for attending this valedictory function. Dr. Ramesh Kumar sir, you can please take.
So, Dr. Ramasamy sir, I'm going ahead a little early because I have to leave within 10 minutes. So that's when talking about Tamil Nadu, and I mean, I'm always so happy, and my wife's double up or triple up when I come. I'm with this team in Tamil Nadu. I'm very honest. It comes from my heart because I've been a fellow traveler of Tamil Nadu for the last 10 years almost, for anything and everything. And believe me, I was the happiest person when this pedicon came to Coimbatore. I really made maja that night when I came to know about the evening. I made myself happy with so many, you know how I was made happy. But I was really excited. And again, coming up the 50th year of Tamil Nadu state, coming up next year with I must say you must celebrate with the national president from Tamil Nadu. So that also happening. You will be, whatever has been your scars or you have lost in the last 25 years would be made up in one single year. So friends, this is your time now. You are actually at the making news across IAP. So you have to make it happen, and we are there as your neighborhood bros or whatever you can call it. But then we see IAP as an organization where now 50,000 members are going around, and we need to take the inclusivity, the confidence, the wish, the affection of the entire country. And that should be our motto, because maybe we have our own culture, our own beliefs, Kerala, Tamil Nadu, we may stand apart a little bit, Bengal, but I believe the IAP as a fraternity always stands. And I have been the national secretary, I had before 2 years at the helm, and as a national president. And I always watch for that. All the members, it is IAP belongs to the 50,000 members, and where IAP stands now, it is just because of the prescription support of the 50,000 members. If this conference is happening, the pharma is behind us, it is not because of the president or secretary making it. It is just because of the member of some corner, the northeast, Shillong, or somebody sitting in Jaisalmer or Bama sitting and prescribing for IAP. These IAP conferences are happening, and we are sitting big on this dais as well as down here. So we need to work for our friends, our members, academic on one side, community on the other side, welfare of family benefit scheme, welfare of the organization of family on the other side, and all certain things we need to enjoy academics with camaraderie. That is what IAP speaks about. And I have learned everything from IAP, and I believe, I always ask in my talk in the morning, I have got DNB, we always morning rounds, I always talk about the practical tips which I have gained from IAP TOTs and IAP CMEs. Nothing from the textbooks, because they are all reading Nelson, they are all reading ChatGPT, they are making, but there are many things which come from the TOTs, well crafted, organized material in the academic CMEs, academic TOTs modules which IAP has been disseminating over the years. So make use of it. You can be a great academician, I think, great grassroots academician like Palanagaman, or you can be a big bro academicians like Ashwada and others. There are so many others. So I have been, last year I think, this time you didn't have the quiz. In Pondicherry, I think, I was listening to Ashwath's quiz and other things. So, and today also the last topic session itself was good, how to get your week without a Monday morning blues. Going to the hospital, I really look forward to Monday morning going to the hospital. I don't want I am enjoying with my patients and enjoying with the kids. So that has to be attitude. So once again, my best wishes and thank you so much, Team Tamil Nadu, all my dear friends, Debgip Bro Ismail and led by the older team Rajendran. You are going ahead and it's going to be year time ahead for IAP. Get it goes team in full flying colors, all these youngsters supporting you. So let's 3 cheers to Tamil Nadu, IAP, Coimbatore Pedicon and the National Pedicon in Coimbatore, and of course, my dear friend Shingaravelu. God bless, inshallah, let it happen. Thank you very much, and thank you for permitting me to come early. I have to leave now for the 2 o'clock bus to Kochi. So I thought I should share some thoughts with you. Thank you.
Thank you, Ramesh, sir. With all your support and guidance, we can achieve greater heights. We are all one big family, sir. Now, Dr. Narmada will resume her introductory speech.
Now, I know all of you are waiting to leave, but I should definitely give my thanks to the entire organizing team of KONGU PEDICON from my heart. So as a Tamil Nadu State Secretary, it is very essential for us to work with the organizing committee and and I never felt I was away from Coimbatore because of this, the constant phone calls and all that, especially the little bit of ups and downs with Dr. Jayavardhan. I told yesterday, like a sibling, we were fighting. So thank you so much. Of course, Sasikumar sir, who also happens to be my senior, and Ashwat, and of course, none other than Ismail sir, taking all his thing like a daughter. He used to tell what is right or what is wrong and taking me along. I felt at home for the past 3 days, and it has been very smooth ride as a state secretary. So that is one of the very essential part of any state secretary. You know, you don't want to have any, because you're coming from a different place, and here I was really very happy, and thanks to you all from the bottom of the heart. And thank you so much, scientific committee, Dr. Ashwat. We did not even have to tell you, along with Akila Yavu, you did a tremendous work, and for the first time, district branches felt represented. And this was the one thing I always felt as a state secretary, I should do that, and as a president, because working from the branches at the lower, I know how they feel when they come to the state. So I'm really happy and thankful for the entire team, and of course Rajendran Anna. He actually, I should call him only Dr. Rajendran here, but I feel very important that he treated, I am a little short-tempered only, but then he guides me, he puts me at the balance at whenever it is, and for the past 1.5 months, a lot of, not only this whole year, this 2 months has been really hectic for all of us, but he gave the space, he gave the thing, and he guided. And I have been the organizer for more than 3 conferences, but what I really learned in this conference was a team effort to be with you all, the youngsters, and how to be with them. Thank you so much for giving me the opportunity, and thanks Team Coimbatore for the same. Thank you so much.
Thank you, Dr. Narmada. We always see you as being part of Coimbatore, so we never see you as an outsider. Thank you so much. Now I would like to invite our President, Dr. Rajendran, to give us felicitations and give away awards to the organizing committee.
Most respected our mentor, teacher, Dr. M. Ramasamy sir is today's chief guest, and all respectable IAP-TNSC office bearers, and KONGU PEDICON Chief Organizing Chairperson Dr. Ismail, Chief Organizing Secretary Dr. Sasikumar, Chief Organizing Treasurer Dr. Mullai Balaji, Organizing Chairperson Dr. Jalil Ahmed, Dr. Nandini Kumaran, Dr. Neminathan, Organizing Secretary Dr. Jayavardhan, Lakshmi Shanti, and Dr. Srinivasan, and organizing treasurers, and all the committees. I can say that all organizing, co-organizing chairpersons, co-organizing secretaries, and the scientific committee, especially our advisor Dr. Agila, and chairperson Dr. Aswad, secretary Dr. Sendil Kumar, finance committee headed by Dr. Nandini Kumaran, and workshop committee Dr. Jaysri Aswat, as well as Dr. Ramesh and Arun Kumar, stall committee, and another thing is audio visual, and food committees, especially Dr. Tyagarajan and Dr. Sathivel. I am really thankful to Madambatti Rangarajan, who has helped us, one of the excellent, he has served a good food for us. I think definitely everybody appreciated. And another one is Transport and Accommodation Committee headed by Dr. Jalil Ahmed and Krishnasamy. And I really appreciate Dr. Mullai Balaji. I think past 2 weeks he could not sleep and he was coordinating all the accommodation and travel, everything. And Entertainment Committee, and especially Dr. Suruthi and P.S. Chandrasekhar, Sendil Kumar, Mallige Selvaraj. And I think I really appreciate Suruthi as she has done extreme good work, all the aspects. And Venue Committee and Dr. Balakrishnan, and I really appreciate all the hall management. So everybody's feedback is really they are giving a good opinion, and as well as keeping time also, and conducted very well. Okay, all the team members I am appreciating. Please stand up. Okay. So they have done really good work, and we will give an appreciation award. Okay. And Souvenir Committee, coming to the Souvenir Committee, and appreciate Kala, Raghu, and Dr. Abhiramalada. So the entire, they almost took within 2 weeks, they finished that Souvenir. And the reception committee members, and poster and presentation, especially Dr. Rajesh. He has done extreme good work. And in this occasion, I really appreciate Dr. Narmada. So he has done almost past 1.5 months. He has coordinated paper as well as poster presentation, and it's one of the good show. And Mementos and Gift Committee also I appreciate. And it is my privilege to be here, and I really appreciate especially Dr. Sasikumar. He's a person behind this success, and he really, and all the days almost he's slept almost 3 hours, 3.5 hours past almost 10 days. He's the first person coming to the venue and last person leaving, and even 6 o'clock he's going and inspecting all toilets. This is a great initiative and a great effort of Dr. Sasikumar. And another thing is I really appreciate Dr. Jayavardhana, because he has done all the scientific things, innovative ideas. He has initiated all the new things, and really appreciate. And I already told you Dr. Sasikumar. So another one is Dr. Thirumurugan is helping all the aspects, past experience. I really appreciate Dr. Thirumurugan. And more than that, so many persons they involved to conduct this conference very well. Even though I am from Coimbatore, I want to appreciate on behalf of IAP-TNSC, appreciate all the organizing committee. 3 cheers to IAP, that Coimbatore IAP, who has done extremely good work. And really I honored that I am from Coimbatore, and hope that this young team, and they are having a lot of novel idea going for National Pedicon. I think we have to support, and this entire Tamil Nadu, we have to take this National Pedicon as our pride, and definitely we will do it. Thank you very much.
So I request President Dr. Rajendran sir to give away mementos. The important, like we have arranged for mementos for all members of the organizing committee, because most of them have left today. We would like to give out to those people who are present here. So first I will request Dr. Rajendran sir to present a memento Dr. M.R. sir, Ramsamy sir. So the chief. Thank you, Ramsamy sir, for always guiding us as a silent. Next, I would like to invite Dr. Ismail sir, the chief organizing chairperson of KONGU PEDICON. He gave us all the space to work, and he was always guiding from behind. Thank you, sir. Now, I would like to invite Dr. Nandini ma'am, co-organizing chairperson, Dr. Jalil sir, Dr. Neminathan sir is not here. Thank you, Nandini ma'am and Jalil sir, for always being there in all the preparatory meetings and planning meetings and guiding us. So next we'll have the Next, we'll have the man behind the show, the Chief Organizing Secretary, Dr. Sashi Kumar, for all his hard work and coordination. Next, I would like to invite the tech man of the conference, Dr. Jayavardhana. Dr. Srinivasan, sir. Please come on to the stage, sir. So he was taking care of all the entertainment, food and memento committees. Thank you, sir. Secretary, Treasurer.
Dr. Lakshmi Shanti, ma'am.
Dr. Mullai Balaji. Dr. Fauzia. Dr. Muruganandam.
Next I would like to invite Dr. Krishnasamy sir, co-organizing chairperson. Dr. Vishwanathan sir. I would like to invite Dr. Duraikanan sir. So I would, Scientific Committee Chair, Dr. Ashwath. Dr. Ahila Ayavu, I think she's not here. So because many people are not here, I would just to call upon... Sir. Sir. Dr. Menaka, is she here? Okay. Dr. Nitya? Dr. Kumar, sir? Dr. M. Sendil Kumar? Okay. Dr. Sendil Kumar from Selvapuram. Now I would like to invite two important doctors from Pollachi, Dr. Shaktivel sir and Dr. Soundarajan sir, who are very instrumental and very helpful in coordinating all. They were present in all the planning meetings. I would like to invite Dr. Maheshwaran sir from Mettupalayam. He came all the way for every meeting and he made his role was very important. Amma, we can just Dr. Karthikeyan, Masanik. Oh, come fast. Now I would move on to the hall coordinators. Dr. Amuda, Dr. Brinda, all of you come. Karthikeyan is coming, sir. Dr. Uma Maheshwari.
Dr. Balakrishnan, Dr. P. Tyagarajan, Dr. Soumya ma'am, Dr. A.R. Srinivas, Dr. Malligai Selvaraj, Dr. Revati Ravishankar ma'am, Dr. N.T. Rajesh, Dr. Suganti, Dr. C. Karthikeyan, Dr. G.S. Maheshwari, Dr. Usha, Dr. Rumesh, Dr. Karthik Annamalai, Dr. Jayaprakash, Dr. Nalini,
Dr. Jayaprakash is here.
Dr. Bhargavi, Dr. Brinda,
Dr. Shruti Ravikumar.
The main person who was, so she has a big fan club here. So 3 cheers to Shruti. Dr. Madhubala is here. Oh, sorry. Dr. Kiritika also. Dr. Vikram.
Dr. Kritika. Dr. Mohan Raj.
Dr. Sendil Kumar. The innor Yaru. Masanic Dr. Sendil Kumar, please come. Dr. Prabhu Vikash, our young energetic treasurer of Coimbatore IAP. Nalli is not here. Dr. Selvailam Kumaran from Tarapuram, please come forward.
Dr. G.S. Maheshwari, ma'am. Dr. Anthony Terence.
Dr. Maheshwari from Masanic. Dr. Ansar Ali is here. Dr. Kala Raghu. Dr. Jayashri Ashwath, please come forward. She did a wonderful job in coordinating and organizing the workshops, 13 workshops. For the first time, we had 13 workshops for a state conference and she did it in a wonderful manner. Thank you, Jayashri. Lavanya is not here. Dr. Nalini, Dr. Uma Malini, Dr. Shanmuga Priya. I think they've left. Oh, Dr. Shanmuga Priya is here, please. Yeah, she's come. So, thank you all. On behalf of the organizing committee, we thank each and everyone who contributed to the success of this conference. Like, we have shields for all of them. Maybe some of them are not here. We'll just make sure that we pass it on to them. Now, coming on to the next thing, like, we want to honor and recognize the services of people who played a major part in the success of this conference. For that, I would like to invite our catering partner, Mr. Madambatti Rangaraj. Because Ismail sir was very clear from the beginning that even if the academic is a bit thing, the food should be, there should be no compromise on the food. So we made sure that happened, and I hope all of you enjoyed the culinary delight. And Mr. Rangaraj made sure that he was present on all the 3 days and made sure there was no any glitch in the catering department. Thank you. Thank you so much. Now I would like to invite Mr. Ranganathan, our event partner. So the main success of a conference is in the scientific committee, the event and the catering. So all three worked in tandem, and we made sure that it was a KONGU PEDICON 2025 was a success. So I'd like to invite Mr. Ranganathan onto the stage. Now I would like to invite Mr. Sai Kishan, who helped in the registration department and doing all the IT work, which was very important. It was very seamless, and many delegates found it very easy to register. Thank you, sir, for your contribution. Mr. Sai Kishan. Next, I would like to invite Mr. Vivin and Mr. John Wesley from the IT team. So they gave very innovative ideas and made this conference first in many of the departments. Mr. John and Mr. Vivin, please come forward. Thank you. All the members from the organizing team were continuously calling them for the past 1 month, so they did a wonderful job. Thank you, sir. Now I would like to invite our secretary, Ms. Abhirami. Ms. Abhirami? Okay. I would like to invite Dr. Tirumurugan to the dais, please. I think you left in the middle, so we missed you. Please join on in the dais. Thank you, sir. Now I would like to invite our Chief Organizing Chairperson, Dr. Ismail, sir, to give his felicitations.
எது நடந்ததோ அது நன்றாக நடந்தது, எது நடக்கின்றதோ அது நன்றாகவே நடக்கின்றது. அடுத்த வருடம் எது நடக்க வேண்டுமோ அது இதைவிட சிறப்பாக நன்றாக நடக்கும் என்று கீதையின் வரிகளோடு உங்களிடையே. இந்த நிகழ்வு என்பது ஒரு சிறப்பான டீம் ஒர்க். அந்த டீம் ஒர்க்கில் ஒருங்கிணைப்பாளராக இருந்து IAP-TNSC பிரசிடென்ட் திரு ராஜேந்திரன் முன்னிலை வகிக்க எனக்கு அந்த டீமை தலைமை தாங்கக்கூடிய பொறுப்புகளை அளித்தார்கள். அந்த வகையிலே அந்த டீமின் இணைந்த கைகளாக நான் பெயர்களை குறிப்பிட விரும்பவில்லை, காலம் நேரம் கருதி. தம்பி சசிகுமாரும் ஜெயவர்தனாவும் லீட் பாயிண்டில் இருக்க ஒரு அழகான இணைந்த கைகளோடு, நட்புகளோடு, பந்தத்தோடு, பாசத்தோடு இந்த இணைத்த கைகள் எல்லாம் சேர்ந்து இன்றைக்கு உங்கள் முன் நடந்த இந்த 3 நாள் நிகழ்வு உங்களுக்கு மகிழ்வையும் அது சிறப்பானதாக நடந்ததற்காக எங்கள் உள்ளங்களில் நெகிழ்வையும் தந்திருக்கின்றது. இந்த மாபெரும் வெற்றிக்கு காரணம், முதல் காரணமாக நான் கூறுவது டெலிகேட் ரெஜிஸ்ட்ரேஷன். 1500 பேர்கள் நீங்கள் பதிவில் என்று சொன்னால் இந்த மாநாடு சிறப்பாக இருந்திருக்கிறது. ஸோ பல்வேறு கமிட்டிகளில் இருந்தாலும் கூட அடுத்த நிகழ்வாக நான் சொல்ல விரும்புவது என்னவென்று சொன்னால், as an organizing chairman, sponsors of this conference, especially my dear pharma friends, அவர்களின் ஒத்துழைப்பு இல்லை என்று சொன்னால் இது இந்த அளவுக்கு வர முடியாது. என்னதான் அவர்கள் நமக்காக உழைத்திருந்தாலும் கூட, பொருளுதவி செய்திருந்தாலும் கூட, நிறைய நட்புகள் ஃபார்மாலிருந்து செல்வத்தாலும் சரி, அதே சமயத்தில் உடல் உழைப்பாலும் சரி, தங்கள் நேரங்களையும் செலவிட்டு இரவு பகல் என்று பாராமல் நமக்காக உழைத்திருக்கிறார்கள். அவர்களுக்காக ஒரு பலத்த கைத்தண்டலை நாம் தர வேண்டும். இந்த அரங்க அமைத்தவர்கள் நண்பர் ரங்கநாதன் அவர்களின் டீம். சசிசா சொல்லிட்டு இருப்பான், 2 மணிக்கு வந்து ஒரு நெய்யல் ஹால் வளைவு போடணும்னு சொன்னால் அந்த நேரத்தில் நடந்தது. மழை வந்தால் என்ன செய்வது என்று தோண்டும் போது அடுத்த நிமிடம் பிளான் பி ரெடி பண்ணி கொடுத்தாரு. அதே மாதிரி தம்பி மாதம்பட்டி ரங்கராஜ் அவர்களை பாராட்டியே ஆக வேண்டும். வந்திருந்தக்கூடிய அனைத்து விருந்தினர்களும் சிறப்பாக செய்திருந்தார்கள். எங்கள் டீம் அனைத்தும் நல்ல விதமாக உழைத்திருக்கிறது. இந்த உழைப்புக்கு முதல்ல நான் இன்னொரு எல்லாத்தை விட நன்றி சொல்லணும்னு சொன்னால் இறைவனுக்கு நன்றி செலுத்த வேண்டும். என்று சொன்னால் வருட பகவானை நிறுத்தி இந்த விழாவினை சிறப்பித்தமைக்கு இறைவனுக்கும் நன்றி தெரிவித்துக் கொள்கிறேன். ஸோ இந்த விழாவிலே எங்களுக்காக வழிகாட்டிய மூத்தோர்கள், சீனியர் பீடியாட்ரிஷியன்ஸ் ஆஃப் கோயம்புத்தூர் ஐஏபி, அதே போல் தமிழகத்தில் இருக்கக்கூடிய நல்ல பல உள்ளங்கள், சீனியர் பீடியாட்ரிஷியன்ஸ் ஆஃப் தி தமிழ்நாடு ஸ்டேட் ஐஏபி, அதே போல் நிறைய நண்பர்கள் பல ஊர்களிலிருந்து நிறைய வகையில் எங்களுக்கு உதவி புரிஞ்சிருக்காங்க. அத்தனை நல்ல உணங்களையும் வணங்கி மகிழ்கிறேன். இந்த விழா சிறப்பாக நடைபெற்றவைக்காக உங்கள் அனைவருக்கும் நன்றியினையும் வாழ்த்துக்களையும் கூறி, அடுத்த முறை இதை விட சிறப்பாக செய்வோம் என்று உறுதி கூறி விடைபெறுகிறேன். நன்றி, வணக்கம்.
Now I would like to invite our Chief Organizing Secretary, Dr. Sashikumar, to give his felicitations. Sir, one minute. ஒரே நிமிஷம். Ismail sir, please present the shield to Dr. Rajendran sir, the Chief Convener of KONGU PEDICON 2025. Thank you, sir, for being with us in all the planning and execution. Thank you, sir.
Respected President, office bearers, executive board members, senior faculties, esteemed delegates, and my organizing chairperson, Ismail sir. Good afternoon, each one of you. It's both an honor and privilege to stand before you today as an organizing secretary of this year's State Pediatric Conference. First and foremost, I wish to my thanks to Almighty for allowing or blessing us to conduct this conference without any issues. And I wish to extend my heartfelt gratitude to our state IAP leadership and executive board for entrusting our team with the responsibility of hosting this conference. Organizing such a conference is not merely an administrative task. It's an opportunity to create the platform where knowledge is exchanged, innovations are shared, and friendships within our pediatric fraternity are strengthened. This year, our team worked with a vision to make the conference scientifically rich, practically relevant, and warmly hospitable. We have curated scientific sessions that address current challenges in pediatric practice with inputs from eminent speakers across the country. We have also incorporated workshops, hands-on training, and case discussion to ensure our delegates take back practical skill along with academic updates. Behind the scenes, the conference has been the result of months of tireless effort, meticulous planning, coordination with faculties, mobilization of resources, and attention to every small detail. I take this opportunity to sincerely thank all our committee members, all the advisors, chairperson, secretary, and all the members, and our friends, workshop coordinators, sponsors, volunteers, and every member of the organizing team for their dedication and teamwork. I also wish to acknowledge the unwavering support of our state IAP and executive board in guiding it through each step. Your suggestions, encouragements, and constructive feedback have been invaluable. In closing, I hope the conference will not only enrich our knowledge but also strengthen the bond we share as pediatricians committed to the well-being of children. I look forward to your continued guidance and support both today and in future. And before closing my speech, I thank three persons. One is Madambatti Rangarajan. Almost 1,500 வந்த delegates அத்தனை பேரும் அவர் கூட செல்ஃபி எடுத்துக்கிட்டாங்க. இந்த செலிபிரிட்டி who has been through all 3 days. நாங்கள் அவர் கூப்பிடும் போதே நீங்கள் கூடவே இருந்து தான் பார்த்துக்கணும் அப்படின்னா he has committed and he has done that. And then Ranganathan, ஆக்சுவலாக அன்றைக்கி நொய்யலாலுக்கு போகிறதுக்கு ஒரு விசிபிலிட்டி இல்லாத மாதிரி இருந்தது. ராஜேந்திரன் சார் ஒரு 12:30 என்னை கூப்பிட்டு, தம்பி அந்த பக்கம் மட்டும் ஒரு சரியில்லையா அப்படின்னு. I called him at 1 o'clock and came here to the venue at night 1 o'clock. 2 o'clock அதை பிரிண்ட் பண்ணி உடனே போட்டு கொடுத்துட்டாரு. ஸோ அந்த மாதிரி ஒவ்வொரு இதுக்கும் வாஸ் வெரி சப்போர்ட்டிவ். அண்ட் தென் அவர் ஆக்சுவலி டெக்னிக்கல் டீம் ரைட் ஃப்ரம் விவின், ஜான் வென்ஸ்லி அண்ட் யுவஸ்ரீ, மனோடெக். தென் லாஸ்ட் 1 வீக்கில் ரெஜிஸ்ட்ரேஷனுக்காக ஆனால் எவ்ரி கான்ஃபரன்ஸ் ரெஜிஸ்ட்ரேஷன்லேயும் ஃபுட்டில் தான் ப்ராப்ளம் இருந்தது. எங்களுக்கு எந்த பிரச்சனையும் இருந்ததில்லை ரெஜிஸ்ட்ரேஷன்லேயும் ஃபுட்லேயும். அதுவே எங்களுக்கு ஒரு பெரிய ஒரு சக்ஸஸாக இருந்தது. அண்ட் வேறு அண்ட் தென் ஃபார்மா பீப்புள் வந்து சிலர் கூட கோவப்பட்டிருக்கிறேன், சிலர் சண்டை போட்டிருக்கிறேன், சிலரை வந்து நான் உங்கள் மருந்தே எழுத வேண்டாம்னு கோயம்புத்தூர் ஃபுல்லாக சொல்லிடுவேன் அப்படின்னு கூட சண்டை போட்டிருக்கிறேன். இன்ஸ்பைட் ஆஃப் ஆல் தோஸ் திங்ஸ் தே கம் ஃபார்வேர்ட், எஸ்பெஷலி அவர் primary sponsors. ஒருத்தர் சொல்லணும்னா ஒன்லி திங் why I want to mention them அப்படின்னா, திருநெல்வேலியில் நாங்கள் சொல்லும்போதே we need 25 lakhs from your company, எங்களுக்கு பண்ணி கொடுக்கணும் அப்படின்னதுன்னா அன்றைக்கே உடனே ஓகே தான் சொல்லி ஃபஸ்ட்டே ஒரு நமக்கு ஒரு நம்பிக்கையை கொடுத்த அபெக்ஸ் ஃபார்மாக்கு பிக் தேங்க்யூ. அண்ட் ஃபார் ஆல் அதர் ஃபார்மாஸ் நிறைய பேர் இருக்கிறீங்க, மென்ஷன் பண்ண முடியாது, ஃபார் யுவர் சப்போர்ட் எவ்ரி திங் அண்ட் ஆல் த ஒர்க்கர்ஸ். அண்ட் ஆக்சுவலி அண்டு ஒவ்வொரு நேஷ்னல் ஃபேக்கல்ட்டி ஆகட்டும், ஸ்டேட் ஃபேக்கல்ட்டி ஆகட்டும், சார் எங்களுக்கு வண்டி வரல, ஹோட்டலில் இறக்கி விடல அப்படின்லாம் இல்லாமல் டிரான்ஸ்போர்ட்டை வந்து ஏசல் ஃப்ரீயாக நடத்தின ஐடியல் ஃபார்மாக்கு ஒரு பிக் தேங்க்யூ. அண்ட் தென் ஃபஸ்ட் டே வந்தப்போ சொன்னாங்க ஒரே ஒரு நெகட்டிவ் ஃபீட்பேக் இந்த கான்ஃபரன்ஸில் எங்களுக்கு கிடைச்சது வந்து ரெஸ்ட் ரூம்ஸ் ஆர் நாட் க்ளீன் அப்படின்னு. உடனே ஆள் போட்டு அந்த ஒரு 15-20 ஹவுஸ் கீப்பிங் வந்து அங்கேயே இருந்து க்ளீன் பண்ண அந்த ஆல் த ஹவுஸ் கீப்பிங் ஒர்க்கர்ஸ் எல்லாருக்குமே, இன்னும் யாரையாவது நான் விட்டுருந்தா மன்னிச்சுக்கோங்க, எல்லாருக்குமே ஒரு பிக் 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 தேங்க்ஸ். அண்ட் திஸ் கான்ஃபரன்ஸ் இஸ் டீம் ஒர்க். ஜஸ்ட் நான் இவங்க பண்ண கூட இருந்த ஃப்ரெண்ட்ஸ், மை GH colleagues, and also I thank my wife, my kids and my mother because நிறைய நாள் என் பொண்ணு இந்த 15 நாளில் நைட் நான் போகும்போதே அவங்க எல்லோரும் தூங்கியிருப்பாங்க, காலையில் நான் எந்திரிச்சு போகும்போது தூங்கிட்டு இருப்பாங்க, அந்த மாதிரி தான் இருந்தது. ஸோ இது ஒரு பெரிய எக்ஸ்பீரியன்ஸ் எனக்கு. இந்த வாய்ப்பு கொடுத்ததுக்கு ராஜேந்திரன் சார், இஸ்மாயில் சார் who have strongly recommended me for this post, உங்கள் எல்லாருக்கும் ஒரு பெரிய நன்றி. என் மேலே வச்சுருந்த நம்பிக்கையை வித் என்னுடைய டீம் ஒர்க்கர்ஸ் அண்ட் கூடவே இருந்து எது சொன்னாலும் ஆனால் சரின்னு சொல்லி பண்ணி கொடுத்த என்னுடைய கொலீக்ஸு, அப்புறம் ஜெயவர்தனாவை அவங்க கூட சண்டை போட்டிருக்கிறேன், எல்லாம் பண்ணியிருக்கிறேன். பட் ஸ்டில் எல்லாருக்கும் ஒரு பிக் தேங்க்யூ தேங்க்யூ தேங்க்யூ.
At this juncture, I would like to make a special mention about our volunteers from PSG IMSR. They were with us all time. They came at 7 o'clock in the morning before all the sessions even started. So I would request Dr. Rajendran sir to honor them. Dr. Madhumita, Shri Shweta, Venisha, Vidya, Sundar, Tamil, Badri, Shweta AR, and the group of 19 was amazingly coordinated by Abhirami Balaprabhan. She had to endure a lot of late night calls from all of us. They were the ones who are behind the seamless functioning of all three halls. Thank you so much.
Now I would like to announce the winners of the quiz that happened yesterday evening. The first prize goes to Dr. A. Tangavel, Assistant Professor, KAP Government Medical College. You always amaze us with your multiple talents, dance, academics. The second prize, Dr. Shweta K.J. Raman. Is she here? The third prize, Dr. V. Anand. Dr. Shweta, please. She's a PG from ICH Chennai. Third prize, Dr. Anand, Dr. Tangavel will collect on behalf. So we conducted online weekly quiz, the KPL champions. So I would like, there were 5 in the leaderboard, 5 pediatricians. Dr. A. Tangavel again. Dr. E. Amuda. Dr. Nancy Jaba Angelin. Dr. P. Karthigeyan. And Dr. S. Karthigeyan. So these are the 5 KPL champions. Please. Karthi, come fast. You only. Hey, you are also here. P. Karthi. Appadiya. Okay. He's not here. Okay, so I would like to hand over to Dr. Narmada for the poster presentation awards.
This is a very important event where all the postgraduates are waiting for. I really want to appreciate the award coordinators. First, I really need to appreciate Dr. Dakshayani and Dr. Sridevi. Please give them a big hand. They have really worked close with me. And both of them have stood 2 days. They have not attended any scientific committee talks. They have been with us. And Dr. Sridevi and Dakshayani are so meticulous that the timing, everything was mentioned. Thanks to you for working with me for the past 1 month since the last date. And of course, the coordinators, Dr. Sudhakar and Dr. Rajkumar. Dr. Rajkumar took care of the entire poster presentations and Dr. Sudhakar was there with him coordinating. Thank you all. I really thank from the bottom of my heart. At this juncture, I also want to appreciate Dr. Tirumurugan for putting in guidelines so beautifully. It has evolved over the past 2 years. Dr. Tirumurugan, thank you so much. Hello, I'm thanking you. Dr. Tirumurugan, thank you for making the guidelines for this one. For putting in the taste. Okay. So now I will, because of the GBM, the few certificates of the judges for the posters, I really thank all of them for staying behind for doing it. Dr. Aravind from Tanjavur. Dr. Selvakumar sir, again from Tanjavur. They were the judges for yesterday poster presentation. Dr. Ajay Prakash, Dr. V.T. Rajesh sir, Dr. Sri Priya, please do come on the stage. Sri Priya, for being the judge. Dr. Arvind, Dr. Arvind, Dr. Sasi Anand, I think you're not here, and Dr. Prasanna, Dr. N.T. Rajesh. Okay. Thank you so much. Sri, come. Now, for the bigger awards, Raji, can you bring VBR? Thank you, Daksh. Thanks for that. Now, because of the GBM, we were not able to give them the certificate yesterday. Thank you so much for being the judges. All these awards had undergone 2 rounds. Most of the awards were sent, almost all the awards were sent out of the state. First, we blinded the theory part, then we sent it, got back, and 3 awards, unfortunately, for the second or third place, it was a tie. It again went to a second round of judges, again from out of the state. We got it, and then they had the oral presentation. And that, now, the first winner of the V. Balagopal Raju Award, it's Dr. Raghav from Institute of Child Health and Hospital for Children. He did on utility of loop-assisted isothermal amplification for diagnosis of Salmonella enterica. Very, very innovative topic. Doctor, you can get your medal as well as your certificate. Congratulations to you and to the co-authors for such a brilliant work. The first runner-up is... can you guess who had attended the VBR award? Dr. Aishwarya Padmanabhan from Mehta Children's Hospital. The timing of clinical presentation in DSD, a case control series they have done, a very wonderful study. First runner-up to you. Please do come to the dais. And congratulations to your co-authors and your seniors who have guided you. The second runner-up is from Government Mohan Kumaramangalam Medical College, Salem, Dr. Balaji. A very futuristic lung ultrasound utilization and diagnosis of neonatal respiratory distress syndrome. As we said, all the papers were very innovative. The judges really had a very tough time in order to decide on the who got the winners. They just missed it by 0.5 or 1 mark. Congratulations to all the award winners. Now we go to BRS Santanakrishnan Teaching Institutions Award. The winner is Dr. Jeevita, Kaveri Hospital, Ma Kaveri Hospital, Trichy. Congratulations to you, and Dr. Suresh sir, you can accompany. They compared the GCS and 4 scores in children with altered sensorium. A very wonderful topic done by them. She gets the medal and the certificates. Congratulations to your co-authors too, Dr. Meghanathan, Dr. Suresh Chalia, who are already here. Please do come. Dr. Jeevita from Ma Kaveri Hospital. The first runner-up, can you really guess, is none other than Dr. Kanmani from Child Trust Hospital, Chennai. A study on children with autoimmune cytopenias and their association with IEI. Please do come and receive your certificates. And congratulations to your co-authors too. The second runner-up is Dr. Ramalakshmi from Institute of Child Health and Research Center, Madurai, Association of Subclinical Thyroid Hormone Variation in Children with Autistic Problems. Congratulations to you and to your co-authors. Congrats. Now, we have the BRS Non-Teaching Award. Singla Vandana Sama Supra Pananga, Dr. Nitya Priya from Dharmapuri, TR Children and Dental Specialty Hospital. She has done on predictors of severe scrub typhus and usage of IV doxycycline. Of course, she is not there. I request Dr. Balaji sir to... She's there. He's there. Please. Congratulations, ma'am. Sorry, I didn't see you. Ma'am, get the certificate. And your medal also, sir. Congratulations, ma'am. Yeah, Dr. KK Award for Social Pediatrics. The winner again from Dharmapuri, Dr. Sadhana. She gets it for improving exclusive breastfeeding rates and its implications in newborns discharged from SNCU. Dr. Sadhana, congratulations to you. And the first runner-up is Dr. Danish Raja. Congratulations, Government Mohan Kumaramangalam Medical College, Salem. This was a very, very interesting topic on a grief experienced by bereaved parents after the neonatal deaths occurring in an urban public health hospital. I was very interested, read through the entire thing. Congratulations to you for taking up such a less research topic. And the second runner-up is again Dr. Nitya Priya, again from Government Dharmapuri Medical College. Congratulations, ma'am, for winning. A study on behavioral and developmental problem associated with increased screen time in preschool children. So I think one was done in a private clinic, the other was from Government Medical College. Congratulations, ma'am. Now the T. Rajagopal Award today, it was very, very interesting, and it was usually TR Awards, they may present some case series also, but this was very interesting. And for the first prize goes to anxiety in school students and its association with screen time in Tiruchirappalli district, which was a cross-sectional analysis done by Dr. Kanagadara from SRM Medical College, Trichy. Amazing work. They have done and screened all the school children. Imagine there were about 56% of anxiety among school children. Very well presented. The second prize goes to Dr. Rasika from Institute of Child Health and Hospital for Children again. This was on short-term outcome and prognostic factors in pediatric NMDAR, autoimmune encephalitis, which was a retrospective cohort study. Dr. Rasika, Institute of Child Health and Hospital for Children. And the next is from KKCTH, Chennai, extrapulmonary manifestations and complications of mycoplasmic pneumonia in hospitalization. What a wonderful collection of case series and photographs. Amazing. Congratulations to you three. It was well fought. All the other papers were also very much deserved one, but really these three stood apart. Congrats to you, doctor. Very well presented. That's what we were saying. Slides were also, it was like a very professional presentations, and they kept on time. That was the best part of it. Congratulations to you. Okay, now we go ahead with the posters presentation. We got whooping 240 posters. And among them, they had gone through the first round of 15 terminals were kept. We had 15 judges who decided independently. 15 of them were selected for the final round. And guess what? We had 3 very difficult examiners, Dr. Balaji, Dr. Ramesh, and Dr. Murugesa Lakshmanan, who grilled them almost for 2 hours to decide on this first 5 posters. So this is a really, really well-deserved award. Please give them a big hand. Dr. Mahalakshmi Surya Narayanan from KKCTH on tiny glands, big impacts, primary adrenal insufficiency. I know KKCTH has almost bagged most of the awards. Please do come and receive it. Dr. Maheshwari again is the first runner-up. Etiology and predictive factors in pediatric cervical lymphadenopathy, again from Child Trust Hospital, Chennai. Come, no problem, you can collect it. Dr. Monica from Child Trust Hospital again gets the second runner-up, clinical spectrum and characteristics of ADAM in children. If she's not there, your friends can please collect it. The third runner-up goes to M. Sindhu from Ma Kaveri, clinical outcomes of childhood leukemia in tertiary care centers. As we said, an amazing collection of cases from institutes. Dr. Shruti Vinod from Srihar, Chennai. Life-threatening manifestations in varicella due to HLH. She's not there? No problem, you can come and get it. This time we selected, we opened up the posters and award paper presentations for postgraduates outside the country also, outside the state, so that they'll get a better chance to present. But we had one poster which stood out, Dr. Surya Prakash from AIMS Patna. Okay, we'll be sending. The rest of the people who have participated in the posters, you will get an e-certificate. For those in the awards also, we will send you a participation certificate through mail in a month's time. Thank you so much, and thanks the dignitaries for taking your time and giving away the awards. Thank you. And over to you, Shanti.
Thank you, Narmada. A special mention to our photographers for the event, Mr. Satish Khanna and team. I would like to invite him on the stage. Thank you, please. So he was there for all the 3 days, continuously doing his work. Thank you. So I would like to invite our chief guest, Dr. M. Ramasamy sir, to give his address.
Thank you for this opportunity to be a valedictorian. The word valedictorian, the distinguished colleagues on the dais, distinguished colleagues at the floor, and I can't believe myself. Believe me when I say that, because 1968, I was the second pediatrician in the city of Coimbatore. After 4 years of training, I felt very good those days. I felt I was quite competent. I was able to look after the 6 children. Almost all of them survived. By then now, almost 60 years down the line, I feel like fish out of water. I feel I'm probably a square peg in a round hole, because so much progress has taken place in the past 60 years. There's a saying in English, don't aspire for tomorrow's work with yesterday's training. I think that very well fits, to my position. Now, I have gathered from Dr. Ashwath more than 200 papers and more than 1,000 delegates. 2 presentations or 2 deliberations stand in my mind out of all these 200. The one delivered by Professor Indumadi with precision and compassion, and I think excellent choice for the Jayanada oration. The reason why I say that, her work reflected very beautifully the power of pediatric medicine and also the power of a devoted pediatrician. Just the strength of pediatric medicine lies in that. The strength of professional life lies in that. And one single devoted pediatrician could change the lives of thousands and thousands of children in the state. Means a lot. So that one stands out. And the second one I most enjoyed the last session under Dr. Sunil. I think that's a very, very interesting one. The art and science of pediatrics. And I'm glad I am in the right company, because my short presentation yesterday was on artificial intelligence. I think that's a very, very, very interesting one. As a matter of fact, now of course I don't want to take anything more than a couple of minutes. If you look at the law of nature, always the old yields to the new one, and no one has said this more eloquently, more profoundly than William Shakespeare, which you all know. The world is large, the world is a stage, but all the men and women are merely players. They have their entrance and they exist. That way, the old order has given birth to a new order. And the amazing, the level of brightness, the level of intelligence, the level of commitment I see among these young pediatricians. I'm glad I have lived up to a little beyond 80 to see this. I'm very happy about that, because I was just wondering when I was asked to become give the valedictory address. I said, God must have had some purpose in keeping me beyond 80, perhaps for this purpose. So thank you very much. And I must apologize for a little delay in coming onto the stage. All my 50 years of life, 60 years of professional life, is the pediatric that dictated me, but off late is the prostate that dictates my life. So sorry for the delay. And so thank you very much for this opportunity. And I must also tell you, in the words of Freemasonry literature, whenever we gather, whenever we disperse, we are going to meet again. There is a very beautiful expression in Masonic literature: happy have we met, happy, maybe meet, happy have we met, happy, we meet again. So with those short, expressions from Masonic literature, thank you very much for this opportunity. For all the colleagues on the, dais as well as, the floor, and individually I did not mention the names, you must pardon me, because you're all known to, one another. So thank you very much for this opportunity.
Thank you for your inspiring words, sir. I would like to call upon our hall in charges, Dr. Sendil Kumar, Dr. Menaka, Dr. Nalini, Dr. Jeba Nancy, and Dr. Bharati. They were the ones behind the MC desk in all the 3 halls.
Now I would like to invite Dr. Rajkumar to give the vote of thanks.
Respected dignitaries on the dais, after dais, it's from the bottom of my heart, I thank all of you for making this function a grand success. This is not the end, this is the beginning. Let us all meet in 2027 January when KONGU PEDICON 2.0 loads. KONGU PEDICON 2.0 loads. KONGU PEDICON 2.0 will load on January 2027. Thank you very much. Thank you.
Please stand for the national anthem.